Can you hear me? Hello guys, good morning. Can you hear me? Give me the confirmation. Good morning, yeah. Good morning, Subhatra, Mahima, Maria, Abra, yeah, Pawan. Good morning. Good morning. So, in today's class, our main target is to complete the cardiovascular system. One cardiovascular system, which is very big. We have to, also we have to do that gastrointestinal, a bit of gastrointestinal, and the remaining time we have to do with the cardiovascular system. After GI, we'll be doing the cardiovascular system. That's our main focus today. So, cardiovascular system, see, it's also important. It's also important in the sense you'll be getting at least 2 questions. Okay, 2 questions. Sometimes even 3 questions was asked in the exams. Sometimes 3 questions is the top end. Every time I believe that endocrine is of highest yield. Okay, endocrine. That's why yesterday I started with endocrine. Like many questions will be coming from the endocrine. So cardiovascular is also equally important. Sometimes we can expect 3 questions. Sometimes 2 questions. We'll do that. Okay, but first itself I will be telling you in cardiovascular system in the beginning for the beginning 1 hour. In the cardiovascular system in the beginning 1 hour, it will be little dry topic. Okay, like action potentials, all this stuff. After that, we'll be discussing about the concepts. Okay, so first itself I'm giving you the clarity, and you need to be highly attentive. Okay, that's the one thing which I want. You need to be highly attentive, and whatever, okay, you should be like, I will be listening to each and every point, whatever it takes, I will be listening to each and every point. That's the determination you should be having. Okay, so having said that, without any further late, let me share my screen. No, first GIT will be doing. After that, CVS will be completed by 3 o'clock or 4 o'clock. After that, we'll be starting with the renal. Okay, we'll be starting with the renal. So we'll do the half of the renal today. Not half of the renal. Renal is a very, very big topic. At least we should have to do the 30% of the renal after cardiovascular system. Okay. So having said that, so let's do the GIT, the remaining part of the GIT. See here. So intestinal secretions, right? Intestinal secretions. In the intestine, mucus is going to be secreted. Okay, in the intestine, who secretes the mucus? It's the goblet cells. So goblet cells are only present in the intestines. Okay. Of course, in the duodenum, there are special mucus secreting cells. Okay, there are special mucus secreting cells in the duodenum. They are called as the Brunner glands. Okay, so generally speaking, who produces the mucus in the intestines? It's the goblet cells. Okay, and the epithelial cells of the intestines, are called as enterocytes. For example, if this is the intestine, a part of the intestine, so the lining cells, these cells are called as the enterocytes. Now these enterocytes, they absorb the materials like glucose, amino acid, they absorb the material. Not only that, they will also release certain juices for the digestive purpose. Okay, so that juices are called as succus entericus. So enterocytes produce succus entericus, also called as intestinal juice. Okay. Now in your intestine, there are also cells for the defense purpose. Okay. In your intestines, what do you have? There are cells for the defense purpose, for the immune purpose. So those cells are called as the Paneth cells. This is the question in the NEET PG exam. Defensins are produced by, defensins are the immune molecules or cytokines which helps in the defense purpose. Okay, it's a part of immune system. Simple. Okay, defensins are also the cytokines which will be helping in the purpose of the phagocytosis. So defensins are produced by which cells? Paneth cells. Paneth cells are present in our intestines. Okay, so Paneth cells produce lysozyme and defensins. So these are the single line MCQs. Next, after this, in the intestines, we also have cells called as Mo cells. This is important. MO. In one of the NEET PG exam, they have asked, motilin is produced by, they gave M cell. That's the wrong statement. Not M cells, Mo cells. MO. Okay, MO, Mo cells. Now, what is the purpose of this motilin? Motilin ka use kya hai? What is the purpose? Motilin, the name itself, it is that it helps in motility. Which motility? Gastric and intestinal motility. The contractions, both the stomach contractions as well as the intestinal contractions. Both the stomach as well as the intestinal contractions are going to be done with the help of this motilin, and motilin is produced by most cells. And these most cells are present in intestines, and they are not only present in the intestine but also present in the stomach. If you want to know, also present in stomach. Okay, now let me clarify everything is clear or not. Is everything clear, guys? My screen is visible, right? I haven't. Yeah, I think it's visible. Yeah, it's visible. Okay, done. Next, very high yielding point with the pharma integration is, see this. Okay, let me draw it here. So imagine this is your intestine, buddies. Okay, this is your intestine. Now on the intestine, okay, there are these receptors. What are these receptors? Motilin receptors. Motilin receptors. Okay, motilin receptors. See, these motilin receptors will be stimulated by motilin. This is motilin molecule. Okay, motilin is going to stimulate the motilin receptors. Okay, then what happens? It causes motility. It causes the motility, the intestinal motility. The intestinal smooth muscles are going to contract. Okay, but important point is, not only motilin can stimulate the motilin receptors, but also other agent can stimulate the motilin receptors. The motilin receptor can be stimulated by a similar drug, a similar agent. So what is this drug? So this drug is erythromycin. Erythromycin, not erythro, it's erythromycin. Okay, so this is erythromycin. Is right? Yeah, here. So erythromycin, this is sin, erythromycin. So erythromycin, see, motilin receptors are stimulated by an antibiotic. It's a macrolide antibiotic. That is a erythromycin. So if I am using erythromycin for infections, I'm using erythromycin for some infection. These erythromycin, what it will do, it will come and stimulate the motilin receptors. So if the motilin receptors are stimulated, means unnecessarily the motilin receptors are getting stimulated because of this erythromycin, unnecessarily. So that will cause increased motility, right? So that will cause increased motility. That increased motility can lead to diarrhea. Okay, that will cause diarrhea. So erythromycin side effect is diarrhea, because it stimulates the motilin receptors. Increases the motility. So whenever there is so much motility, absorption will be hampered, absorption will be affected. So that can lead to diarrhea. Okay, so that's why erythromycin side effect is diarrhea. SE means side effect. Here it is a side effect is diarrhea. But the same erythromycin can be used in the treatment of certain diseases. See, for example, diabetic. Okay, diabetics, after a long time, after 25 years, 30 years, like, chronic diabetic. In chronic diabetic, there will be something called as diabetic gastropathy or diabetic gastric paralysis. In diabetic people, the GI motility will be hampered, affected. The GI motility is going to be reduced. Okay. In diabetic people, what happens? GI motility is reduced. Okay, so in those individuals, we can use this erythromycin. So erythromycin can be used in diabetic gastric paralysis or paralytic ileus. Okay, paralytic ileus. Same again, the intestines are not moving properly, maybe after surgery, after trauma or something. Okay, so in paralytic ileus and in diabetic gastric paralysis, we can treat these diseases by giving erythromycin, because erythromycin increases the intestinal motility. So we are using the side effect to treat the disease. Okay, got it? So the next important hormone is ghrelin. Already you know about the ghrelin. Okay, so ghrelin is produced during fasting. Okay, ghrelin is produced during fasting. And in yesterday's class itself, I have told you, sir, ghrelin is responsible for the hunger. It increases the hunger. It's a typing mistake. Please make it clear. It increases the hunger. Ghrelin increases the hunger. Okay. Now, you should think logically and tell me. Sir, look here, ghrelin is going to increase the hunger, no doubt. What about the ghrelin relationship with the insulin? Ghrelin is produced during hunger. Means hungry time, you want more glucose or less glucose? You want more glucose. During hunger, you want more glucose. So what it should do to the insulin? So ghrelin should decrease the insulin. Ghrelin should decrease the insulin. Otherwise, what insulin will do? Insulin decreases the glucose. So you need to decrease the insulin, right? So insulin should go down. Okay, insulin should go down. So ghrelin decreases the insulin. Decreases insulin. Important MCQ. Because ghrelin want to increase the glucose. Insulin want to decrease the glucose. So now the insulin should have to go down. During fasting, simple. During fasting, your insulin levels will go down. Remember that point. During fasting, insulin levels will go down. And ghrelin decreases the insulin. And what about the ghrelin relationship with other hormones? See, ghrelin is increasing the growth hormone, true. And also ghrelin increases the acid in your stomach, true. So these three relations I want you to know. Ghrelin decreases the insulin, increases the growth hormone, increases the acid. And also ghrelin increases the GI motility, gastrointestinal motility. Motilin increases motility, true. Motilin increases motility, true. In the same way, ghrelin also increases GI motility, true. So with this, some direct single answer questions are completed. These are the small topics. Okay. Next. So I hope you understood. So let me check if anyone of you have asked anything. Anyone of you have any doubts? No doubts. Everything clear, right? Chalo. So what are the questions which you need to know in this from this slide? Defensins. Defensins are produced by pannate cells. Important. Succus centricus is produced by enterocytes. Important. Motilin is produced by Mo cells, not M cells, Mo cells. Secretin is produced by, in yesterday's class I have told you, secretin is produced by S cells. Cholecystokinin is produced by I cells. Okay. Next, sir, what is the relationship between ghrelin and insulin? Ghrelin decreases insulin. Okay, ghrelin increases growth hormone. In yesterday's class I have discussed ghrelin also stimulates the release of growth hormone. Ghrelin increases acid and ghrelin increases intestinal motility. Okay, done. Next. So, your GIT is under your control? No, you are not contracting your GIT. You can't control your intestines. You can't control your stomach contractions. So, who is controlling this contractions in the stomach? So, there is a pacemaker. Who is that pacemaker? There is a beautiful cell called the Kajal cell. Okay. So, the pacemaker in the stomach is called as interstitial cell of Kajal. So, let me ask you some questions. So, who is the pacemaker in the cardiovascular system? In the heart, the pacemaker is SA node. You know it. SA node. Okay. In the GIT, who is the pacemaker? Is the interstitial cell of Kajal. ICC, interstitial cell of Kajal. In the respiratory system, who is the pacemaker for the respiratory system? This is the question which most of the student doesn't know. Respiratory system, who is the pacemaker cell? Who is controlling the contraction of diaphragm? Who is controlling your respiration? You are not doing that. Who is going to do that? Who is controlling your respiratory activity? Who is the pacemaker? Come on, students. Who is the pacemaker? Vishnu, Subhatra, Pranati, Abra, Nadia, Satish. Come on. Hindbrain? No. No, Iqbal. No, Iqbal. Not so hindbrain. Anyone of you have anyone of you heard about something called as pre-Botzinger complex? Important MCQ. Tested already in the exams. Most student doesn't know about this. Only students know about this cardiovascular system. SA node is the pacemaker and interstitial cells of the Kajal are the pacemaker. But now, right, respiratory system, there is something called as pre-Botzinger complex. Okay, pre-Botzinger complex is the pacemaker in the respiratory system, already tested. Now, sir, this interstitial cell of Kajal, okay, this is not needed. Interstitial cell of Kajal, from where it is going to start? From where it started, sir, interstitial cell of Kajal? It's going to start from the stomach, body of the stomach. Stomach, you know, there is something called as body, fundus, like, you know, pylorus, antrum, all these parts are there, right? So, It's going to, these cells are going to start from the body of the stomach. Okay, along the greater curvature, Okay, well, let me show you. You know, right? So there is something called, see, this is the greater curvature and this is the lesser curvature, greater curvature and lesser curvature. Now, see this interstitial cell of Kajal. Okay, Kajal is something beautiful thing, right? Beautiful cell. So are you satisfied with one Kajal? No, we are not satisfied with one Kajal. Okay, so we have lot of Kajals. Okay, so this interstitial cell of Kajal, these pacemaker cells are many in number, not one. In heart, there is only one pacemaker. In respiratory system, there is only one pacemaker. But we are not satisfied with one Kajal. So there are so many interstitial cell of Kajal from the stomach till to the colon. There are so many interstitial cell of Kajal. Okay, that's the point which I want you to know. Okay, keep that point in mind. So these interstitial cell of Kajal, from where they are starting from the body of the stomach along the greater curvature. Okay. Now let me draw that beautiful cell for you. Okay. So this is the interstitial cell of Kajal ICC. Now this interstitial cell of Kajal, let me say there is resting membrane potential, RMP, resting membrane potential. For example, it's at minus 60 millivolts. These voltages are not needed. Okay, this resting membrane potential, the cell is having a voltage of minus 60 millivolts, membrane voltage of minus 60 millivolts. Okay. Now in this interstitial cell of Kajal, this Kajal cell is a little crazy cell. What is happening is, see, this is minus 60, for example. Voltage is at minus 60. Sometimes, okay, the voltage is going to go little positive, okay, going little positive, and it is coming back. Okay, so voltage is again going to become positive, again it's coming back. So voltage is fluctuating. Okay, so this is the normal. Normally, always in the interstitial cell of Kajal, voltage is fluctuating, going to positive, coming back, going to positive, coming back, going to positive, coming back. So these electrical fluctuations, which are normally happening in the interstitial cell of Kajal, they are called as basal electrical rhythm. Okay, this is called as a basal electrical rhythm. So these electrical fluctuations are called as a basal electrical rhythm. Are they action potentials? No, they are not action potentials. Let me write here. They are not action potentials. They are not action potentials. Okay, they are just electrical fluctuations. They are not action potentials. Are they responsible for any GIT contraction? This basal electrical rhythm, is it going to cause any contractions, peristalsis? No. No contractions. Okay, they are not going to cause no GI contractions. Okay, so there will be no GIT contractions. No action potentials. They are not the action potentials. They are not responsible for the GI contractions. They are called as a basal electrical rhythm. So basal electrical rhythm is also called as, these waves are also called as slow waves, right? Slow waves. Okay, slow waves. Just remember this word slow waves. Remember this word slow waves because the same thing I will ask in the central nervous system. In central nervous system also this word will come, slow waves. Okay, remember that, slow waves. Done. So now, okay, just let me erase a little bit. You don't do anything. See here, I am drawing it again. So these are the electrical fluctuations. These are the electrical fluctuations. That's called basal electrical rhythm. Now, when you eat the food, okay, when you eat the food, actually, food, which nervous system is going to get active? Parasympathetic nervous system is going to get active, right? So let me draw it here. Now, when you actually eat the food, it's a vagus nerve. Look here, this is the vagal nerve endings. Vagus nerve, it's going to release what? Acetylcholine. It's releasing acetylcholine. Now, when the acetylcholine is acting on its receptor, look what happens. Now, on the basal electrical rhythm, new waves are coming. So what are these new waves? New spikes are coming here. So these are called as, because of this acetylcholine action, when the acetylcholine is acting, when you actually eat the food, acetylcholine is going to be released. So when the acetylcholine is acting, now there is a little bit more fluctuation. Okay, more fluctuation is happening. So these fluctuations are called as spike potentials. So these spike potentials are the action potentials. They are action potentials. Important MCQ. They are the real action potentials. They are responsible for GIT contractions. Okay, whenever spike potentials are there, they are responsible for what? GI contractions. Okay, they are responsible for the contractions in the stomach and intestines. Okay. Now, for example, so you have done with your eating, completed, or when you are eating, suddenly a news came. For example, suddenly a news came. The next exam that you are going to give in the June, okay, or July, the next exam is going to be next exam. Okay, so what's going to happen? You are going to get panicked. Okay, you are going to get anxious. You are going to get panicked. Totally, you are worried. So when you are worried, which nervous system is going to be active in your body? Sympathetic nervous system. When you hear about certain news, sympathetic nervous system is going to get activated. So whenever the sympathetic nervous system is activated, again, let me draw it here with the other color. So for example, now these are the sympathetic nerves. Okay, these are the sympathetic nerves. See what these sympathetic nerves are going to release? They will be releasing epinephrine or norepinephrine. When epinephrine is acting on its receptor, what will happen? Now look what is happening. See the spike potentials are decreasing, and again the basal electrical rhythm is going to be established. Again, the basal electrical rhythm is going to be established. Okay. So acetylcholine or the parasympathetic nervous system. Okay, acetylcholine or the parasympathetic nervous system is responsible for this spike potentials, is responsible for the spike potentials. Whenever epinephrine is acting, whenever the sympathetic nervous system is acting, okay, whenever epinephrine is acting, the spike potentials, see, the spike potentials are decreasing and basal electrical rhythm is going to be established again. Okay, so the same thing I am showing you here. Okay, if you are done with this diagram, you are no need to draw this actually, no need to draw this because it's already given in your book. Okay, now first, do you have any doubts? So let me check whether you have any doubts or not. Okay, no one is having any doubt, right? Okay. Yeah. So look at here. Look at here. Now forget about these recordings. These values, they are not of importance. Okay, they are not of importance. Now, what I have told you. See, normally there is electrical fluctuation. Normally there is this electrical fluctuation. What is this electrical fluctuation called as? These electrical fluctuations which are happening, they are called as basal electrical rhythm. You can say these are the basal electrical rhythm. Okay, so here I am talking about the electrical fluctuations, electrical recording. Whenever there is basal electrical rhythm, is there is any GIT contraction? I am asking you. Is there is any mechanical contraction? No. So mechanical recording, see, there is no mechanical contraction. It's a flat line. The GIT is not contracting. It's a flat line. But see, whenever your parasympathetic nervous system is activated, who is coming? See, spikes are coming. 2 spikes, 3 spikes. Means more the number of spikes, more contractions. Okay, more the number of spikes, more contractions are happening. Okay, so these are the spike potentials. Okay, guys. Now, whenever your sympathetic nervous system is activated, look what happened to the spikes, decreasing, and basal electrical rhythm is coming back. So look, the GIT contractions are decreasing and coming to like the GIT contractions are going to be stopped, right? So these are some important points. Directly, what they will ask in your exam is basal electrical rhythm. Is it action potential? No, they are not action potential. Is it responsible for GI contractions? No, they are not responsible for GI contractions. Then who is responsible for GIT contractions? It is the spike potentials. Okay, it's the spike potentials. Spike potentials are because of acetylcholine. That's it. Okay, that's it. Now, the next important topic which was already tested in the exam is, see, now look at here, look at here. No need to draw it, just try to understand, don't draw it. Sir, how many interstitial cell of kajal are there? You are having one kajal or many kajal? You are having many kajals, right? So this is one kajal cell. This is one kajal cell, number 1. Okay. This is one kajal cell in your duodenum. And this is a kajal cell which is present in your cecum. Okay, cecum, one kajal cell, and there is one kajal cell in duodenum. Now look here. In the duodenal, this is the duodenal kajal cell, duodenum. Okay, there are kajal cells present in the duodenum also. Now look here, how many times the electricity is getting fluctuated? How many times the membrane voltage is getting fluctuated? In a minute. Look, so many times the electrical voltage is getting fluctuated, increasing, decreasing. Okay, the electrical voltage is fluctuating so many times. How many times? Almost. See, the basal electrical rhythm. Okay, the rate of BR. How many times? 12 times the electrical voltage is going to get fluctuate in duodenal interstitial cell of Kajal. Okay, this is the MCQ. Maximum BR. Maximum BR is seen in duodenal interstitial cell of Kajal. Okay, only write this thing. And if you look at the cecal interstitial cell of Kajal, this is the cecal interstitial cell of Kajal. How many times electrical voltage is going to get fluctuate? In a minute, only 2 times the fluctuation is going to happen. Okay, the nature has designed like that. Okay, don't like sir, why it is like that? The nature have decided. Okay, so only 2 times the electrical voltage is fluctuating. So cecum mein, the cecal interstitial cell of Kajal, what is the rate of BR? 2 times the electrical voltage is going to fluctuate in a minute. So only these two. This is the minimum BR. So maximum BR and minimum BR. Only write those two. Other things are not needed. These things are not needed. Okay. There are so many things that are going to come, that are going to be there in the book, but all those things are not needed. Okay, don't worry about them. Duodenum and cecum. Completed. The next most important topic in the GIT. See, in the GIT, if you want to know only one topic, GIT may only one topic. If you want to know about this peristalsis and segmentation. Okay, know about the peristalsis and segmentation. So what is this peristalsis and segmentation, sir? So both these peristalsis and segmentation, both are GI motilities, both are a type of GI motility. Okay, these are 2 types of GIT contractions, 2 types of GIT contractions. Okay. Now, what is peristalsis? What is peristalsis? Peristalsis may see you have taken the food. Okay, food is there in your intestine. Food is there. Now you want the food to move towards the one end. Okay, you don't want the food to go back. Okay, only it should be always, the food should be always, our food or the stool should be moving always towards the anus. It should be only one directional. The food should not be regurgitated. Okay, it should not come back. So that's why what is happening? The proximal segment, this is the starting area, right? So this part of the GIT is contracting. Okay, so to prevent the regurgitation. And the distal segment, it will actually relax. Okay, it will actually relax so that food will move forward. This arrow is important. See, the food is moving forward little by little, the food is moving forward. So the proximal segment, right? Where I should write here? Okay, let me write here. Proximal portion or proximal segment contracts. Proximal segment contracts. And distal segment relax. In peristalsis type of GIT motility, proximal segment is contracting, distal segment is relaxing. So who is responsible for this contraction? Which neurotransmitters will cause this contraction? Acetylcholine and substance P. Repeatedly tested questions. Acetylcholine and substance P will cause the contraction. And who is going to cause this relaxation? This relaxation is done by nitric oxide and vasoactive intestinal peptide. Okay, nitric oxide and vasoactive intestinal peptide. Okay, acetylcholine and substance P cause the contraction, and vasoactive intestinal peptide causes the relaxation. Vasoactive intestinal peptide and nitric oxide, they cause the relaxation. Okay, let me test. So in yesterday's class, we have discussed about the nitric oxide in one place. Can you tell me what is the secondary messenger used by the nitric oxide? Nitric oxide का secondary messenger क्या है? Is it CAMP, CGMP or IP3? Nitric oxide. What is the secondary messenger of nitric oxide? Jyoti Sharma, excellent. Nadia, Rahul, excellent. It's a CGMP. Okay, it's a CGMP. Okay, that's also tested many times in the exam. Okay, don't forget about that. So in peristalsis, if you want to know one thing, sir, what is that? Always look at the arrow. Okay, arrow will help you. Okay, see, arrow should be moving forward. So peristalsis is helping for what? He's helping for the propulsion. P for P. Remember, propulsion of the food or the movement of the food, forward movement of the food. So peristalsis for propulsion. Okay, peristalsis helps in propulsion of the food or pushing the food forward. So then what is segmentation? Okay, what is segmentation? Segmentation means, see here, arrows is important. The food is not moving forward, not moving forward. Okay, arrows are important. Okay, see here, both the proximal segment and distal segment are both are contracting. Okay, and now the food is in the small pockets. Now food is divided into small pockets. Okay, both proximal and distal segments are contracting. Now here the food is going to be mixed with the enzymes. Now look, the food is going to be mixed. Now here the digestive juices are going to be mixed with the food. Okay, digestive juices are releases and the food is going to be mixed with the enzymes. Okay, so what's happening here? At the end of the day, there is digestion of the food. See, the food is getting digested. The big food is getting into smaller microparticles. The food is, see, look here, the food is getting digested. Okay, then segmentation main purpose is not the movement. Segmentation main purpose is not the movement. Segmentation main purpose is mixing movements. Okay, mixing the food. This is the keyword, mixing. Okay, mixing and digestion. So mixing the food with the digestive enzymes, okay, and further digestion. So segmentation, you need to know mixing and digestion in keywords, mixing and digestion. Okay, food is divided into small pockets. Okay, and mixed with the digestive enzymes, and food is going to be digested. That's it. So these are the two differences between peristalsis and segmentation. No one will ask you anything about this. Okay. So is that clear, guys? Peristalsis and segmentation. Is that clear? If it is clear, let me ask you something. Peristalsis and segmentation, both these things, are they happening during fed state? Are they happening during fed state? Fed means like no, when you have taken the food. Are they happening during fed state or fasting state? Are they happening during fed state or fasting state? They're happening during fed state. Fed, we have taken the food. They're happening during fed state. Now my question to you, sir, you haven't ate anything from the morning, for example. You haven't ate anything. Okay. Guys, the Zoom got a technical issue. Okay. So there is no problem from your side. There is no problem from your side. It's the problem from my side. That Zoom got some technical issue. So again, I'm telling you, if there is any issue, I will come back. Okay, don't worry. I will come back within 5 minutes. I will be there. So my question to you, guys, if you haven't ate anything from the morning, you haven't ate anything. So will your GIT is going to contract? I'm asking you. You haven't ate anything, sir. You haven't ate anything. Will your GIT is going to contract? Can you see me, guys? Can you? Sai Pant is saying we can't hear your voice. Is it so, guys? Can't you hear? Can't you hear my voice? Audible, right? Ah, you can hear. You can hear. Sai Pranati, it's a problem from your side. Sai Pranati, it's problem from your side. So next, chalo, let's continue. See, even during fasting states, even when you do the fasting, Okay, even when you do the fasting state, even during fasting states, your GIT is going to contract. True. Even without food, your GIT is contracting. So those contractions are called as migratory motor complex. Okay. So what exactly is a migratory motor complex? Migratory motor complex are contractions during when? During fasting state. Okay, during fasting states, you will have the contractions. Those contractions are called as the migratory motor complex. Now, these contractions will start from the stomach. Okay, important. They will be starting from the stomach. Contractions will start from the stomach, and they will go till to the colon. Contractions will be starting from the stomach till to the colon. Now, you can ask me, sir, without food, why our GIT is contracting? Why it is contracting? To clean the GIT, to clean any leftover food. If there is any leftover particles in the stomach or intestines, we need to remove them. We need to clean them. We need to move those things into the colon and into the rectum, right? So the purpose of this migratory motor complex is to clean the GIT. So that's why this migratory motor complex is called as broomstick or sweeper or housekeeper of the GIT. Housekeeper means cleaning, right? So housekeeper of GIT. So it's called as a broomstick of the GIT, sweeper of the GIT, or housekeeper of the GIT. Okay. So sometimes this migratory motor complex, okay, migratory motor complex can cause pain. Okay, if you are not eating for like long time, for 2 days, 3 days, you are not eating for long time, then people will say, right, like, you don't know the pain of fasting, you don't know the pain of like, not eating. Okay, so this migratory motor complex, if it is powerful enough, when it is more powerful, it will cause the pain. It will even cause the pain. So that they are called as the hunger pangs or hunger pains. Okay, migratory motor complex. These contractions are responsible for the pain during fasting. Okay, and I have said you already, it cleans the GIT and it prepares the GIT for the next meal. And how frequently you have this migratory motor complex? How frequently? What is the frequency? Means one migratory motor complex. Okay, one migratory motor complex in 1.5 hours. Okay, for every 90 minutes, one migratory motor complex. Okay, one powerful wave of contraction is going to start from the stomach, and that contraction will go till to the colon. One migratory motor complex in every 90 minutes. And see, remember, migratory motor complex start with the letter M. So who is going to mediate this migratory motor complex? Motilin, I have discussed motilin receptor, erythromycin, the same motilin. Motilin is going to take care about this migratory motor complex. Okay, migratory motor complex is mediated by motilin. That's it. Okay, so the last slide, motility in the GIT. If you are still writing, right. So next. So motility in the GIT. I have already discussed about the electrical motility. Electrical fluctuations are happening. I have discussed about that in the interstitial cell of Kajal. They are called as the basal electrical rhythm. You already know it. And what are the real mechanical motility? See, during fed state, you have peristalsis as well as segmentation. You are having what? Peristalsis as well as segmentation. And during fasting state, what kind of mechanical motility you are having? What kind of mechanical motility? You are having migratory motor complex, that is motilin mediated. Migratory motor complex, motilin mediated MCQ. Migratory motor complex, 1 in every 90 minutes MCQ. Okay. So done. So the last slide, edification reflex, it's a bullshit, not needed. They haven't never tested this thing. Not in FMG, NEET PG. They have never tested such thing, just for the first year students. Okay. Not for you. That's for the first year students for understanding purpose, not needed for you. So with this, we have completed the GIT. So shall we start? See, it's a digestive enzyme, succus entericus. Okay, bile, like, succus entericus, bile, and pancreatic enzymes, all these enzymes. Okay, those enzymes. The food have to be mixed with the enzymes for the thing. So shall we start with the cardiovascular system? Yeah, Abra is asking about the ECG. See, I will do actually. Let me tell you about the ECG. Just wait. Let me tell you about the ECG. At the end of the cardiovascular system, I will tell you. Okay. So let's start the cardiovascular system. As I have already said, in the first 1 hour of the cardiovascular system, but the first 1 hour, it will be little boring, little dry topic. First 1 hour. Later on, all topics are conceptual, very important. Okay. So having said that, chalo, let's start cardiovascular system. Next. In the cardiovascular system, in your heart, there are two types of tissues present in your heart. Okay, in your heart, there are two types of tissues present. What are the two types of tissues? There are tissues called as the nodal tissues. So nodal tissues. What are the nodal tissues? SA node, AV node, like Purkinje fibers. Okay, bundle of His. These are the nodal tissues. SA node, AV node, Purkinje fibers, bundle of His. What is something special about the nodal tissues? The nodal tissues generate the action potentials. Okay, nodal tissues generate action potentials. Means they are responsible for the contraction. Okay, they will generate the action potentials and they will cause the contractions. The other thing is the muscular tissue. Okay, so muscular tissue is the one which undergoes contraction. Okay, muscular tissue is the one which undergoes contraction. Here they generate action potentials. Because of this action potential, the muscular tissue will undergo contraction. Okay, so two types of tissues completed. Not that important. Leave it. Okay, not that important. Next, action potential pathway. Okay, action potential pathway. Are simple. First of all, let me tell you where the action potentials are originating in your heart. Okay, in your heart, where the electrical, where the electrical event originates, where the electricity originates. Okay, so it's the SA node. So SA node is a place where the action potential is originated. From the SA node, the information, the electrical information or the electricity is going to pass to the AV node. From the AV node, the electricity is going to pass to the bundle of His. From here, the electricity is going to spread into the right bundle branch and right and left bundle branches. And finally, the electricity or the action potential will travel to the Purkinje fibers. Okay, so this is the pathway. Now, even if you look here, so here it's not clearly shown, but anyway, we'll just leave it. So this is the pathway. Now, from here, there are certain single liner questions that there. Okay, there are some single liner questions there. Okay, some single liner questions there, which I want you to know. Those single liner questions. What are they? See, SA node is the pacemaker of the heart. Okay, it's the pacemaker of the heart. See, SA node, AV node, a bundle of His, Purkinje fibers. See, they all can generate the action potentials. All of them, they can generate the action potential. But why only SA node is called as the pacemaker of the heart? Because it generates maximum frequency of action potentials. Means more number of action potentials are generated by the SA node. So that's why it is controlling the heart rate. Heart rate is under the control of SA node because it generates maximum action potentials. How many action potentials? 70 to 100 action potentials per minute. Okay, 70 to 100 action potentials per minute. So your heart is under control of SA node. That's why it's the pacemaker of the heart. MCQ asks, pacemaker of the heart because of maximum frequency generation, maximum frequency of the action potential generation. Okay, believe me, this is the simple question which was asked. Who is the pacemaker of the heart? SA node. Okay, just wait. In the, just where is the cardiovascular system? So these are all the previous year questions. Okay, in the recent FMG exam, see, this is the recent, in the recent FMG exam, this is how simple the questions were asked. This is the question which was asked. Electrical impulses are originated in SA node. That's the question asked in the FMG exam. Recent means not the recent one. I think 1.5 years back. Electrical impulses are originated in SA node. Okay, as simple as that. So let's come back to our topic. Next, what are the important points about the AV node? See, AV node is called as a gatekeeper of the heart. Okay, it's called as what? Gatekeeper of the heart. Why it is called as the gatekeeper of the heart? Because all the action potentials, look guys here, let me draw heart for you in a simple way. See, these are the 4 chambers of the heart. Where is SA node? SA node is here in the right atria. Here, right atrium, SA node here. Okay. Now, who is here? AV node. Okay, here is AV node. Now, this electrical impulses or the action potentials are coming to the AV node. See, in the AV node, this speed of okay, the electrical impulse is going to be greatly reduced. The speed means the electrical impulse is going to go very, very slowly. So that's why the AV node is called as a gatekeeper, because all the impulse have to go through the AV node. Okay, it's like a watchman. The impulses have to go through the AV node. That's why it's called as a gatekeeper. And second point I have told you, see, there is a slowest speed of conduction. There is slowest speed of conduction, means the electrical impulse is going to be slowed down. Okay, so that is responsible for AV delay. That's causing the AV delay, because the electrical impulse is traveling slowly in the AV node. That will cause AV delay. Some students will have a doubt. What is this AV delay, sir? AV means atrioventricular delay. Guys, look, what is the importance of this AV delay? Why do we need this AV delay? If you ask me, look at me, sir. See, now imagine there is a heart in my hand. Okay, look at me. There is a heart in my hand. First, atria should contract, pumps the blood into the ventricles, then ventricle should contract. First, atria should contract, then the ventricle should contract. Don't think that both atria and ventricles are contracting at the same time. No, big no. First, atria should contract, then the ventricle should contract. Array, electrical impulse, electricity almost travel with the speed of light. Okay. So the point which I want you to know is, for example, if there is no AV node, either AV node nahi hai. For example, if AV node is not there, what happens? The electrical voltage will spread throughout the atria and directly comes into the ventricle. Within a fraction of a millisecond, the electrical voltage will spread through the entire heart, and both atria and ventricles will contract at the same time. No, we don't want that. First, the atria should contract. Later on, the ventricle should contract. Okay, so this AV delay is required. Here, the impulse should be slowed down, so that first atria will contract, later on the ventricle will contract. So what is the importance of this AV delay? The AV delay importance is it prevents the simultaneous contraction of both atria and ventricles at same time. It helps in what? Helps in ventricular filling. Okay, first atria will contract. When atria is contracting, ventricle is in relaxed state. So ventricle is going to be filled. Okay, ventricle is going to get filled. Okay, so what is the importance of this AV delay? It helps in the filling of the ventricles. It prevents the simultaneous contraction. Now, this AV delay, okay, how it is represented in the ECG? You know ECG, right? Let me draw the ECG for you. This is also a question which was asked. ECG mein P wave, QRS, and T wave. Okay, P wave, QRS, and T wave. So, what is PR interval starting from the P to the Q? Okay, so this is PR interval from here to here. Okay, just let me draw it with the other lines. Okay, so this interval which I am showing here is PR interval. Okay, PR interval. So this PR interval, what is happening during this PR interval? If someone asks you, during this PR interval, okay, impulse is starting from the SA node. Impulse have started from the SA node, and impulse is going through the AV node. Okay, the impulse is still going through the AV node. Okay, so this PR interval in the ECG is occurring during when? When the impulse is going from the SA node to the AV node. Now in the ECG, it is represented as PR interval. PR interval. Okay, impulse have started from the SA node and it is going to and through the AV node. So that time period is represented as PR interval. Okay, and normal, what is the normal time of PR interval? 0.1 second. Okay, 0.1 second PR interval. Okay. Now from here, the impulse is going to the bundle of his. You know it. Impulse is going to the bundle of his. Okay. Sorry, just one more point I have forgot. So what happens in certain individuals who are mainly alcoholics, okay, in those people, the impulse sometimes is getting blocked. The electrical impulse will be totally terminated, is blocked in the AV node. When the impulse is totally blocked in the AV node, that is called as conduction block or heart block. Okay, it's called as heart block. Right here, heart block or conduction block. So what is the most common site of conduction block? The most common site of heart block or conduction block is AV node. The impulse sometimes is going to be terminated here. It's going to totally stop in that area. It's not going to the bundle of his. It's not going into the ventricles. So that's called as a conduction block or heart block. Okay. That's the point which I want you to know. One thing. Next, this bundle of his, these things are not that important. Now, last important point is Purkinje fibers. Our fastest speed of conduction, okay, is happening in the Purkinje fibers. In the Purkinje fibers, there will be fastest. The electrical impulse is going to go very fast. Okay, just wait for a second. So this is your heart. In your heart, here is the SA node present. Here is the SA node present. Here is the AV node present. Now from the AV node, who is going to come? This is the bundle of his. Here is the bundle of his. Bundle of his is going to divide into right bundle branch, left bundle branch. This is right bundle branch. Here is the left bundle branch. And from here, who is going to come? These are the Purkinje fibers. Purkinje fibers goes to the myocytes, ventricular myocytes, and helps in contraction. These are the Purkinje fibers, right? Like this. Now, see, in the AV node, you already know it. In the AV node, there is slowest speed of conduction, slow speed. Okay, there is slow speed. But in the Purkinje fibers, there is fastest speed of conduction. Okay, there is fastest speed of conduction. So that's the point which I want you to know. It's fastest speed of conduction. Why there is fastest speed of conduction? Because there are more gaps between the cells, more number of gap junctions are there. So very easily the electrical impulse is going to travel. Okay, Purkinje fibers, they're having maximum gap junctions. That's why there is fastest speed of conduction. Here in AV node, there is a slowest speed of conduction because there are minimum gap junctions or less gap junctions. Okay, there are less gap junctions. And here there are more gap junctions. That's it. The topic is completed. Action potential pathway, some single line questions. Next. Now let's talk about the action potential. Okay, SA node action potential. Before going further, let me tell you, in the cardiovascular system, what are the important topics for your exam? Okay, now we are actually going to the real topics. Okay, the real topics. Right, important topics in cardiovascular system. One thing, action potentials of SA node and ventricular myocyte. Okay, action potential of SA node and ventricular myocyte. Second important topic is cardiac cycle. Cardiac cycle, along with it heart sounds and murmurs. Okay, cardiac cycle, heart sounds and murmurs. Next, important topic, left ventricular pressure volume loops. Left ventricular pressure volume loop. Fourth topic, jugular venous pressures. Next, concept of preload and afterload. Okay, concepts of preload and afterload. And next, the super important topic which was also recently tested in the exam, that is cardiac reflexes. That's it. Okay. Last, some miscellaneous topics were there. We will discuss about them later. In they will come in vascular physiology. But in cardiovascular physiology, these are the important topics. Okay, action potential of SA node, ventricular myocyte, cardiac cycle, heart sounds and murmurs, left ventricular pressure volume loops, JVP, jugular venous pressures, preload and afterload, and cardiac reflexes. If you know this, you can answer any question, any damn question. So having said that, without any further late, now let's begin with the first topic, action potentials of SA node and ventricular myocyte. Questions asked so many times. So many times the question has been asked. No doubt in that. So first draw with me. Take a blank page and draw with me. Here, this is SA nodal cell. Your pacemaker, SA nodal cell. Okay. Now, in this SA nodal cell, what is the electrical voltage? The electrical voltage is at minus 60 millivolts. See the starting point here. Okay, this is the starting point. This is the starting point. Okay, this is at minus 60 millivolts. Right. So resting membrane potentially is at minus 60 millivolts, like this, at minus 60 millivolts. This line is representing minus 60 millivolts. Okay. Now, question is why it is minus 60? MCQ. The resting membrane potential is at minus 60. Kyun? Why? 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 It's because of two reasons. Now, draw it. So, on the cells, there are potassium channels. See, these are the potassium channel. Okay, let me show in the red color itself. These are the potassium channels through which potassium is going out. Potassium is going out. Potassium is going out. See, the positive charges are going out, right? Positive charges are going out. As the positive charges are going out, cell will automatically become negative. Positivity is going out. So, cell will become negative. So, that's the reason. The number one reason for this resting membrane potential at minus 60 is because of, right? So, resting membrane potential is because of what? Right. This resting membrane potential minus 60 is due to number one reason. Potassium efflux. Potassium is going out. Okay. Potassium efflux. Number two reason. The number two reason on the same cells there are, right, there are channels. Let me show in black color. There is a channel. What it is doing is it throws 3 sodium out, means it's throwing 3 positive ions out and only bringing 2 positive ions in, 2 potassium in. 3 sodium are going out and 2 potassium is coming in with the help of ATP. Means more positivity is going out, but only less positivity is coming in. Less positivity is coming in, right? So what is this? Sodium potassium ATPase. So sodium potassium pump or sodium potassium ATPase. So the number two reason for this resting membrane potential or this minus 60, it is due to sodium potassium pumps. Okay. So it's at minus 60 millivolts. So okay, sir. Now what happens? Okay, now what happens is this SA node have to generate the electricity. Now it have to generate an electrical impulse, right? How that actually happens? See, for example, okay, for every 0.1 second, what happens is first event is these potassium channels, they will close. They will start to close. First, that's the first event. Okay. Next event is on the cells, there are sodium channels. These are sodium channels called as a leaky sodium channels, also called as funny sodium channels. These are the funny sodium channels. Okay, leaky sodium channels are funny sodium channels. Now what happens is, now automatically by default, time to time, automatically sodium will start to trickle in. Okay, sodium will start to coming in. Already one thing happened. First event, what is the first event? Potassium is not going out. Potassium is starting to accumulate. Means the positivity is accumulating. One thing. And second thing is sodium is also coming into the cell. Again, positivity is coming into the cell. And the third event is here there are also the calcium channels present. There are also calcium channels present. Now these calcium channels are also open through which calcium is coming in. Calcium starts to come in. Again, positivity is coming in. So this calcium channel are called as T-type calcium channel. These are called as what? T-type calcium channel. Sodium is coming in, calcium is coming in. Done. So now tell me, sir, positive charges are coming in, positive charges are coming in, and here the positive charges are getting accumulated. So because of these three reasons, now the membrane voltage from 60. Okay, now the membrane voltage is at what? The membrane voltage is at 60, right? Now it is going towards positivity. Means it will go from 60, it will become minus 40 millivolts. Means it's getting little positive. It's little positive. Means from 60, it is getting to 40. Means moving towards positivity, right? Minus 60, minus 1. Minus 40 is more positive when compared to minus 60. So here it is fluctuating like this. It's not constant. It comes to minus 40. The moment, see, the moment minus 40 is attained, the moment minus 40 millivolts is attained within the cell, immediately do you know what happens? Now, for the first time, look, these channels, that some new channels are opening. Okay, these new channels are opened. What are these channels? These channels are L-type calcium channels. These are the L-type calcium channels through which lots and lots of calcium will come into the cell. Okay, lots and lots of calcium will come into the cell. So what is this minus 40 called as? See, this minus 40 is called as threshold potential. This is the threshold potential, means that's a threshold value, final value. Once you reach the threshold potential, immediately depolarization will start. No doubt the cell is going to get depolarized. See, calcium is going to come into the cell. Calcium will come into the cell. So because of that calcium, see, a lot of calcium is coming in. So the membrane is getting positivity. The membrane voltage is getting maybe plus 20 millivolts, or sometimes even plus 50 millivolts. Okay. So there is a spike. The voltage is going towards the positivity. So calcium comes into the cell. So this phase, this pink color phase, is called as the depolarization. Okay, depolarization. Now tell me, depolarization is because of what? Calcium. Depolarization is because of calcium. Okay, depolarization or phase zero. Depolarization or phase zero. P0, phase zero. Don't worry, I will make you to write everything one by one. There are tables, don't worry. Okay, so just listen to the concept. Depolarization or phase zero is due to calcium influx. Calcium influx. Okay, completed. Now, can anyone tell me, sir, this phase from minus 60 to minus 40, minus 60 to minus 40, what is this phase called as? This phase is called as a pre-potential. Pre-potential. Why? What is the reason for this pre-potential? Why it is going from minus 60 to minus 40? Why? Because of three events. Event number one is potassium efflux decrease. This is the number one. Potassium efflux decrease here. Potassium efflux decrease. Second event is through the leaky sodium channel, sodium is coming. And the third event is via the T-type calcium channels. Via the T-type calcium channels. So depolarization completed. Okay. So now let's write one by one. Okay. Pre-potential. Come to this slide. Right, pre-potential phase. What is the pre-potential phase? The membrane voltage is moving from minus 60 millivolts to minus 40 millivolts. Okay, minus 60 to minus 40, that is threshold. Okay, minus 60 to minus 40. Why? What is the reason? Why? Who is responsible? Who is responsible? First, number one event is reduced potassium efflux. This is a question tested in the FMG exam. What is the first event that will occur? During the action potential generation, the potassium efflux decreases. Second, sodium influx. Sodium will come through the leaky sodium channels, funny sodium channels. Sodium influx through funny sodium channels or leaky sodium channels. Event number three, calcium influx. Through what? Calcium influx. Through what? Calcium influx through T-type, not L-type, T-type calcium channels. Okay, calcium influx, T-type calcium channels. Okay, pre-potential reached, pre-potential attained, a threshold attained. Okay, threshold completed. Now after threshold, what is the next phase? Depolarization or phase 0. Okay, depolarization or phase 0. What is happening in the depolarization? Once this minus 40 is attained, calcium channels, L-type calcium channels are opened. So calcium will start to come into the cell. So that calcium is responsible for depolarization. So this one, depolarization, right? So right. So depolarization phase 0 is due to calcium influx through L-type calcium channels. L-type, L for long-standing. L-type means long-standing. Okay. L-type calcium channels. T means transient. T means transient. L means long-standing. Okay. T type means transient. L type means long-standing. Okay. Done. Done. So what is the next phase? Repolarization. The leftover thing is the repolarization, sir. Okay. Repolarization. So now what happens is once positivity is attained, once plus 20 is attained, now new channels are going to open on the cell surface. New channels. What are these new channels? These are delayed rectifier potassium channels. These potassium channels, they will open. They will allow the potassium to go out. They will allow the potassium to go out. Now again, positive charges are going out. The positive charges are going out. Okay, already depolarization happened. The membrane become positive. Okay, the membrane become positive. So after depolarization, potassium will start to go out. Okay, as the positive charges are going out, see the positive charges are going out. Again, the voltage will come back to minus 60. Okay, again the voltage will come back to, okay, let me show in the black color. The voltage will come back to minus 60. So this black color phase is called as what? Repolarization. Also called as phase 3. Repolarization or phase 3. Due to what? Potassium efflux. Due to potassium efflux. Okay, completed. So right here in our table, so repolarization of phase 3 is due to opening of, important word, opening of delayed rectifier potassium channels. Okay, opening of the delayed rectifier potassium channels leading to potassium efflux. What is happening? Okay, just right. Potassium efflux. Potassium is going out. Potassium efflux. Potassium is going out. Okay, opening of the delayed rectifier potassium channels leading to potassium efflux. So these are the 3 phases. So these are the 3 phases of the action potential. Now, the same thing, whatever I have drawn, it's same thing given in this also. See, from minus 60, it is going to minus 40. This is called as pre-potential. And it is due to 3 events, you know it. Okay, it is due to 3 events. First, potassium channel should close. Later, there should be slow influx of sodium, and also because of calcium influx. Next phase is this phase, this red color phase, which I am showing here, this red color one. What is that? That is the depolarization. This phase is the depolarization. This red color phase is the depolarization. The depolarization is also because of calcium, rapid influx of calcium via L-type calcium channels. After that, there is repolarization. It's due to efflux of potassium, efflux of potassium, or outflux of potassium. Okay, done. So completed. One topic is completed. Okay. Next, in one of the FMG exam, okay, in one of the FMG exam, they have asked this thing. What is the effect of your autonomic nervous system? Autonomic nervous system includes sympathetic. Autonomic means it's not under your control. Your heart rate is not under your control. Okay. Effect of autonomic nervous system on SA node action potential or pacemaker action potential. Okay. So what sympathetic nervous system is doing and what parasympathetic nervous system is doing? These are the single liner questions. Look carefully here, sir. Green color thing is normal. Whatever I am showing in the green color, that is normal. You know. So, okay, let me take the green color again for easy understanding purpose. So this is the starting point. This is the threshold. This is pre-potential. Okay. What is this phase? Depolarization. Okay. And what is this one? Repolarization. Okay. 3 phases completed. But look what's happening when the sympathetic nervous system is acting. Sympathetic nervous system. What sympathetic nervous system is doing? When sympathetic nervous system is acting in your body, look what is happening to the prepotential. Prepotential is completed in very little time. That's the first event. Okay, prepotential, the time for the prepotential is less. Previously, it is taking long time from here. Previously, it is taking from here till here. That's the prepotential time. Okay, let me erase and draw it again. So, previously, first starting. Where prepotential is starting? So, prepotential is starting from here. The green color one starting from here. And it is taking till here, prepotential. So, this much time it is taking. This much time. But when sympathetic nervous system is activated, now how much time it is taking for the prepotential? It's starting from here, and prepotential, it is taking less time. In less time, it is completed. In less time, it is completed. Okay, so I can say one thing. This is the question which was asked in the FMG exam. What is the difference between the prepotential from normal when compared to the sympathetic nervous system when it is acting? Here, this is the prepotential, which is the normal. When the sympathetic nervous system is acting, the prepotential slope increase. The prepotential is now having more slope. Okay, prepotential is having now more slope. It is getting how I should say that the slope is going to be more. Okay, now the slope is now more. It is increasing. The slope is increasing. So that's the thing which I want you to know. What is the effect of sympathetic nervous system? Slope of prepotential increases. Okay, that's the one question. When you compare it with the parasympathetic nervous system, when the parasympathetic nervous system is acting, okay, let me take some orangish color. Okay, now when the parasympathetic nervous system is acting, see, prepotential is starting here. Okay, prepotential, it is starting from here, and see how much time it is taking, the prepotential, to reach the threshold. It is taking so much time. Okay, so the slope decreased. Slope, not the time. Time is increased, but the slope is decreased. So parasympathetic nervous system, what it does, it decreases slope of prepotential. It decreases the slope of potential. Okay, done. These two are the important MCQs tested somewhere around 2017-2018 area. Okay, so I'm just keeping it here. One increases the slope, one decreases the slope. So far, is it clear? If I get a confirmation from your side, I will go further. Is it clear, guys? Chalo. If you have any doubt, you just type it here. Okay, you just please put it in the chat box. I will say it. Next. Now, you have to know about certain terminology before going further. You have to know about certain terminology. So what is this chronotropy? Okay, chronotropy, inotropy, dromotropy, bathmotropy, okay, lucitropy. Okay, the lucitropy was tested in the NEET PG exam. That's why. Chronotropy means, chronotropy is all about heart rate. Heart rate is a layman term, like normal term. I can say heart rate. Anyone can understand. But if you want to use the fancy word, that's the chronotropy. Okay, chronotropy means I'm talking about the heart rate. For example, if I say positive chronotrope, it increases the heart rate. If I say negative chronotrope, it decreases the heart rate. Something like that. Okay. Next, inotropy. What is inotropy? Inotropy is about the myocardial contractility. Myocardial contractility means how strong the heart is contracting, how powerful the myocardium is contracting. Okay. So inotropy is all about myocardial contractility, the power of contraction. Okay, it's all about the power of contraction. It's all about the power of the contraction. Next, what is the dromotropy? Dromotropy is the impulse conduction speed, the speed of impulse conduction, cardiac conduction velocity, or how fast the impulse is going. How fast the impulse is going from SA node to AV node to bundle of his to bundle branches and Purkinje fibers. How fastly it is going is called as a dromotropy. Okay, cardiac conduction velocity. Okay, bathymetropy. Bathymetropy is how easily we can stimulate the myocardium. How easily the myocardium is getting stimulated, or how easily the SA node or AV node, okay, they can easily, how easily they can excite, how easily they can generate the action potential, how easily they can generate the action potential is called as bathymetropy. Bathymetropy. Okay, that's called as a cardiac excitability. How easily we can excite the heart. And lucitropy. This is the question which was asked in the NEET PG exam. Lucitropy is all about relaxation of the heart. Relaxation of the heart. For example, there are certain diseases where lucitropy is affected. There are diseases where lucitropy is affected. Means, for example, like constrictive pericarditis and restrictive cardiomyopathy, where the ventricles are not relaxing properly. Relaxation problem. Okay, so something like that. Lucitropy is all about relaxation of the heart. Okay, contraction is inotropy. Relaxation is lucitropy. Done. Okay, done. Now, I have said you something special, that see this event number 2. What is this event number 2? See, what is this channel? These channels are leaky sodium channels, right? These are the leaky sodium channels through which the sodium will come into the cell. Automatically, the sodium will try to come into the cell, leading to this prepotential, right? So there are certain drugs which will block this funny sodium channels. There are drugs which blocks the funny sodium channels. Tested long back in the FMG exam. See, what is the drug? There is a drug called as ivabradine. Okay, there is a drug called as what? Ivabradine. What is this ivabradine is going to do? It's a funny sodium channel blocker. Funny sodium channel blocker. It's a funny sodium channel blocker. There is a drug called as ivabradine. The name itself is there. It causes bradine. It causes bradycardia. It decreases the heart rate. It's logical, right? It's blocking the sodium channels. So automatically heart rate decreases. So it is useful to reduce heart rate. It reduces the heart rate during tachycardia. During tachycardia, sinus tachycardia. Sinus tachycardia is normal tachycardia. During tachycardia, it reduces the heart rate. Okay. So what is the funny sodium channel blocker? One is the fun. So funny sodium channel blocker is ivabradine. Okay. Now, important side effect of this drug is it also blocks sodium channels in the eyes. It also blocks the sodium channels. Same sodium channels are also present in your retina. Okay, same sodium channels are present in your retina, in your rods and cones. So that's why they can cause visual disturbances. That's a side effect. That's a side effect. Okay, so that's why ivabradine starts with the letter IV. Okay, so visual abnormalities. Okay, so I starting with the letter I, right? I. Visual abnormalities in the eye. There will be visual abnormalities. IVA. You can remember like that. In the eye, there can be visual abnormalities. Ivabradine can cause visual abnormalities. Remember. It's an important side effect. So with this, SA node action potential is completed. Means half of the nonsense topic is completed. Half of the boring topic is completed. Okay. Now, later on, we have to discuss about ventricular action potential, ventricular myocyte action potential. Okay. So draw it fresh in the new slide. Take a new white page. Draw this diagram. Here is what? This is the ventricular myocyte. Not SA node, not AV node. This is ventricle. This is the ventricular muscle cell. Ventricular myocyte. Ventricular myocyte. Okay. Now, see, it cannot generate any action potential by itself. By itself, it cannot generate action potential. Okay. So, first it is at resting. What is the resting membrane potential? So, the resting membrane potential is at minus 90 millivolts. It is at resting. Okay. So, it's minus 90 millivolts. Minus 90 millivolts. That is the resting membrane potential. Resting membrane potential. Okay. Now, see, when the electrical fluctuation or this electrical impulse, okay, electrical impulse, when it is coming from the Purkinje fibers, now that electricity is coming and touching the myocardial cells. immediately do you know what happens? Immediately on the cell, these channels are going to get open. Which channels? Look here. These channels are going to open. What are these channels? These are sodium channels. These are sodium channels, voltage gated. These are voltage gated sodium channels. So immediately sodium, lots and lots of sodium will start to come into the cell. Now, as the positive charges are coming into the cell, look, as the positive charges are coming into the cell, the resting membrane potential immediately will jump towards the positivity. Okay, towards the positivity. Now, maybe it is plus 55 millivolts coming to the positivity. Okay, so this phase, this blue color phase is called as depolarization. Okay, depolarization. Depolarization is due to, see here the depolarization is due to sodium. Here the depolarization is due to sodium. But if you look at the SA node action potential, the depolarization is due to calcium. Okay, SA node में depolarization is due to calcium, and in ventricular myocyte, the depolarization is due to sodium influx. Depolarization is called as phase 0. Phase 0. Here the resting membrane potential, here it is called as phase 4. Resting membrane potential is called as a phase 4. Okay, the same thing I am showing here. The resting membrane potential is phase 4. Later on, the depolarization, this depolarization is phase 0, right? Phase 0. Depolarization due to sodium influx. Okay. Okay. Next, what happens? Next, what happens? Look, next what happens is, once the positive potentials are attained, once the positivity is attained, now here the potassium channels will open, delayed rectifier potassium channels will open. So potassium starts to go out. Potassium is going out. As the potassium is going out, repolarization started. See, repolarization started. Okay, decreasing. Again, the voltage is decreasing. So this is what? This is phase 1. Phase 1 is what? Early repolarization. Early repolarization or initial repolarization. Due to what? Due to potassium efflux. Due to potassium efflux. Potassium is going out. Let me show you the same thing here. Wait 1 minute. Look here. See, as the potassium is going out, see the voltage is coming down. It's the phase 1 due to potassium efflux. Phase 1 potassium efflux. Potassium will go out. So potassium is going down. Okay. But this is the question which was asked in the recent exam. Recent FMG exams is the question which was asked. Now, suddenly what happens is, now calcium channels will open. Okay, now the L-type calcium channels will open. Now, when the L-type calcium channels are opened, calcium is coming in. Calcium is coming into the cell. So at the same time, look, at the same time, potassium is going out and calcium is coming in. Potassium is going on, calcium is coming in. So positive charges are going out, at the same time positive charges are coming in. So that's why the voltage is going to be flat. At the same time, potassium is going out and calcium is coming into the cell. Calcium is coming into the cell. So this is called as, this phase is called as plateau. What is this phase called as? Plateau or phase 2. Phase 2 or plateau. What is happening during the plateau? Potassium is going out, and the same time calcium is coming into the myocardial cells. Okay, that calcium can be helping in the, like, the contraction and all these purposes. So anyway, so plateau or phase 2. Next, what is happening? After some time, once the calcium comes into the cell, these calcium channels will close. The calcium channels will close. Only potassium is going out. Only potassium is going out. So again, the voltage will come back to minus 90. Okay, again it drops. So this is due to same potassium efflux. That is repolarization. That is phase 3 repolarization. So this is late repolarization. This is early repolarization. Here, this is early repolarization. This is late or delayed repolarization. Okay. So I know I'm taking time because these are the important areas. Okay, we can't hurry in these areas. These are the important areas. You should know about it. That's it. No doubt in that. So how many phases are there? Let me highlight the phases. Phase 4 resting membrane potential. Phase 0 depolarization. phase 1 early repolarization, phase 2 plateau, and phase 3 that is repolarization. These are the phases. Same things here I have shown. Phase 2 that is plateau, calcium influx and potassium outflux or efflux. Okay, phase 2. After phase 2, what is there? Next, phase 3 that is repolarization due to potassium efflux. Efflux means going out, potassium out. So that's it. Ventricular myocyte action potential is also completed. Okay, ventricular myocyte action potentials are completed. Now let's fill up the table one by one. In 1 minute, we have to complete the table. Come to the slide table. Sir, phase 4. What is phase 4? Phase 4 is resting membrane potential. Who is responsible for resting membrane potential? See, resting membrane potential, resting membrane potential, I have said, the beginning, I have said resting membrane potentials are because of two things, potassium efflux and sodium potassium ATPases. Sodium potassium ATPases. Don't don't confuse. In the beginning, I have said, see, the resting membrane potential everywhere. Here minus 60. Resting membrane potential is due to potassium efflux and sodium potassium pump. Here also, same in our ventricular myocyte also, same thing. Okay, resting membrane potential is due to potassium efflux and sodium potassium ATPase. How much is the resting membrane potential here? Minus 90 millivolts. This is due to these events, potassium efflux. Now, what is happening during phase 0? Rapid depolarization, phase 0, rapid depolarization due to sodium influx. Phase 1, that is early repolarization or initial repolarization due to potassium efflux. Phase 1, that is early repolarization or initial repolarization. Phase 2 is plateau. Plateau is due to potassium efflux and calcium influx. Phase 3, late repolarization, is also due to potassium efflux. So potassium efflux is happening everywhere. Okay, potassium efflux is happening everywhere, but where it is not happening, potassium efflux is not happening during phase 0 depolarization. Okay, that's the point. So with this, ventricular myocyte action potential is also completed. Ventricular myocyte action potential is also completed. Okay, done. So shall I go forward? Take a deep breath, sir. Everyone take a deep breath. Do you have any doubts? Do you have any doubts? I will revise. Yeah, increase. Yeah, otherwise you are asking increase in the heart rate is due to increase in the slope of the P potential. Yes, you are true. And vice versa. Yes, exactly. Okay. So now let me see who can answer. In your exams, this one question is going to be there. Imagine this is the question. The resting membrane potential of SA node or the resting membrane potential of the ventricular myocyte is due to resting membrane potential of SA node or the ventricular myocyte doesn't matter, is due to resting membrane potential is maintained by. Try to answer. Resting membrane potentials are always due to potassium efflux and sodium potassium ATPase. These two things, potassium channels and sodium potassium ATPases, they are maintaining the resting membrane potential. Okay, they are maintaining the resting membrane potential. Okay, remember that one thing. Next, can you tell me what is the resting membrane potential of the ventricular myocyte? Resting membrane potential of the ventricular myocyte minus 90. Resting membrane potential of the SA node. SA node minus 60. Okay. Now the depolarization in SA node depolarization is due to which channels? Depolarization in SA node is due to which channels? Think and tell. Think. SA node. Depolarization is due to calcium, L-type calcium channels. Okay, L-type calcium channels. Don't confuse, buddies. Okay, this is SA node. Okay, so this depolarization is due to calcium, L-type calcium channels I have discussed. Okay, so this one, L-type calcium channels. Depolarization. Okay, pink, pink, see, pink, pink. Next, the depolarization in ventricular myocyte. The depolarization in ventricular myocyte, this depolarization, that is the membrane is getting positive, the membrane voltage is getting positive. The depolarization is due to sodium influx. That's a big difference, big difference. There it is calcium, here it is sodium. There it is calcium, here it is sodium. Okay, so depolarization in ventricular myocyte is due to sodium influx. Okay, now tell me, sir, repolarization, repolarization in both SA node as well as ventricular myocyte. In both SA node as well as ventricular myocyte is due to repolarization is always due to potassium efflux. Okay, potassium efflux. Okay. Now, what about the calcium status during plateau stage? What about the calcium? Is it influx or efflux? During plateau stage. What about the calcium? Calcium influx. Calcium influx and potassium efflux. Okay. So these are the things which I want you to know. Okay. Final thing. What is the first? I'm talking about the SA node. Right now, I'm talking about the SA node or the pacemaker. What is the first event to occur during the generation of action potential? What is the first event to occur? I said, a pre-potential. What is the first event to occur? Pre-potential is going to happen, but in the pre-potential, what is the first event? Potassium efflux decreases. Potassium efflux decreases. Right? Potassium efflux decreases. Potassium channels will close. Potassium efflux decreases. That's the first event. Okay. So done. So here I have discussed. So in the pre-potential, what is the first event that occurs? Potassium efflux decreases. Potassium will stop going out. Potassium will stop going out. So done. Okay. Now after this, little integration. Okay, little integration with the pharma. Okay. So right now we have discussed about the action potential graphs, right? These are the action potential graphs. Guys, by using your beautiful eyes, tell me, what is this action potential graph? Is it the action potential graph of SA node, or is it the action potential graph of ventricular myocyte? Tell me. Resting membrane potential, depolarization, plateau and repolarization. So what is it? This is the action potential curve or graph of ventricular myocyte. Okay. Now, even though it takes some time, but this is worth knowing. Okay, for your FMG exam. Okay. Now, first, the topic which I'm going to discuss here is anti-arrhythmic agents. Means whenever there are arrhythmias, you can use these drugs. Okay. So they are anti-arrhythmic drugs. They decrease the arrhythmias. So what is the classification that we are going to discuss here is called as the Vaughan-Williams classification. Okay. Vaughan-Williams classification. According to him, there are 5 classes of anti-arrhythmic drugs. Okay, 5 classes of anti-arrhythmic drugs. Here I'm going to discuss about the 4 classes. There are 5 types of anti-arrhythmic drugs. So what is the first class? Class 1. Class 1 are called as sodium channel blocker. They block the sodium channels. Okay, in ventricular myocyte, in the ventricular myocyte, you know, sodium channels are responsible for depolarization. Okay, so class 1 are all sodium channel blocker. So that's why, look, black color is normal. Here, whatever I'm showing in the black color, that is normal. But when you use this class 1 drugs, what is happening? See now, what is happening to the depolarization? Now it is taking long time. Now it is taking more time. It's not sharp like this. Now it is taking long time. Okay, so slope is decreasing. See, slope is decreasing, falling. So now it takes a lot of time. When it is taking a lot of time, the number of action potentials produced are also going to be less. So something like that. Okay, heart rate decreases, like, you know, contractility also going to come down, all these things. Okay, so now what I'm trying to put into your mind is, sir, first class 1 drugs are sodium channel blockers. What they are doing, they are affecting which phase? Now tell me, they are affecting which phase? Sir, the depolarization phase 0, the phase 0 is getting affected. They are blocking the sodium channels. Now it's taking a lot of time. And not only that, even see, the repolarization is also taking a lot of time. Now black color is normal. Okay, black color is normal. This is the normal repolarization. But here repolarization is also taking a lot of time, which means not only sodium channels are getting blocked, They are also potassium channel blockers. Okay, class 1. Okay, class 1 में there is a subtype, class 1A. Class 1 में class 1A subtype. This is a class 1A subtype. Examples are procainamide, quinidine. At least these two, procainamide and quinidine. What they are doing, they are blocking sodium channels as well as potassium channels. Okay, see, both blocks sodium as well as potassium channels. So because of this, what happened to the action potential duration? The action potential duration is increasing starting from here and going till here. Action potential duration is increased. Okay, so increases the action potential. Remember, lifelong one point. Remember, whoever blocks the potassium channel, whoever, whatsoever the drug, okay, whoever blocks the potassium channel, in ECG, I'm talking about the ECG. In ECG, the QT interval is going to be prolonged. There is prolongation of, okay, prolongation of QT interval. So these drugs, of course, yeah, they are antiarrhythmic drugs, but even sometime they can lead to arrhythmias like torsades. Okay, so they can, yes, of course, they're antiarrhythmic drugs, but they are also having some side effects. They can also lead to arrhythmia. Which arrhythmia? Torsades. Okay, torsades. Because of prolongation of QT interval. When the QT interval is prolonged, that causes torsades. So now tell me, guys, repeat after me. Sir, what is the classification that is used? Vaughan-Williams classification. According to him, 5 classes of drugs are there. First class one is sodium channel blockers. Sodium channel blockers में there are 3 subclasses, 1A, 1B, 1C. 1A drugs are procainamide, quinidine. They blocks both sodium channels as well as potassium channels, because of which the action potential duration is increasing. It's taking a lot of time. Okay, so action potential duration increases and QT prolongation occurs that can lead to torsades. Done. So class 1B. Class 1B, one important drug at least which I want you to know is lidocaine. If you can remember, also remember phenytoin. Okay, phenytoin and lidocaine. What is happening? See, here also, look, they are also sodium channel blockers, no doubt. They are all sodium channel blockers. So little, like a weak sodium channel blocking activity. Okay, the slope is little decreased, but look at the repolarization. Repolarization is completing quickly. Repolarization is completing quickly. Okay, so what happened to the action potential duration? The action potential duration have actually decreased. Okay, these drugs are actually decreasing the action potential duration. Okay, so what exactly I want you to know is the repolarization is happening quickly. Means these drugs are opening potassium channels. They are potassium channel openers. They are blocking the sodium channel. They are blocking the sodium channel, but opening the potassium channel. Okay, class 1B drugs are lidocaine and phenytoin. What they do? Right, they block sodium channel, but opens, these drugs opens potassium channels. So what happened to the repolarization? Quickly completing. Repolarization is completing quickly, because of which action potential duration is decreased. Okay, action potential duration is decreased. Okay, so such a type of drugs, these drugs can be used in treating certain type of arrhythmias. Okay, for example, lidocaine. Now this lidocaine, star mark. Lidocaine is a drug of choice for post-MI ventricular tachycardia. Okay, post-MI ventricular tachycardia. See, post-MI means after MI, means after MI. After developing myocardial infarction, some people will develop ventricular tachycardia. Okay, after developing the myocardial infarction, they will develop which arrhythmia? Ventricular tachycardia. So how to treat this ventricular tachycardia? Post-MI ventricular tachycardia, the drug of choice is lidocaine. Lidocaine is class 1B antiarrhythmic drug. Okay, it's a sodium channel blocker, but the potassium channel opener. Okay. Next, class 1C. Class 1C, examples which I want you to know is flecainide. Okay, flecainide and propafenone. Flecainide and propafenone. What they will do? Look here carefully what they are doing. Sir, yeah, they are the sodium channel blockers. So depolarization is getting affected. Yeah, sodium channel blocker, sodium channel block ho gaya. And what about the repolarization? Look about the repolarization. There is no effect on repolarization. So there is no effect on potassium channels. No effect on potassium channels. No effect on potassium channels. Okay. Now, important points which I want you to know is, sir, flecainide, star mark, propafenone, star mark. In which conditions we can use these drugs to treat which arrhythmias? See, flecainide is the drug of choice for prophylaxis, prevention of arrhythmias in WPW syndrome. Okay, flecainide is a drug of choice for the prophylaxis of WPW syndrome to prevent the arrhythmias in WPW syndrome. Flecainide. Tell me what is flecainide? It is a class 1C antiarrhythmic drug. Class 1C antiarrhythmic drug. Okay. Class 1C antiarrhythmic drug. Now, in WPW syndrome, I hope you already know what is WPW syndrome. Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. Okay, for some students who doesn't know, WPW means Wolff-Parkinson-White syndrome. Okay, Wolff-Parkinson-White syndrome. Now, in Wolff-Parkinson-White syndrome, what happens is there is this abnormal connection between atria and ventricles. Okay, there is this abnormal conduction pathway, aberrant conduction pathway is going to be there. Abnormal illegal connection is going to be there. Okay, so that is responsible for arrhythmias. Okay, it will cause unnecessary arrhythmias. So now in WPW syndrome, look carefully. If right now, if there is an acute episode, right now the patient is throwing arrhythmias, right now the patient is having arrhythmias, what is the drug of choice? IV procainamide, intravenously give the procainamide. Now where we have discussed about the procainamide? Sir, procainamide, here we have discussed. See, class 1A antiarrhythmic drug. So procainamide is the drug of choice for the acute episode of WPW syndrome. For prophylaxis, use flecainide. Prophylaxis ke liye use flecainide. And right now, if you have an acute episode, right now the patient is throwing arrhythmias, use procainamide. Okay, but ultimately this is the MCQ which was tested many times in the exam, NEET PG exams, many times this was asked, what is the treatment of choice? How to treat WPW syndrome? Complete treatment of choice is radio frequency ablation of that aberrant conduction pathway. Okay, radio frequency, totally burn this. Okay, totally fry this. Okay, so totally remove or burn that pathway, aberrant conduction pathway. That is called as a radio frequency ablation of the aberrant conduction pathway. This aberrant conduction pathway, there is a name also. This is called as a bundle of Kent. Okay, this is called as bundle of Kent, K-E-N-T, bundle of Kent. Okay, bundle of Kent. That aberrant conduction pathway is called as a bundle of Kent. So with this, we have completed the Vaughan-Williams classification of class 1. Class 1 includes 1A, 1B, 1C. Okay, 1A, 1B, 1C. Now, they will ask you something like this. Which of the following antiarrhythmic drugs? Look, which of the following antiarrhythmic drugs causes torsades de pointes? Tell me. Which of the following antiarrhythmic drugs causes torsades de pointes? Can you tell me? Buddies, can you tell me? Which of the following antiarrhythmic drugs causes torsades de pointes? Don't say class 1. Specific, be specific. Class 1A. Class 1A. Okay? Believe me, that's a question which was tested. Class 1A. Right? Next, which of the following antiarrhythmic drugs decreases the action potential duration? Which class of antiarrhythmic drugs decreases the action potential duration? Decreases the action potential duration. Okay, it's class 1B. Class 1B. What is the drug of choice for post-MI ventricular tachycardia? Post-MI ventricular tachycardia. Post-MI, the word is important. Post-MI ventricular tachycardia, lidocaine. Okay. IV procainamide. Sorry, not IV, just procainamide. Procainamide is which class of antiarrhythmic drug? Procainamide is which class of antiarrhythmic drug? Flecainide is 1C, not 3. It's 1C. Okay, 1C. Lidocaine is 1B. Okay, done. Next, chalo. Let's discuss about this is the main important thing. Class 1 is the most important thing, and class 3. Next, class 3 is important thing. Okay, now let's start with the class 2. Simple. This is one single slide. Simple. Class 2 are the beta blockers. Okay, the beta receptors. Beta are the sympathetic receptors on the heart. Beta receptors are the sympathetic receptors on the heart. So we are going to block the sympathetic receptors. Okay, so class 2 type of drugs are beta blockers. Example, propranolol, esmolol. Okay, so where they are affecting? They are affecting the SA node. So that's why, see, this is the action potential of the SA node, right? This is not ventricular myocyte action potential. This is the Action potential of the SA node. So now see it is taking this dotted line. Black color is normal. Black color is normal. So now it is taking lot of time, say, for the pre-potential. For pre-potential ke liye, it's taking lot of time. Okay. So time duration is increased. Okay. So you are blocking the sympathetic receptors. When you block the sympathetic receptors, now pre-potential is taking lot of time. Okay. That's the point which I want you to know. So one thing, important point is esmolol. Esmolol is a little important. Okay. Esmolol, what is important point? Esmolol is used for rate control in atrial fibrillation. This is the medicine question. If the patient is having atrial fibrillation, you have to control rate and rhythm. You have to control rate and rhythm. Rate control in atrial fibrillation is done with the help of esmolol. Okay, done. And there is one more drug also. Later I will tell you. Say rate control in atrial fibrillation can also done with a drug called as verapamil. Okay, but we'll discuss it later. So done. Class 2 completed. Next, class 3. Class 3 are the potassium channel blockers. Okay, class 3 are what? Potassium channel blockers. So as the potassium, I have said in the beginning, whoever blocks the potassium channels, that will cause QT prolongation. That will lead to torsades. Okay, this is a super high yielding point. So class 3 are what? Class 3 are potassium channel blockers. So what they will do? They increase the QT prolongation. When the QT prolongation occurs, what they will do? They will cause torsade bonds. So that's why I say potassium channels block hone to what is happening? Repolarization is getting affected, which means right phase 3 is getting affected. That is prolonged repolarization. So action potential duration is increasing. So that's why I say here action potential duration increases. QT prolongation, TDP. Now important drugs which you need to know: amiodarone and sotalol. Okay. So what is the important point about the amiodarone? It's a drug of choice for ventricular tachycardia. It's a stable VT. Alright guys, never ever forget post-MI ventricular tachycardia. Is lidocaine. Okay. Post-MI ventricular tachycardia is lidocaine. But this is normal ventricular tachycardia, stable ventricular tachycardia. For example, like monomorphic ventricular tachycardia. Stable. The patient is stable. Okay. Stable ventricular tachycardia, drug of choice is amiodarone. Amiodarone is what? It's a class 3 antiarrhythmic drug. And the same amiodarone will also be used for the prevention of atrial fibrillation. Prevention means prophylaxis. Prevention of atrial fibrillation. What is the drug that is used? Amiodarone. Now, one more important point about the amiodarone, which is very important, is it have all class properties. All class means class 1, class 2, class 3, class 4. All class properties means it's a wide. Means it's having wide range of properties. Means it can block sodium channels. It can block beta block. It's a beta blocker. It is a potassium channel blocker, and it also have the calcium channel blocking properties. They have all the properties, but mainly it is class 3. Mainly it is a potassium channel blocker. So all class properties. It have all class properties. All class properties are there. Okay. Again, I'm telling you, lidocaine is used for post-MI ventricular tachycardia. Lidocaine. But drug of choice for stable ventricular tachycardia is amiodarone. Done. Now, next sotalol. See, it's the lol. Lol means beta blocker, right? Sotalol means beta blocker. Okay. But beta blockers are class 2. Look, so that's why here I have written sotalol arise may. This question will be repeatedly tested. Okay, even Khalil sir, whenever he's taking the classes, he's going to repeatedly ask this thing. Okay, so sotalol is most of the students will think it's a beta blocker, so they will answer it as class 2. No, it have both class 3 as well as class 2 properties. Mainly it is a class 3 because it's mainly a potassium channel blocker. So sotalol have both class 3 as well as class 2. Both it's a beta blocker as well as potassium channel blocker. Okay, and ebutilide. What's the important point about the ebutilide? It is used for rhythm control. Esmolol, rate control. Ebutilide, rhythm control. That's it. Rhythm control in atrial fibrillation. Rate control, esmolol. Rhythm control, ebutilide. Prevention of atrial fibrillation, amiodarone. So all these are previously tested MCQs. Okay. Even if one question comes, that's integration from pharmacology, you got one question. Okay, that's good. Even if one question comes from this slide, that's worth knowing. Okay, so class 4, last thing, class 4 are the calcium channel blockers. Class 4 are the calcium channel blockers. Only one point which I want you to know is verapamil. Okay, calcium channel blockers, they act on SA node as well as AV node. They act on SA node and AV node. Calcium channel blockers, verapamil. Okay, so one point which I want you to know is verapamil. It is used in controlling the rate control of atrial fibrillation. Esmolol rate control, verapamil also rate control. That's it. If you know this much, that is more than enough. Okay, so now finally, now I'm asking you, finally try to answer this one question. Finally, one question you just try to answer me. Which of the following antiarrhythmic drug, which classes of the antiarrhythmic drugs causes torsades? Which classes of the antiarrhythmic drugs causes torsades? This is the question. 1A as well as 3. You say 1A as well as 3. Class 1A, yes, Subhitra, Jyothi, yes, you're all true. 1A, 1C, yeah, true. Okay, class 1A as well as 3. Look, okay, here I have discussed class 3 antiarrhythmic drugs are potassium channel blockers. Whoever blocks the potassium channels on the heart. Okay, potassium channel blockers. See torsades. Also 1A I have discussed. 1A causes torsades. Okay, so same question. QT prolongation is caused by 1A as well as class 3. 1A as well as class 3. Okay. Now, questions. Which of the following classes of antiarrhythmic drugs? Which of the classes of antiarrhythmic drugs blocks potassium channels? Tell me. Which classes of antiarrhythmic drugs blocks potassium channels? Think and tell. Potassium channels are blocked by. Think. Potassium channel blockers. Class 1A and 3. Same thing. Class 1A and 3. Class 1A, they are sodium channel blockers as well as potassium channel blockers. And class 3. Okay. Class 1A and class 3. Class 1A and class 3. Okay. Next question. Sir, which of the which antiarrhythmic drug is a drug of choice for stable VT? Stable VT के लिए, what is the drug of choice? Just write the short form. Stable ventricular tachycardia. Sir, which beta blocker is having both class 2 as well as class 3 properties? Which beta blocker is having both class 2 as well as class 3 properties? Sotalol. Sir, which beta blocker is used in the treatment or is used as a drug of choice for rate control in atrial fibrillation? Rate control. Which beta blocker? Esmolol. Which calcium channel blocker? Verapamil. Verapamil is also used. Okay, verapamil. Okay. Which of the following antiarrhythmic drug is used for the prophylaxis of WPW syndrome? Prophylaxis of WPW syndrome. Wolff-Parkinson-White syndrome. Fleckenide. Excellent. Okay. Which class of antiarrhythmic drug is used for acute attack of WPW syndrome? Acute episode of WPW syndrome or arrhythmias, acute episode of arrhythmias in WPW syndrome. IV procainamide. Which class you have to tell me? Class 1A. IV procainamide. Treatment of choice is radio frequency ablation. So that's it. This is the boring topic. All boring topic is done. Done. Okay, boring topic all completed. Now we can go into the concepts. From here we can go into the concept. So we have started the class at 9 o'clock, right? Now it's 11 o'clock. Now do you want a 5 minutes break? Do you want to have a 5 minutes break? Now we can go into the cardio, the main concepts, the cardiac cycle, heart sounds, murmur, JVPs thing. Look. Glory, you are confused. See, for acute attack, for acute episode of WPW syndrome, what is the drug of choice? IV procainamide. Where is IV procainamide? Look, IV procainamide is class 1A. Okay, procainamide is class 1A. Okay, you understood? So if there is right now acute attack, give procainamide. But procainamide is 1A. Okay. For prevention, you can use flecainide. Flecainide is class 1C. Hope you understand, Glory. Glory, okay? So take a 5-minute break. Now the time is 11:05, right? Now 5-minute break till 11:10. Okay, 11:10, 5 minutes break. Okay. Hello guys, can you see me? Hello guys, can you see me? Yeah. So let's continue. Guys, now we are going to start with the topic that's the cardiac cycle. Okay, cardiac cycle. Now, see, if you understand cardiac cycle, here I have told you what are the important topics. If you understand cardiac cycle, only then you can understand the heart sounds. Only then you can understand the murmurs. Without understanding cardiac cycle, forget about heart sounds, forget about murmurs. Without understanding cardiac cycle, you can't understand left ventricular pressure volume loops. Without cardiac cycle, you can't understand JVP. For everything, the base topic is cardiac cycle. This is the base. Okay. So first, let's concentrate on the cardiac cycle for the next half an hour. It takes half an hour time, but worth knowing. Worth knowing. Okay. Chalo, let's begin. What are the phases of the cardiac cycle? Cardiac cycle mein there are 5 phases. Cardiac cycle mein mainly there are 2 phases, systole as well as diastole. Systole and diastole of what? Systole and diastole of ventricles. In cardiac cycle, we are going to mainly talk about the ventricles. It's a systole of ventricles and diastole of ventricles. Means systole means contraction and diastole means relaxation. Okay, so I'm mainly talking about the ventricles. I'm not talking about the atria. I'm not talking about the atria. This is what you need to know. Cardiac cycle mein there is systole, there is diastole. Okay, systole mein how many subphases are there? 3 subphases: isovolumetric contraction, rapid ejection phase, slow ejection phase. And diastole mein how many subphases are there? Protodiastole, you know it, IVR, isovolumetric relaxation, rapid ventricular filling, slow filling, and atrial contraction. Now look. Sorry. Atrial contraction. See, atrial contraction is a phase of diastole. Okay. When atria is contracting, when the ventricles are relaxed. When the ventricles are in relaxer phase, atria is contraction. So contracting. So atrial contraction is a phase of ventricular diastole. Okay. So totally how many phases are there? 8 phases are there. Okay, 8 subphases I should say. Okay. Systole mein 3 subphases and diastole mein 5 subphases. Totally 8 phases are there. Now it's a cardiac cycle, right? It's a cycle. Cycle means what? Same events are going to occur again and again. Same events will occur again and again. Means wherever I start, the same events will occur again and again. Okay. For example, if I start with atrial contraction, for easy understanding purpose, I will start with atrial contraction. After atrial contraction, what is the next phase? After atrial contraction, the next phase is isovolumetric contraction again. After 8, again one will come. After that, rapid ejection phase. After that, slow ejection phase. After slow ejection phase, what is the next phase? Protodiastole. Something like that. So for better understanding purpose, let me begin with atrial contraction. Phase 8. First atria are contracting. So directly come to this slide. The slide where this timeline graph is there. This timeline graph is there. This timeline. So atrial contraction. Atrial systolar contraction. Okay. Now, first of all, before going into the topic, atrial contraction, I want you to know the simple diagram. Don't write anything. First look at this diagram. Sir, A hai aapka heart and 4 chambers are there. 4 chambers are there. What are they? Right atria, right ventricle, left atria, left ventricle. Now, what is this wall which is present over here? Most of the student knows, but for some students, I'm telling, what is the wall that is present here between right atria and right ventricle? What is this wall? This is the tricuspid wall. What is this wall? This is the mitral wall. Okay. Now, can you tell me what is this blood vessel that is coming out of the left ventricle? What is this blood vessel that will come out of the left ventricle? So this blood vessel is aorta. Aorta. And what is this wall which is present over here? This is aortic wall. Okay. And what is this blood vessel that is coming out of the right ventricle? What is this blood vessel? Can you tell me what is this blood vessel? This one. This is pulmonary trunk. Or pulmonary, you can say pulmonary artery, you can, for easy understanding purpose, pulmonary trunk. Later, pulmonary trunk divides into pulmonary arteries. Okay. Now, what is this wall, which I am showing here? What is this wall? This is pulmonary wall. Pulmonary wall. Okay, on one side aortic wall, on the other side pulmonary wall. Both these two walls are called as semi-lunar valves. Okay, semi-lunar valves. Okay. Now this is the basic thing which I want you to know for some student who doesn't know. Now, first let's start from where? First, let's start with the atrial systole. First, the atria are contracting. See, that's why here in the atria, I am keeping the plus symbol. Wherever I use the plus symbol means contraction. When the atria is contracting, please tell me. Look here, when the atria is contracting, what is the status of these valves? This mitral valve and tricuspid valve, are they open or closed? They are in open state. They are in open state. They are already in open state. Okay. Now, what happens when the atria is contracting? 30% of the blood is coming into the ventricles. How much is coming? 30%. Okay. But already 70% is already there in the ventricles. From where the 70% came, I will explain you later. Okay. So, when the atria is contracting, how much blood is coming into the ventricles? 30%. Already 70% blood is there in the ventricles. Already it is there. So 30 plus 70, 100% completed. 100% filling completed. So what are the important points? Atrial systole. It contributes how much percent filling of the ventricles? 30%. When the atria is contracting, that causes S4 heart sound. Okay, that causes S4 heart sound. So usually it is not heard. Usually it is not heard until unless if there is some pathological condition. So S4 heart sound is heard during which phase? S4 heart sound is heard during atrial contraction. Atrial contraction. Okay. Right. So here look, this atrial contraction, tell me, atrial contraction, it is the last phase, right? It is the last phase. Diastole is the last phase, atrial contraction. So that's why in our timeline diagram also, look, in our timeline diagram also, here it's the diastole, here it's the systole. In diastole, what is the last phase? See, atrial systole is the last phase. This is what I want you to know. Atrial systole is the last phase. So during atrial systole, which heart sound is heard? S4 heart sound is heard. Okay, that sound, like this is the sound. Okay, so here this pink color thing, which heart sound? S4. Done. Now my question to you, this is the kind of question that will come in your exam. How much percentage of the ventricles are filled actively? How much percentage of the ventricles are filled actively? Active means by using contraction, by using muscle contraction, by using ATP. How much percent of the ventricles are filling actively? 30%. This is active. Okay, because of the atrial contraction, 30% of the ventricles will fill with the blood. So, my dear students, use your brain and tell me. After atrial contraction, ho gaya, tick. Now, after atrial contraction, what is the next phase? What is the next phase? Next, we are entering into systole. Ventricles are filled. Ventricles are 100% filled now. Now, ventricles have to contract. So, the next phase is isovolumetric contraction. Isovolumetric contraction. So, now come to this slide. Okay, next slide. Next slide, this one. First phase, that is isovolumetric contraction. Okay. Now, look. See how much percentage of the blood is there in the ventricle? 100% blood is there. Okay, 100% the ventricles are filled. 100% ventricles are filled. 100% means how much, sir? 100% means how much? 100% means 120 to 140 ml. Here 120 ml, here 120 ml, or you can say 140 ml. Okay, 120 to 140 ml of blood is there in the ventricles. Right now, how much blood is there in the ventricles? 120 to 140 ml. So this blood is called as a preload. Okay, the blood, that 120 to 140 ml of blood which is there in the ventricles, that is called as a preload or end diastolic volume. Okay, end diastolic volume value how much? 120 to 140. Here 120, and this side also 120. Both sides 120, 120. Okay, now what do you think should happen? What do you think should happen? Here 120 ml blood is there. Here you also 120 ml blood is there. Okay, 120 ml blood is there. Okay. Now, what should happen? The ventricle have to contract. See, that's why the plus symbols here. The ventricles have to contract and push the blood where? Push the blood into aorta and this side it have to push the blood into pulmonary trunk. Okay, so here is aorta. This is aorta. Now, question is, in aorta, the baseline pressure, the baseline pressure is 80 mmHg. Here the pressure is 80 mmHg. I'm mainly going to talk about the this side, left side. Whatever the events happen on this side, the same events happen on the right side also. Same events. Okay, so that's why I'm talking on this side. What is the pressure in the aorta? 80 mmHg. Okay, and what is the pressure in the ventricle now here? Maybe the pressure in the ventricle is 5 mmHg. 5 mmHg. Pressure is 5 mmHg. Now, in order to open this aortic valve, okay, now you have to open this aortic valve to pump the blood. In order to open the aortic valve, the ventricle have to contract. The ventricle have to contract, right? Now the pressure from the ventricles, it have to increase from 5 to, it have to increase to 81. The pressure have to increase to 81, so that aortic valve will open and the blood will go into aorta. The blood will go into aorta. Okay. Now, buddies, just look, whenever or wherever you see the word this isovolumetric, what is the meaning of isovolumetric? Iso means same. Volumetric means what? Volume. Okay, same volume. Isovolumetric. What is that same volume? Same volume means, see, when the ventricle started to contract, to prevent the regurgitation of the blood, should not occur. To prevent the regurgitation of blood, immediately which valve closed? The mitral valve closed, as well as tricuspid valve is also closed. Both the mitral valve as well as tricuspid valve are closed. Okay. Already aortic valve is in closed state. Already these are in closed state, no doubt. But right now, for the first time, the mitral valve and tricuspid valve, they are closed. When? During the beginning of the isovolumetric contraction, the starting point, in the beginning of the isovolumetric contraction, immediately mitral valve closed, tricuspid valve closed, creating the sound that is S1 heart sound. Okay. So now you know S4 heart sound is heard during atrial contraction. S1 heart sound is heard during isovolumetric contraction, the beginning of the isovolumetric contraction. Now tell me, in the isovolumetric contraction phase, what is the status of all the valves? What is the status of all the valves? Sir, all valves are in closed state. That's the key point which I want you to know. Wherever you see the word isovolumetric, all valves are closed. All valves are closed, which means nothing is coming into the ventricles, nothing is coming in, and nothing is going out. Nothing is coming in, nothing is going out. Okay. So that's why the same volume here, how much is there? Same 120 is there. Nothing is getting added and nothing is leaving. So that's why isovolumetric contraction. Okay. So let's see the points one by one. Whatever I have written, it's already there in your book. Just go through one by one. What is the purpose of this phase? Purpose kya hai this phase ka? The purpose of this phase is to increase the pressure. Here the baseline pressure is 5. The pressure have to increase up till 81, so that this valve will open and the blood will go into aorta. That's the purpose, right? So the purpose of this phase is to open aortic valve on left side and pulmonic valve on right side. Okay. Now, next what happens? Ventricle started to contract. The rise in ventricular pressure, see, what it is doing, it causes the mitral valve and tricuspid valve to close. It's causing to close these valves, resulting in first heart sound, S1 completed. Okay. Now, once the pressure rises above 80 mmHg, now here the pressure is rating above 80 mmHg, that is 81. Immediately what will happen? Aortic valve will open. Once the aortic valve is opened, isovolumetric contraction is completed, because now the blood is going out. So phase is completed with the opening of aortic valve. With the opening of aortic valve, this phase is going to complete. Here, with the opening of pulmonic valve, and here the opening of aortic valve, the isovolumetric contraction phase is completed. See, that's why once the pressure rises above 80 mmHg, the aortic valve opens. Okay, you know it. Now this phase, see, this phase ends by isovolumetric contraction. It ends. What is the end event? It's the opening of aortic and pulmonic valves, respectively. Okay. Now, once these valves are opened, listen carefully, guys. The moment these valves are opened,
that will cause a little heart sound. If this valve opens, that will create a heart sound called as ejection. The moment these valves open, there will be ejection of the blood that will create a sound called as ejection click. The moment these valves open, there will be ejection of the blood that will cause ejection click. So I can say with ejection click, the moment I hear ejection click, isovolumetric contraction is completed. The moment I hear ejection click, isovolumetric contraction is completed. Okay. So come to the timeline slide. Timeline slide. This one. Now look here carefully. Right now I'm talking about the systole. Ventricle is contracting, right? Yes, ventricle is contracting. Systole. Systole, what is the first phase? Look, what is the first phase in the systole? Isovolumetric contraction. That is the first phase. In the beginning of the isovolumetric contraction, what is the heart sound that is heard? Yes, one heart sound. That is due to closure of mitral valve and tricuspid valve. And at the end of the isovolumetric contraction, because of the opening of aortic valve and pulmonic valve, what is the heart sound that is heard? Ejection click. Okay. So isovolumetric contraction is a phase between, it's a phase between S1 and ejection click. Done. Okay. Now, my dear student, I am asking you one question. Okay. I am asking you one question. You should tell me, during isovolumetric contraction, how much ml of blood is there in the ventricles? How much ml of blood is there in the ventricles during isovolumetric contraction? Right, during isovolumetric contraction, all valves are closed. All valves are closed. Nothing is coming in, nothing is going out. Nothing is coming in, nothing is going out. All valves are closed. Then how much ml of blood is there in the ventricles? 120 to 140. Okay, 120 to 140. That is called as a preload or end diastolic volume. Preload and end diastolic volume. Now I am asking you, listen carefully. During isovolumetric contraction, is any blood going into ventricles? Is any blood going into ventricles? Any blood is going into ventricles? People will think isovolumetric contraction, ventricle is contracting. But any blood is going into ventricles? No blood is going into ventricles. Not even a single drop of blood is going into the ventricles. Yes, ventricle is contracting, but no blood is going out of the ventricles. Remember that point. Okay. So, done. Done. So, this is also completed. Isovolumetric contraction be okay. So, tick mark completed. Now, isovolumetric contraction. What are the next phases? Rapid ejection phase and slow ejection phase. Now, let's discuss about these two phases in one single slide. Okay. So now, see, what is this rapid ejection and slow ejection phase? Simple. 5 minutes. Look, now aortic valve opened, pulmonic valve opened. Both the sides, pulmonic valve opened, aortic valve opened. With the, but that's causing a sound. What is that sound? Ejection. Click. Look carefully here. Now, ventricle is not satisfied. The pressure generated 81 mmHg, for example, 81 mmHg pressure generated. Okay. And these valves are opened. The blood is going. But still ventricle is contracting. But still the ventricles are contracting and they are raising the pressure. See how much they are raising the pressure. The pressure is raising from 81 to 120. The pressure is raising from 81 to 120. The pressure is raising. As the pressure is raising, more blood will go into the aorta. More blood will go into the aorta. So, as the pressure is raising, more blood will go into aorta and pulmonary trunk. So that phase is called as rapid ejection phase because the pressure is increasing. Rapidly the blood is getting ejected. Rapidly the blood is getting ejected into the aorta. So that is rapid ejection phase. Okay. And after some time, the ventricular pressure decreases. Ventricle is not relaxing. Ventricle is not relaxing, but ventricular pressure decreases. Okay. It's generating less pressure. So the pressure from 120, it is decreasing to 80. So as the pressure is decreasing, less amount of blood will go. Less amount of blood will go. Okay. So that is called as a slow ejection phase. So rapid ejection phase is from 81 to 120. Slow ejection phase is from 120 to back to 80. Okay. So important point which I want you to know. Sir, more blood when it will go? More blood will go into the aorta during which phase? During rapid ejection phase. So that's the thing. During rapid ejection phase, the pressure is increasing from 120 to 81 to 120. So how much blood is going? 2/3 of the stroke volume. For the first time, you are hearing the word stroke volume. Stroke volume, see, out of 120. Okay. See, here we have kept 120. 120. That is end diastolic volume. How much will go into aorta? How much will go into the aorta is called as stroke volume with one heartbeat. One heartbeat. See, let me write here. What is stroke volume? SV, stroke volume. With one heartbeat, how much blood will go into aorta? With one heartbeat, how much blood goes into aorta? How much blood will go into the aorta? Out of that 120, 70 ml will go. So that is the stroke volume. Okay. Even in the 70 ml, maximum 2/3, even in that 70 ml, 2/3 will go during rapid ejection phase and 1/3 will go during slow ejection phase. So maximum stroke volume, 2/3 of the stroke volume will go into the aorta during rapid ejection phase and 1/3 will go during slow ejection phase. That's the question which was asked. Maximum stroke volume is ejected during which phase? That's the question in FMG exam. Maximum stroke volume is ejected during which phase? Rapid ejection phase. Now you understood? So the 3 events are completed. Isovolumetric contraction, rapid ejection phase, slow ejection phase. The same thing I'm going to show you in the timeline diagram. In the timeline diagram, say after isovolumetric contraction, what is there? After isovolumetric contraction, there is rapid ejection phase. Tell me what is the pressure? 81 to 120. How much stroke volume? 2/3 of stroke volume is ejected. After that, there is slow ejection phase. Slow ejection phase is from 120 back to 80. 120 back to 80. Okay. How much stroke volume is getting ejected? 1/3. 1/3 of the stroke volume is getting ejected. That's it. So with this, we have completed systole. Systole ho gaya. Okay. Is that clear? Want the clarity? Is that clear? Please confirm me, guys. Because this is the base topic. If you don't understand this, it will be a little problematic for other topics. Okay. Now you tell me. Come on, guys. Arre, systole ho gaya. Look at this. Systole khatam. Now after slow ejection phase, what is the next phase? What is the next phase after slow ejection phase? It's a diastole. It's a protodiastole. Okay. Come to the slide. Protodiastole. Kya hai? What is a protodiastole? Okay. Protodiastole. Protodiastole means it's a proto means very small phase. Okay, protodiastole. It's a very small phase. Proto means in the beginning of the diastole. Proto means in the beginning of the diastole. Okay. Now, what is the pressure here? Tell me what is the pressure here? 80. You know, during slow ejection phase, pressure from 120 came back to 80. Now ventricle is relaxing. Now I am starting the diastole. Now ventricle is relaxing. Now the pressure is going from 80 to 79. Only 1 mmHg drop in the pressure. 1 mmHg drop in the pressure. Now whenever there is 1 mmHg drop in the pressure, now you know what is the baseline pressure in the aorta? Always 80. That's the base pressure. Now the left ventricular pressure is becoming, the ventricular pressure is becoming less than the aortic pressure. Left ventricular is becoming less than the aortic pressure. So immediately what happens? To prevent the regurgitation of blood, because here is a higher pressure, here is a lower pressure. To prevent the regurgitation of blood, immediately what happens? See, on this side aortic valve closes, on this side pulmonic valve closes. Okay, so the closure of these valves now, is creating which heart sound? S2 heart sound. So now tell me, sir, S2 heart sound is heard during protodiastole. Okay. So even in our timeline diagram, look here. Even the timeline diagram, see protodiastole, when the pressure is going from 80 to 79, the pressure falls from 80 to 79, that is protodiastole. You will hear which heart sound? S2 heart sound. Why S2 heart sound? S2 heart sound is due to closure of aortic valve and pulmonic valve, A2, P2. The second heart sound, right? So aortic valve is closing, pulmonic valve is closing, creating second heart sound. Okay. So now tell me, S2 heart sound is heard during protodiastole. Again, repeat. S4 heart sound during atrial contraction. S1 heart sound during isovolumetric contraction. Isovolumetric contraction due to closure of mitral valve and tricuspid valve. And right now I am talking about S2 heart sound. S2 heart sound is heard during protodiastole. Okay, done. Now look, the important points. Protodiastole is the first stage of ventricular diastole. Okay, where the ventricular pressure falls from 80 to 79, right? Okay. When the ventricular pressure, see, when the ventricular pressure here, when the pressure in the ventricles, when the ventricular pressure becomes less than the aortic pressure or pulmonary artery pressure, the semilunar valves closes. That is these valves, aortic valve and pulmonary valve closes, creating S2 heart sound. So protodiastole bhi ho gaya. So tick mark. Protodiastole also completed. Now, okay. Next, let's discuss about isovolumetric relaxation. Now, guys, you should tell me something. Iso means the same. Volume. Isovolumetric relaxation. Isovolumetric relaxation means wherever you hear the word isovolumetric, what you should know? All valves are closed. Nothing is coming in, nothing is going out. All valves are closed. Nothing is coming in, nothing is going out. Isovolumetric relaxation. Okay. Now, look here. Isovolumetric relaxation. What is happening? You already know during S1, these valves are closed. Mitral valve, tricuspid valve, they are already in closed state. Right now, these valves are also closed. Aortic valve, just now aortic valve closed, mitral valve is closed. And now tell me, previously in the beginning, how much blood was here? 120. 120 was there. Previously, 120 to 140. That is the end diastolic volume. 120 is there. Now, some blood have gone out, right? 70 ml have gone out. 70 ml came here. So how much is left over here? 50 ml. See, that's one, this one, 50 ml. So this is called as the end systolic volume. At the end of the systole, how much volume of blood is there is called as the end systolic volume. So how much is the end systolic volume? Is 50 ml. So how much blood is left over here? 50 ml. Here 50 ml, here 50 ml. 50 ml of blood is there. That's called as the end systolic volume. Again, so right here, like, no need to write, just like same. What is the end diastolic volume? EDV or preload, 120 to 140. Total filled. How much filled? 120 to 140 ml of blood is filled. In that, how much gone into the aorta? Stroke volume. How much is the stroke volume? 70 ml have gone out. And how much is left over? End systolic volume left over in the ventricles? 50 ml is left over in the ventricles. These are the three values which I want you to know. End diastolic volume, stroke volume, and end systolic volume. Okay. All valves are closed. These valves are also closed. And these valves are all valves are closed. Now what is happening? Now the ventricle is relaxing. Diastole, right? Diastole, right? Now the ventricle is relaxing. What is happening? Pressure from 70 is decreasing to 50, 30, 10, decreasing to 5. The pressure is decreasing to 5. Okay. So look here. During isovolumetric relaxation, both AV valves and semilunar valves all are closed. Now the pressure inside the ventricles falls without any change in volume. That's why isovolumetric. Only 50 ml is there. Okay. It's not increasing, it's not decreasing. Okay. Now what happens? Later on, what happens? See, now the pressure is decreasing, sir. Okay, now the pressure is decreasing. It came to 5. But during this relaxation, when the ventricles are relaxing, isovolumetric relaxation, see, at the same time, atria are filling with the blood, right? Atria are receiving the blood. See, atria are receiving the blood. Atria are receiving the blood. Okay. Now, like this. Atria are receiving the blood. Now, once the pressure, ventricles are relaxing. Now, once the pressure goes to, for example, like 4 mmHg, ventricles are relaxing. Once the pressure reaches the 4 mmHg, immediately what happens? Just wait. Yeah. Here in the atria, the pressure is 5. Here the pressure is 5. Now, here the pressure became 4. Okay, here the pressure became 4. Now, immediately what will happen? Immediately these valves will open. Okay. Tricuspid valve, mitral valve, they will open and the blood will fall. So that is the point which I have written here. Once the pressure inside the ventricles, when they fall below the atrial pressures, the AV valves, the atrioventricular valves, that is the mitral valve and tricuspid valve, the AV valves will open. The AV valves will open. So what is the end? What is the end of isovolumetric relaxation? What is the end point? Once these valves are opened, now the new blood is coming in. Once these valves are open, this new blood is coming in. So the opening of these valves is the end point for isovolumetric relaxation. So this phase ends by opening of AV valves, that is mitral and tricuspid valve. When they open, that's the ending of the isovolumetric relaxation, because new blood is coming in. So new blood is, once the blood comes in, that is no longer isovolumetric, right? So that's the thing which I want you to know. Once this valve opens, okay? So the same thing, let me show you the timeline diagram. Look here, timeline diagram. The pressure is going from 79. The pressure is, for example, if it reaches 4, the ventricular pressures are decreasing. Now immediately what will happen? Immediately the valves will open. AV valves will open. AV valves. The opening of the AV valves will cause a heart sound that is called as opening snap. Once the AV valves are opened, it will cause opening snap. So this is isovolumetric relaxation. Okay, the same thing I have written here. See, opening snap. With the opening of opening with the beginning of opening snap, IVR completed. Isovolumetric relaxation completed. Okay, done. It's clear, right? Now, isovolumetric relaxation also completed. Okay, let's keep a tick. This is also completed. Now we are at the end. The next phase is rapid ventricular filling. Rapid ventricular filling. Very simple. See, this valves open, sir. Now the atrioventricular valves opened. Now in the beginning I have said you, there is 70% of the blood in the ventricles. 70% of the ventricles are already filled. From where that 70% blood came? Now see, now when this atrioventricular valves, when they open, blood will directly fall. Atria is not contracting. No, atria is not contracting. Just opening of these valves is enough. Due to gravity, 70% of the blood will fall into the ventricles passively, without using any contraction, without using any energy. Just the ventricles are getting filled. Okay, so look here, this is called as rapid ventricular filling. Rapid ventricular filling. See, opening of AV valves leads to rapid filling of the ventricles. That is passive. How much passive? 70%. The rapid, now look, when there is 70% of the blood, when it is falling into the ventricles, look, when the 70% of the blood, when it is falling into the ventricles, that will cause a little vibration in the wall of the ventricles. That will cause S3 heart sound. Okay, so during rapid ventricular filling, see, the rapid inflow of blood vibrate the ventricular walls and creates third heart sound, that is S3. S3. So again, S4 is heard during atrial contraction. S1 is heard during isovolumetric contraction. S2 is heard during protodiastole. S3 now, it is heard during S3 is heard during rapid ventricular filling. S3. When 70% of the blood falls into the ventricles, it creates the vibrations in the wall of the ventricle that creates S3 heart sound, which is not usually heard in healthy individuals. It is heard in pathological conditions only. In normal individuals, it is not heard. But this S3 MCQ, it is normal in children. It is physiological in children. It is physiological in children. S3 is physiological in children. So rapid ventricular filling also completed. Now, how much percentage of the ventricles are filling passively? 70%. How much percentage of the ventricles are filling actively? 30%. Okay, done. So look here, during rapid ventricular filling phase. Okay, during rapid ventricular filling phase, which heart sound is heard? S3 heart sound is heard. Okay, so after that, there is a slow filling phase, which is also called as a dash test. There is very small phase, which I don't want to discuss here. Okay, it will unnecessarily give you confusion. There is a very small phase called as a dash test. Okay, where the heart is very still. The blood movements in the heart is also very, very still. The atria are not contracting, ventricle is not contracting, and the ventricular filling is also very, very less. The blood movement is not happening. Okay, so there is least cardiac motion. Okay, there is least cardiac motion. The movements in the heart is very less. So this is the best time to visualize the heart on echocardiography. That's the best time to visualize the heart. Okay, that's it, enough. And again, after diastasis, what is the next phase? Atrial contraction. 70% either fill ho gaya. Okay, next in atrial systole, other 30% will fill. So with this, cardiac cycle completed. Now I will ask you questions. If you are having clarity, I will ask you questions. Let's see whether you can answer or not. Let's go from the beginning. Okay, let's check yourself, and let's see who can answer the first. Okay, first basic thing, how many phases are there in the cardiac cycle? 8. Otherwise, yes, true. 8 phases.
Okay, total 8 phases. Total 8 phases. Okay. If you say systole and diastole, and even in systole diastole, total there are 8 phases. Okay. Yeah, I will repeat. Okay, I will repeat it then. Next. So during isovolumetric contraction, isovolumetric relaxation, both the phases, using isovolumetric contraction and isovolumetric relaxation, what is the status of all the valves? All valves are closed. All valves are closed. Excellent. Next. Sir, during isovolumetric contraction, how much blood is there in the ventricles? How much volume of blood is there in the ventricles? During isovolumetric contraction, how much blood is there in the ventricles? 120 ml, 120 to 140 ml. Excellent. Okay, excellent. 120 to 140 ml. During isovolumetric relaxation, means contraction ho gaya, all valves are closed. Now, how much blood is left over in the ventricles? During isovolumetric relaxation, how much blood is there in the left over in the ventricles? 50 ml. That is called as end systolic 50 ml. 50 ml. That is end systolic volume. End systolic volume. And how much blood ejected into aorta with one heart contraction? With one heart contraction, how much blood is ejected into aorta? 70 ml. That is called as a stroke volume. That's called as a stroke volume. Okay. Quickly tell me. 70% of the filling of the ventricles occurs during. 70% of the ventricles occurs during which phase? Rapid ventricular filling. Rapid ventricular filling. Rapid ventricular filling, is it active or passive? Passive. Passive. 70% of the 70% of the ventricles passive. Okay, 70% of the ventricles are filling. Because because atrial contraction is filling 30%. Okay. Next, tell me, S2 heart sound is heard during. S2 heart sound is heard during. Protodiastole. Excellent. What is the first phase of diastole? What is the first phase of diastole? Protodiastole. Protodiastole. Okay. So same protodiastole. Okay. I hope you understood. Someone was asking about some student was asking about the isovolumetric relaxation. Isovolumetric relaxation, simple. Isovolumetric relaxation. Ventricle is relaxing. Where is it? Yeah, here is isovolumetric relaxation, right? Isovolumetric relaxation means, first of all, you already know. Isovolumetric relaxation means, isovolumic means all valves are closed. See, look here, all valves are closed. How much ml is there? 50 ml is there. Simply ventricle is relaxing. It's the easiest phase. It's the easiest phase. Simply ventricle is relaxing. See, the pressure is coming down. Pressure is coming down from 70 to 50, 30, 10, and the pressure is coming to 5. Simply the ventricle is relaxing. That's it. With the same amount of blood, 50 ml, all valves are in closed state. Okay. When the ventricle is relaxing, on the top, on the above, what is happening? On the above, atria are doing their work. Atria are doing their work. They are receiving the blood. Here, the left atria is receiving the oxygenated blood. Okay. And the right atria is receiving the deoxygenated blood from superior and inferior vena cava. The blood is coming here. Okay. The blood is getting filled here. Here also. That's it. Simple. So now I'm giving you time. Okay. Come here and check whether the statements are true or not. First, from here, check one by one. First statement, S1. S1 heart sound occurs during isovolumetric contraction. You know it. S1 heart sound occurs during isovolumetric contraction. Okay. It is due to what? It is due to closure of mitral valve and tricuspid valve. True statement. It is due to closure of mitral valve and tricuspid valve. And S2 heart sound occurs during the protodiastole. It is due to closure of aortic valve and pulmonic valve. That's also true statement. Both are true statements. Okay. Next, ejection click. When you see in the name itself, it's there. Ejection click. I have said you ejection means rapid ejection, the beginning of a rapid ejection phase. Ejection. So ejection click is due to opening of aortic and pulmonic valve. When the aortic and pulmonic valve, say this is the heart. See, this is the aorta, this side pulmonary trunk. When this valves open, when the aortic valve open and when the pulmonic valve open, what happens? Blood will eject. So that causes ejection click. Ejection click is due to opening of aortic and pulmonic valve. And opening snap is because of what? Opening snap is because of opening of
This mitral valve and tricuspid valve. When the mitral valve and tricuspid valve, when they open, that will cause opening snap. Mitral valve and tricuspid valve, when they open, that cause opening snap. See, S3 heart sound heard during, during rapid ventricular filling. S4 heart sound occurs during atrial contraction. Both this S3 and S4 are pathological, only seen in pathological conditions. S3 को एक दूसरा नाम है. There is another name for S3. That's called as a ventricular gallop rhythm. S3 is also called as ventricular gallop rhythm. S4 is also called as atrial gallop rhythm or atrial kick. S3 is also called as a ventricular gallop rhythm. S4 is also called as atrial gallop rhythm or atrial kick. Okay, that's it. These are the main things. And you know about the time periods. In the timeline I have given IVC, when it begins. Okay, when it begins and when it ends. IVR, when it begins and when it ends. It's clear. It is clearly given. And end diastolic volume, end diastolic volume also called as a preload. How much is the preload, sir? 120 to 140 ml of blood. And end systolic volume, the remaining blood remained in the heart. How much? 50 ml. Everything. Okay. So with this, cardiac cycle bhi ho gaya and heart sounds are also completed. Both things are completed. Cardiac cycle as well as heart sounds. Now, this S3 and S4 heart sounds, there is something special about it. Look here. Normally, all the heart sounds are high pitch. All the heart sounds are high pitch heart sounds. But in the entire medicine, okay, there are some low pitch heart sounds. Low pitch means you can only hear them with the bell side of the stethoscope. Stethoscope may big side hai, and one small side will be there, right? Now the small side is called as the bell. The big side is called as the diaphragm. Okay. Now the S3 heart sound and S4 heart sound, they can be heard with the bell side of the stethoscope. Bell side of the stethoscope in pathological conditions only. Okay. So S3 is called as ventricular gallop rhythm. S4 is called as atrial gallop rhythm. Okay. And there is one more sound called as a tumor plop sound. When you hear the tumor plop sound in a condition called as atrial myxoma, if a patient is having atrial myxoma, see, there is a tumor in the left atria. In left atria mein ek tumor hai. Okay. Now, for example, let me draw here. Sir, this is your left atria. Now, there is a pedunculated tumor. Okay. There is a stalk. So, it is going to move. It is going to oscillate. It is going to move. Right? It is going to move. So, the point which I want you to know is the tumor plop sound. It is a low intensity heart sound seen in patients of atrial myxoma. When it is heard after opening snap. Opening snap means, opening of the mitral valve and opening of the tricuspid valve. Okay. It is heard right after opening snap. So when you hear this, a low intensity heart sound which is heard after opening snap, you should think about a condition called as tumor plop sound seen in atrial myxoma. You will hear this again in your pathology lectures. Okay. When sir is taking your pathology classes, then also you will hear this. Okay. So tumor plop sound, atrial myxoma. So done. So what are the three low intensity heart sounds or low pitch heart sounds? S3, S4 and tumor plop sound. Done. So are you having clarity? Guys, clarity hai, nahi hai. Clarity unda. Please tell me. During exercise, you can hear S3. Okay, you during exercise, when you are doing exercise, during exercise conditions, you can hear S3. And S3 is also physiological in children. Yeah. Next, after this, come to our important topics table. Mein. We have completed what? We have completed ticks. Keep the ticks. Action potentials completed. Morning we have completed. We have completed the cardiac cycle now. And I have also integrated and explained heart sounds also completed. So what is the next topic that I should teach you? I have to teach you now murmurs. This one. Come to this slide. This is all about the murmurs. Now, before going to the murmurs, I want you to know one point. Look here. Guys, look at the systole. Systole is a phase between, can I say something like this? Systole is a phase between S1 heart sound and S2 heart sound. Yes, true. And diastole is a phase between S2 and S1 again. Right? right? So systole is a phase between S1 and S2. Diastole is a phase between S2 and S1. Okay. So the same thing, let me show you here. S1 S2 के बीच में what do we have? Systole. And S2 and S1 के बीच में diastole. Okay, here what I am showing you is this light blue color phase is the systole. This green color phase which I am showing here is the diastole. Okay, systole and diastole. Now, this is the exact image based question which was given. Exact image based question which was given in the NEET PG 2023. NEET PG 2023. See, now there is abnormal sound that is coming from the starting of the systole to the end of the systole. So is it there in the beginning of the systole or end of the systole? It is there throughout the systole. So it's a pan systolic murmur or holosystolic murmur. This is a murmur which is seen in the entire duration of the systole. So this is the abnormal sounds. Murmurs are the abnormal sounds. So tell me, holosystolic murmur or pansystolic murmur. It is seen in which conditions? It is seen in three conditions. Wherever you go in medicine, in pathology, in physiology, only these three will come. Holosystolic murmurs or pansystolic murmurs are seen in three conditions. What are they? MRTR VSD. MRTR VSD. See, mitral regurgitation, tricuspid regurgitation, and ventricular septal defect. MRTR VSD. Okay, insufficiency means regurgitation. They are not closing properly. Mitral regurgitation, tricuspid regurgitation, and VSD. Now, some students will be scratching their heads. Sir, why, sir? Why there is a murmur during systole? Why there is an abnormal sound that is happening during systole? Look, for easy understanding purpose, look here. Now, you please tell me what is the thing that I am drawing here? What is this wall? Mitral wall. What is this wall? Tricuspid wall. See, these walls are not closing properly. Okay, these walls, they are not closing properly. During systole, they are not closing properly. Okay, during systole, they are not closing properly. When they are not closing properly, you tell me. Now, unnecessarily, the blood will go back. Okay, maybe for example, here there is mitral regurgitation. Here what is happening? There is a tricuspid regurgitation. When this regurgitation is happening during systole, okay, during systole, unnecessarily the blood is getting ejected. During isovolumetric contraction, rapid ejection phase, slow ejection phase, unnecessarily the blood is getting regurgitated back into the atria. So that will cause unnecessary sound. That will cause what? Unnecessary sound. Okay, understood? So that's why pansystolic, see, pansystolic murmur. So pansystolic murmur is heard during mitral regurgitation as well as tricuspid regurgitation. And what is the next thing? I have said there is a condition called as VSD. What is VSD, sir? Ventricular septal defect. Ventricular septal make hole here. There is a hole here. Okay, ventricular septal defect. So during systole, what happens? During systole, now the blood is going to move from left to right. The blood is going to move from left to right. So that unnecessary moving of the blood, will create again sound, murmur. During when? During systole. That's why again pansystolic murmur. So tell me, the pansystolic murmur is heard during which conditions? You should have to say three conditions: MRTR VSD, mitral regurgitation, tricuspid regurgitation, ventricular septal defect. You can hear with the stethoscope. You can hear MRTR VSD, MRTR VSD, MRTR VSD. Okay, done. Next, you tell me. So one murmur completed. हो गया. So done. Now look here. So this is the second murmur, right? This is the second murmur. Now this murmur, is it heard during systole or diastole? Is it heard during systole or diastole? This is also heard during systole, sir, from the beginning to the end. So can I call it as a pansystolic murmur? Of course, it's a pansystolic murmur, no doubt. But what is difference? What is the difference? The intensity of the sound is increasing and later decreasing. So the intensity, the murmur intensity increases and decreases. Like zzz, means the murmur intensity is going to go up and it will come down. So this is called as a crescendo decrescendo murmur. Okay, so it's a crescendo decrescendo murmur, or sometimes it is also called as the ejection systolic murmur. Okay, so crescendo decrescendo murmur, it's in the shape of the diamond, so it's a diamond shaped murmur. It is seen in which conditions? Which pathological conditions? Murmurs, of course, happens in the pathological conditions. Which pathological conditions? Aortic and pulmonic stenosis. Aortic and pulmonic stenosis. No need to remember like subaortic. If you can remember, that's best. So simply remember aortic stenosis, pulmonic stenosis. Also write HOCM. What is HOCM? Hypertrophic obstructive cardiomyopathy, where the patient is going to have subaortic stenosis. Okay. So pulmonic stenosis, aortic stenosis, and HOCM, that is hypertrophic obstructive cardiomyopathy patients. These patients are going to have diamond-shaped murmur or crescendo decrescendo murmur. Okay. Now, why some students again they will be having doubt? Always these are like doubt beings. Always for everything in the life they have a doubt. So look here. What is aortic and pulmonic stenosis? See, this is aorta here, and here it is pulmonary trunk, right? Now stenosis. Look here, there is stenosis. Okay, let me show it with the yellow color. This aortic valve, it is stenosed. It is not opening properly. It is not stenosis. It is not opening properly. On this side, the pulmonic valve, it is not opening properly. Okay, it's not opening properly. Whenever they are not opening properly, now look, guys. First, initially the pressure will increase from 80 to 120. So pressure is increasing. So more blood will go or less blood will go? Rapid ejection phase. More blood will go. So more blood is going means through the small orifice. Through the small orifice, more blood is going means more sound will come. Later on, the pressure is decreasing from 122 back to 80. The pressure is decreasing. That is slow ejection phase. Less blood is going to go. Less blood will go. If less blood is going, automatically the intensity of sound will also decrease. So initially the intensity of sound increases. Later on, intensity of the sound decreases. Okay, that's why crescendo, decrescendo murmur. The same stuff here also. Crescendo, decrescendo murmur. So crescendo, decrescendo murmurs are heard in aortic stenosis this side, and this side pulmonic stenosis. Okay, is that clear? Aortic stenosis and pulmonic stenosis are going to cause crescendo, decrescendo murmurs. Okay, aortic stenosis and pulmonic stenosis are going to cause crescendo, decrescendo murmurs. Now, look again, repeat. Systole mein, either you can have pan-systolic murmur, either you can have a pan-systolic murmur, which is seen in MR, TR, VSD, pan-systolic murmur. Crescendo, decrescendo murmurs are seen in aortic stenosis, pulmonic stenosis. If you can remember HOCM. Okay, hypertrophic obstructive cardiomyopathy. Okay. What Abra you are asking? HOCM patient stage. Hypertrophic obstructive cardiomyopathy, it's autosomal dominant disorder. It is usually seen in younger ages. Okay, for example, a 20-year-old boy suddenly fall dead when he is playing. Okay, 20-25 years fellow, normally he is playing or he is dancing and suddenly he fell dead. HOCM, how come? Okay, because of the ventricular fibrillation. Is usually it is seen in the young patients. It's autosomal dominant disorder because of the beta myosin heavy chain mutation. It is seen usually in a younger individuals. Okay, 20-year-old fellow playing hockey, he suddenly fell dead, something kind of case will come. Okay, there you will hear crescendo, decrescendo murmur. Next, so 2 murmurs are completed. The next murmur, which is important for your FMG exam, is this third murmur. This one. Okay, so what is this murmur, sir? This murmur, look here, it is there during systole and it is also there during diastole. It is there during systole and also during the diastole. So what is this? So it is continuously there. Doesn't matter whether it is in systole or diastole, it's continuously there. So this is called as continuous murmur or machinery-like murmur. Continuous or machinery-like murmur is seen in patent ductus arteriosus. Patent ductus arteriosus or PDA. Patent ductus arteriosus. Okay, patent ductus arteriosus. Now, let me explain you why it is such. What is patent ductus arteriosus, sir? Draw this diagram. So this is your heart with the 4 chambers. Now I'm changing a little bit. This is the left ventricle, right? From here, aorta is coming down like this. Aorta. I'm drawing it downwards, aorta. And what is this one? This is pulmonary trunk. Okay. Now, there is this abnormal connection present between these two. This is called as patent ductus arteriosus. Abnormal connection even after birth. If you have this connection even after birth, before birth it's okay. But if you have the persistence of this connection even after birth, that is called as patent ductus arteriosus. Patent ductus arteriosus. Now, what is the baseline pressure in the aorta? Remember this thing, you don't know this thing, but for now, remember. So, what is the baseline pressure in the aorta? Always 80. What is the baseline pressure in the pulmonary trunk? The pulmonary trunk mein baseline pressure is 10. That's the difference. So always in the left side, always on the left side, you have higher pressures. Left side may higher pressures. Hey, okay. So doesn't matter whether it is systole or diastole. Doesn't matter. Always there will be left to right shunting. Okay, in the patent ductus arteriosus, blood is going to shunt from left side to right side. So that will cause murmur continuously like a machine. The sound is going to come like a machine that is working. So that is called as a continuous machinery like murmur seen in patent ductus arteriosus. Okay, so done. So come on, I'll be asking you, tell me. Sir, S3 heart sound is heard during. Vamsi, you are saying, I don't know, sir, I'm feeling confused. Where do you feel confused? Vamsi, please tell me. Vamsi Nikhil, please tell me where you have confused. In murmurs? Okay, guys, wait. Guys, is it only with the Vamsi? Vamsi, like I'm asking you generally. Guys, you understood about the murmurs or not? Yeah, briefly I will revise. Is problem with everyone? Is the problem with everyone or like it's clear, right? You understood? Okay. Are simple murmurs are seen in pathological conditions. Remember, simple. Remember like this. There are two ways. Knowing the content, knowing the things in and out. That's one thing. If you can't understand everything, the other way is simply by hearting. Okay. Simple. Let's try to understand like this. Murmurs are seen in pathological conditions, no doubt. Either a murmur can be seen in a systole or a murmur can be seen in diastole. Systolic murmurs, diastolic murmurs. Right? Systolic murmurs, diastolic murmurs. Now, here in your exam, what they will give you is, look, they will give you something like this. Same image, 2023 NEET PG. S1, S2, again S1. So what is the phase between S1 and S2? That is called as systole. What is the phase between S2 and S1? It's a diastole. Okay. If you hear a murmur like this, look. If you hear a murmur like this, that is called as what? That's called as a pan systolic murmur. Okay, pan systolic murmur. Okay, because it is there throughout the systole. This pan systolic murmur is heard in which conditions? A conditions lo kanpistayi ilaga. Which conditions may you will hear this pan systolic murmurs? 3 conditions, sir. One is MR, TR, that is MR means mitral regurgitation, TR means tricuspid regurgitation, and third condition is ventricular septal defect. In these 3 conditions, you will hear pan systolic murmur. Okay. Now, there is one more murmur. See, the murmur is looking like this. The murmur intensity increases and murmur intensity decreases. So this is called as a crescendo decrescendo murmur. So this crescendo decrescendo murmur is also seen in the systole, but such type of crescendo decrescendo murmur is heard in which pathological condition? So crescendo decrescendo murmurs are seen in aortic stenosis, pulmonic stenosis, or hypertrophic obstructive cardiomyopathy. In these 3 conditions, you will hear this diamond shaped murmur or crescendo decrescendo murmur. Okay. And final murmur, there is a murmur which is heard during systole as well as it is also heard during diastole. Okay, a murmur which is heard during systole as well as diastole. That is called as continuous murmur. That is heard in which condition? Patent ductus arteriosus. That's it. Simply 3 murmurs, different conditions. 3 murmurs, different conditions. Simple. Okay. Again, this will come in your medicine also. Okay. But physiology topic. If you have any specific doubt, you can ask me. Sir, why MR may pansystolic murmur or why aortic stenosis may crescendo decrescendo murmur? I have discussed. Already I have discussed, but if you have doubts, you can ask me. No doubt. Yeah. Done. Different conditions, so different murmurs. Okay, is it clear? Done. Yeah. So now these 3 murmurs are very much important for your exam.
But in one of the exam 2018 May, look, this question was asked. This question was asked. Just look. This is the image that was given. This is the image that was given in that exam, and they have asked to arrange the correct order. What is 1, 2, 3, 4? What is this area? This is the right side. This is the left side. Okay. Now, this is the first. Like, what is this area? What murmur you can hear? Like, what murmurs you can hear in this area? This is the second intercostal space, right? Right side, second intercostal space. This is the left side, second intercostal space. Okay. Now, in this, what is this area? Which valves murmurs can be heard here? 2, 3, 4, 5. Okay. Now, for this, you need to know. Look, the number 1 point, you don't need to draw. I will share the PDF here. This is 1. Okay, 1. What is that area? It's the aortic area. Here you can hear the aortic murmurs. Okay, aortic wall related murmurs are the things. Now, 1, right side. Okay, because aorta will be turning like this. It takes a turn like this. Okay, so that's why aortic wall murmurs are better heard here in this 1. So it's the aortic area. Right side, second intercostal space. What is then second? What is this area 2? Here, it's a pulmonic area. Okay, pulmonic area. Okay, pulmonary valve, stenosis, pulmonary regurgitation, all these abnormalities can be better heard here. Which area? Second intercostal space, left side of the sternum. Left side of the sternum, second intercostal space, pulmonic area. Okay. Now, this third one, it's called as the Erb's point. This third area, third intercostal space, left side, third intercostal space. That's called as the Erb's point. There also you can hear the aortic murmurs. Okay, that's also the place where you can hear the aortic murmurs. Okay. Next, this fourth, point number 4. Okay. That is the tricuspid area. Fourth intercostal space, left side, fourth intercostal space. That is the tricuspid area. Okay. And last one in the mid-clavicular line, that's a mid-clavicular line. Okay. Fifth intercostal space. The fifth intercostal space, mid-clavicular line. This is the fifth intercostal space. Fifth intercostal space, mid-clavicular line. That's the mitral area. All mitral wall murmurs can be better heard here. Mitral wall, mitral area. That's the left of the sternum, left side. Everything is on the left side. Everything is on the left side except aortic. Okay. So mitral area, left of the sternum, fifth intercostal space, and the mid-clavicular line. So that's which I want you to know. So what is 1, 2, 3, 4? What is 1, 2, 3, 4? So okay, let me directly show you. Let me directly show you the question which was asked in the exam. Okay, you try to answer them. Okay. This is the question which was asked in the exam. Try to answer it. What is the sequence of heart sounds heard from top to bottom on the left side of the chest wall? Top se niche tak. Okay, top to bottom. You have to arrange pulmonary, mitral, aortic. On the left side, the top, what do you have? Left side. See, left side with top mein, second, this one, right? Left side, pulmonary, followed by Erb's point. Erb's point means aortic. Okay. Next, tricuspid and mitral. So, what is the first one? Pulmonary is first. Next, Erb's point, that is second. And mitral is third. So, what is the order? First, 1. This 1, 3, 2. This is order. Okay, 1, 3, 2. This is the order from top to bottom. First pulmonic, next aortic, next mitral, PAM. Okay, pulmonary, aortic, mitral. So this is the answer. So I'm taking this and I'm keeping it in our topic here itself. Copy, paste. Let me come. So in the murmur topic itself, I am keeping here, paste. So yeah, done. So with this, murmurs also completed. Cardiac cycle completed, heart sounds completed, and murmurs also completed. Cardiac cycle, heart sounds, and murmurs. Okay. Next, topic. Okay, before going to the next topic, clarity. Can I go forward? So why aortic left? So we can hear better sounds because aorta is like, it's going to go back like this. Okay. So its aorta is not like a straight tube. It curls back like this because of the anatomical position. Because of the anatomical positioning, we can better hear the sounds in those areas. Okay, yeah. Because it crosses, yes. True. True, guys. True. So, chalo. Guys, the next topic which we are going to discuss is the pressure volume loops, left ventricular pressure volume loops. Come to this slide. We have completed heart sounds ho gaya, murmurs bhi ho gaya. Next, we have to discuss about the left ventricular pressure volume loops. Now, chalo. Those who understand the cardiac cycle, for them, this is an easy peasy topic, simple topic. Okay. Now, first, what you need to know. First, basic. A kya hai? This is x-axis. Okay, x-axis hai, sir. Okay. Now, what is this axis? Y-axis. Whatever I'm showing you right now here, this is the y-axis. This one, sir. This is the y-axis. X-axis. Okay. Now, on x-axis, what I am talking? X-axis, I'm talking about, see, some volumes. 40 ml, 60 ml, 80 ml, 100 ml, 120 ml, 140 ml, something like that. Okay. I'm talking about the volume. 40, 60, 80, 100, 120, something like that. Which volumes? Ventricular volumes. Ventricular volumes. Do you know about the ventricular volumes? Have you ever heard about the ventricular volumes? Sir, there is something called as end diastolic volume, 120 to 140. There is something called as end systolic volume, 50. There is something called as stroke volume, 70. You know about some volumes. Okay, no problem. Then, on y-axis, what I'm talking about? I'm talking about the pressures. 20 mm Hg, 40, 60, 80, 100, 120. Do you know any pressures in the left ventricle? You know pressures. Pressure increases to 80. Pressure increases from 80 to 120. 120 to back to 80 pressure. You know the stuff. So, now let's begin. Before, so, okay, let me show you here. First, I'm talking about left ventricle, only about the left ventricle. Left ventricle में pressure और volume का, pressure and volume का graph. I'm talking only about the left ventricle, not about the aorta, not about the right ventricle, not about the atria. I'm talking only about the left ventricle. Okay. First, left ventricle में how much blood is left over every time? How much blood is left over? Tell me. 50 ml, sir. See, 50. That's why here 50, 40 or 60 के बीच में 50. Okay, 40, 60 मतलब ఎంత 50 కదా. So 50 here, 50. Okay, so that 50 is the end systolic volume. How much blood is left over in the ventricle? 50 always. Starting. 50 is there. Okay. After 50, what happens? Left ventricle will fill. Will it fill or not? Due to rapid ventricular filling, 70%. And due to atrial contraction, 30%. Ventricle, will it fill or not? Yes, it will fill. So that's why, see, volume is increasing. This pink color line, volume is increasing. How much volume is increasing? Up to 120. That is end diastolic volume. That's it. Simple. So what is this pink color line representing? The pink color line, this is the question which was asked in the FMG exam. This pink color line is representing ventricular filling. Okay, pink color line, what is representing? Ventricular filling. Okay, ventricle fills, ventricular filling. Once you have 120 ml of blood in the ventricle, you tell me. Look at me once. So look at me. Once you have 120 ml blood in the ventricle, what is the next thing that should happen? Ventricle should have to contract. Okay, ventricle have to contract. Right? Raise the pressure in the ventricle. We have to contract the ventricle and we have to raise the pressure in the ventricle. So that's the same thing happening. They go here. So once you have 120 ml of blood, once you have 120 ml of blood, now ventricle is going to contract. Now when the ventricle is contracting, immediately mitral valve closes. I'm talking about the left ventricle, right? Left side. So that's why I'm writing here mitral valve closes. So exactly at this point, when the ventricle started to contract, mitral valve closes. And what is ventricle is doing? Ventricle is contracting. So that's why the pressure from 5, it is increasing to 10, 20, 30, 40, 50, 60, 70, 80.
something like that. So pressure is increasing to 81. The pressure is going to increase to, for example, 81. The moment pressure increases to 81, immediately which valve opens? Aortic valve opens. Okay. So what is this phase, sir? What is this violet color phase? So this violet color phase where the pressure is increasing up till 81. This is isovolumetric contraction. Here in the down, this is ventricular filling. Ventricular filling because of rapid ventricular filling as well as atrial contraction. Okay. So this is IVC, isovolumetric contraction. Now after isovolumetric contraction, what happens? The pressure from 81, it reaches to 120. See, the pressure is reaching to 120. So that is which phase? Rapid ejection phase. Rapid ejection phase. Now after rapid ejection phase, the pressure is going to come from 122 back to 80. So the pressure is decreasing. What is this phase? Slow ejection phase. Slow ejection phase. Rapid ejection phase, slow ejection phase. Okay. Now, so blood got ejected. Blood got ejected. So when the blood got ejected, done. Rapid ejection, slow ejection completed. Now ventricle have to relax. Now the ventricle have to relax. So now the pressure is now becoming 80 to 79. When the pressure becomes 80 to 79, immediately aortic valve closes. Okay, immediately aortic valve is going to close because ejection completed. Ejection ho gaya. So ejection hone ke baad aortic valve is closing. So exactly here at this point, aortic valve closes. At this point, aortic valve opens. Now ventricle is relaxing. 80 to 60, pressure decreasing. 60 to 50, 50 to 40, 40 to 30, 20. Now the pressure is decreasing almost to 4. For example, the pressure is decreasing to 4 mmHg. When the ventricular pressures are less, look, when the ventricular pressures are decreasing, what happens? When the ventricular pressure less than the atrial pressure, listen to my word. When the ventricular pressure is becoming less than the atrial pressure, top atrial pressures, immediately which valve opens? Mitral valve opens. Mitral valve open ho gaya. Mitral valve open hone to, when the mitral valve opens, again filling. Rapid ventricular filling. After that, atrial contraction. So again filling. So done. So what is this? Isovolumetric relaxation. This down phase, ventricle is relaxing. Isovolumetric relaxation. Okay. Again, 50 ml is there. Okay. So now, for easy understanding purpose, look here. Simple, guys. Take two axes. X-axis, Y-axis. Take two axes. First here write, what is this? 50 ml. Here write, how much ml? 120 ml. Okay. Now first the ventricle have to fill. Ventricle have to fill from 50 to 120. So if you want to fill the ventricle, first which valve should open? Mitral valve should open. When the mitral valve is open, yeah, ventricle is filling. And how much you got? 120. That 120 is end diastolic volume. Now once you have 120, now immediately here what happens? Mitral valve close. Because ventricle is contracting. So now the ventricle will start to contract. So the pressure is increasing. Pressure increases up till the pressure increases up till how much? Okay, let me draw like this. The pressure increases up till 80, maybe here 80 or 81. The pressure becomes 81. Immediately which valve opens? Aortic valve opens here. Aortic valve opens. So what is this phase? Isovolumetric contraction. Now after this, the pressure from 81, it increases up till where? The pressure increases up till to 120. 120. What is this phase? This is rapid ejection phase. Rapid ejection phase here, 120. Now later the pressure will come back to again 80. That is slow ejection phase. Now when the pressure is going below 80, immediately which valve will close? Aortic valve close. Once the aortic valve is closed, now what happens later? The pressure will again come down. The pressure is going to come down. Okay. So this is isovolumetric relaxation. Okay. So done. That's it. So this is the left ventricle में pressure and volume का changes. We are keeping it in the form of a graph. Okay. So here this is ventricular filling down, isovolumetric contraction, rapid ejection phase, slow ejection phase, isovolumetric relaxation. That's it. These are the phases. In your FMG exam, what they will ask you is, so they will simply give you a graph like this. They will give you a graph like this. Now you should tell me. So this is a point number A, B, C, D, E. Okay, A, B, C, D, E. Now, what is the point C representing? What is the point number C representing? What is the
point number C representing? Come on, Rahul Singh. Excellent. Rahul Singh, excellent. It's a rapid ejection phase. Rapid ejection phase. Okay, what is the point number A representing? What is the point number A representing? In your exam, yeah, it's a ventricular filling. Ventricular filling. B representing isovolumetric contraction. C representing rapid ejection phase. This is D is low ejection phase. E is isovolumetric relaxation. Now, let me ask you it in a different way. Sir, A, X, Y. Okay, not X, Y. Let's say P, Q, R, S, T. For example, PQRST. Something like this. Okay, PQRST. Now, which valve is going to close or open here at Q? Which valve is it going to close or is it going to open at Q? First of all, which valve? Which valve opens or which valve closes? You tell me. Q may like 120 ml of blood is there. When 120 ml of blood is there, ventricle have to contract. When the ventricle have to contract, the mitral valve have to close. The mitral valve have to close. Yes, excellent. Yes, excellent, guys. Vamsi, yeah, Maria, Sai Pranita, yes, Subhadra. Yes, it's a mitral valve. Yes, mitral valve have to close. Mitral valve have to close. Now, let me ask you one more thing. Let me ask you one more question. Now, if I say this one, point number where? Yeah, here. Oh my God. Let me use some other color. Yeah. So point, this is alpha, for example. Here I'm saying beta. Okay, alpha, beta, for example. Okay. Now, what is A representing? What is A is on the x-axis? A is on the x-axis. What is this A? Alpha. Alpha. What is this alpha? Alpha. I'm talking about the alpha. Alpha means here, what is this? 50 ml. Okay, 50 ml. 50 ml is what? End systolic volume. What is this beta? Beta is 120 ml. What is that? End diastolic volume. End diastolic volume. Now, the really intelligent student can answer me. What is the difference between alpha and beta? What is the difference between alpha and beta? What is this difference? What is this difference between alpha and beta? Can anyone tell me what is the difference between the alpha and beta? Only a super high intelligent student can answer this. What is the difference between alpha and beta? The difference between this alpha and beta ke beech mein, both are on the x-axis. Alpha and beta, both are on the x-axis. What is the difference? The difference is, one is end systolic volume, okay. One is end diastolic volume, okay. But what is the difference between these two? Anyone? Who said in the beginning? Rahul Singh, Satish, yes, you all are true. It's a stroke volume. It's a stroke volume. Yes, excellent, guys. Excellent. That's the stroke volume. Beta is 120. Alpha is 50. The difference is 70. What is that 70? Stroke volume, sir. That's the stroke volume. So with this, left ventricular pressure volume loops. Okay, yeah, that's it. Here, in detail explanation was given. What is a, like, no, in detail explanation was given, but no need to go through that. Simple, whatever I have taught you, remember it. Okay, phases and which valves. Phases and which valves. Enough. Okay. Next, guys, this is a pure physiology. Till here, pure physiology. So till here, pure physiology. But in your FMG exam, they will ask you about integration. From pathology, they will ask you integration. Pathology and physiology integration. Now, I will teach you that. Okay, now I will teach you that. 4 things you should know. Alright, guys, look. Now, look here. This is x-axis. Here it is y-axis. Now, what is a normal left ventricular pressure volume loop? This is how the normal left ventricular pressure volume loop looks like. This is how. So this is the normal left ventricle ka pressure volume loop. Normal. How much is the top notch? Top notch pressure that is attained is 120, right? 120, for example, 120 here. Okay. Now, I will show you one pathological graph. You should tell me what is that condition. Okay. See, there is this one thing, condition.
where the left ventricular pressure volume loop, okay, where the left ventricular pressure volume loop is going to look something like this. The green color thing is abnormal. Left ventricular pressure volume loop. This is how the left ventricular pressure volume loop is attained. Maybe here the pressure that is getting generated is 200 mmHg. Maybe the left ventricle is generating 200 mmHg. So what is this condition? In which condition may left ventricular pressure volume loop is going to come something like this? Is going to be something like this. Which condition may? The answer is, okay, let me see, anyone of you can answer it or not. What is this green color? In which condition you will see this? Aortic stenosis. Yes, it is seen in, excellent guys, it is all seen in the aortic stenosis. Why aortic stenosis? Understanding purpose. See, imagine this is the left ventricle. I am talking here only about the left ventricle. Okay, here I am talking about the left ventricle. Here it is aorta. This is LV. Now here the aortic wall, it is stenosed. It's not opening properly. It is not opening properly. It is hardened. It is hardened. Okay. In order to open this aortic wall, okay, now left ventricle have to generate less pressure or more pressure. Now you have to generate more pressure. Now it is not enough. Now you have to generate more pressure in order to open this aortic wall. So left ventricle, in order to push the blood, it is generating more pressure. So that's why the pressure is reaching more. Maybe 180, maybe 200. It is generating more pressure. But tell me, do you think whenever there is a stenosis block here, do you think all the blood will go into aorta? All the stroke volume will go into the, I should say, that 70 ml blood will go into the aorta? Definitely not. Definitely not. Okay. So more blood is going to be, see, normally how much should be left over? 50 ml should be left over. 50 ml should be left over. But in our condition, how much is left over? Maybe 70 ml is left over. Means more blood is accumulating inside the left ventricle. Blood is not going forward. More blood. That's why it's like this. Normal condition, what is the stroke volume? The difference. Stroke volume is 70 ml. Maybe here in this condition, stroke volume is just only 50 ml decreased. Stroke volume is also decreasing difference. Okay. So in aortic stenosis, you will have a tall curve like this. Tall curve like this. Okay. Tall curve like this. So look here in aortic stenosis, see how the left ventricular pressure volume loop is. It's a tall. Okay. Next, see, let me make it easy for you. Let me make it easy for you. Draw 4 graphs. Okay. 4 graphs. Draw normal left ventricular pressure volume loop. This is a normal left ventricular pressure volume loop. You don't need to draw this, but just look at least. If there is no space, don't draw it. Just listen to what I'm teaching. Like this, right? Now, you already know it. If you ever see a tall graph like this, left ventricular pressure volume loop, the answer is aortic stenosis. Just by heart it. Now, whenever you see a left ventricular pressure volume loop, if it is moving in one direction, okay, if it's moving in one direction like this, here on the screen, I'm showing to the right side, right? The left ventricular pressure volume loop, okay, the left ventricular pressure volume loop, it is shifting to one side. Okay, it's one side, that's the right side, it's moving. Okay, that is aortic regurgitation. Okay, aortic regurgitation. The aortic regurgitation is a pathology. Aortic regurgitation. The left ventricular pressure volume loop is going to be something like this. It's going to shift like this to the right side. Whenever you see a left ventricular pressure volume loop which is smaller than usual, this is mitral stenosis. In mitral stenosis condition, it will be chota thing. Small, MS small, mitral stenosis. And is a condition called as a mitral regurgitation, MR, mitral regurgitation, where the left ventricular pressure volume loop, it extends to both the sides. If it is extending, see, to both the sides, it is MR. So just by heart it like that. If you go into too much concept, this is not the time to go into too much detailed concept, because this is pathology. If I teach you pathology, it will take the whole time. Okay, I can't complete the subject. So remember, whenever you see a tall curve, it is aortic stenosis. Look, if the tall curve is aortic stenosis. Explanation was given. If you can go through that later when I share the PDF. In aortic regurgitation, it will go to one side. Aortic regurgitation mein explanation was given. And in mitral stenosis mein chota thing. Like, this is the normal thing. Okay. Black color is normal. The blue color thing is abnormality. It's small. Mitral regurgitation. In mitral regurgitation, extending to both the sides. Both the sides. Okay. So this is the easy way to remember. Now let me give you a question and try to answer it. Sir, if there is a patient, now his left ventricular pressure volume loop curve was given. Now the patient's left ventricular pressure volume loop was shown in the blue color. Tell me what is the abnormality that he is suffering with? What is the abnormality that he is suffering with? Blue color. What is it? MS, simple. MS, mitral stenosis. Both the sides, mitral regurgitation. One side, aortic regurgitation. That's it. Okay. So done, sir. Completed. So keep it tick. Left ventricular pressure volume loops also. Okay. Now what is the next topic? Jugular venous pressures. JVP, jugular venous pressures. Okay. Now take a 1 minute, just 1 minute break, 1-2 minutes break. Just have a deep breath, have some water. Now let's complete the jugular venous pressures. After that, I will give you the break. Okay. After jugular venous pressures, I will give you the break. Okay. Is that okay, guys? One minute break. Okay. What's the time now? 12:39. Okay. Let's take it as a 12:40. We'll start at 12:42. 2 minutes break. Okay. Okay. Then next, let's discuss about the jugular venous pressures. Where am I? So the next topic that I'm going to discuss is the jugular venous pressures. So how to understand the jugular venous pressures? It's very simple. Look here. Jugular venous pressures means right now, first thing you need to know is I'm only talking about right atria. Okay, let me write. I'm talking about what? Right atria. Okay, I'm only talking about the right atria. So here I'm showing you, sir, right atria. Okay, this is the right atria. So right atria, it's in contact with what? Right atria, it's in contact with the superior vena cava. Am I right or not? Yeah, here is the superior vena cava. Okay, this is the superior vena cava, which is bringing the deoxygenated blood. This is the superior vena cava. Now, from where the superior vena cava is receiving the blood? So superior vena cava is receiving the blood from the internal jugular veins. Okay, let me show you the internal jugular vein in a different color. So imagine this is the internal jugular vein. So this is the IJV, internal jugular vein. So internal jugular vein say blood is coming into the superior vena cava. From the superior vena cava, the blood is coming into right atria. Okay. Now try to understand they are like a one single chamber. Okay, right atrium, superior vena cava, and internal jugular vein, which is visible in the, which you can see in the neck. Internal jugular vein, which you can feel in the neck. Okay, they are like one single chamber. Now tell me, if I increase pressure here in right atria, what happened to the pressure in the superior vena cava? Increases. What happened to the pressure in the internal jugular vein? Increases. Okay. So right atria में pressure changes होने तो, if there are pressure changes in right atria, automatically that will cause pressure changes in the internal jugular veins. Right atria sometimes contracts, sometimes relaxes. So automatically, sometimes pressure increases, sometimes pressure decreases. In the same way, in the internal jugular vein also, sometimes pressure increases and sometimes decreases. Sometimes pressure increase, sometimes pressure decrease. So this is what I am showing you here. So in the jugular veins, in the internal jugular vein, sometimes the pressure is increasing and sometimes during the cardiac cycle, the pressure is decreasing. Okay, sometimes it's increasing, sometimes it is decreasing. So how many waves are coming? Look here, there are A, C, X, V, Y waves. Okay, so there is A wave, there is C wave, small wave, C wave, and there is X wave, and there is V wave and Y wave. Y wave means decreasing. Means A may, look, the pressure is increasing. C, the pressure is increasing. C is pressure is increasing. V, the pressure is increasing. And X may look, X, the pressure is decreasing. Y, the pressure is decreasing. Okay, so what are positive waves? Positive waves means the pressure is increasing. When the pressure is increasing, see, A, C, V are positive waves, and X and Y are negative waves, means the pressure is decreasing. Okay, so according to the cardiac cycle, the pressure in the right atria changes and the pressure in the internal jugular vein also changes. This is the easiest way to understand. Okay, for understanding purpose, this is the easiest way. Okay, so let's go one by one. Let's see one by one. Okay, now look. First, we know our atria contract or not. Our right atria, will it contract or not? Okay, look at me. Look at me, sir. First, my right atria contracts. Right atria contracts. Left atria also contracts. When right atria is contracting, what happened to the pressure in the right atria? Right atrial pressure increases. What happened to the pressure in the internal jugular vein? Also increases. So that's why there is this A wave. The pressure is increasing, A wave. Why the pressure is increasing in the internal jugular vein? Because atria is contracting. During atrial contraction, we have the A wave. We'll note the A wave. Okay, we'll note A wave. Pressure is increasing. Atrial contraction completed. Now after that, after the contraction, atria should have to relax. So atrial relaxation. When the atria is relaxing, the pressure in the atria decreases. Also, the pressure in the internal jugular vein decreases. So that's why this X, the pressure is decreasing. So X is the atrial relaxation. The pressure is decreasing. A is due to atrial contraction. X is due to atrial relaxation. But here there is a small bump. There is a small elevation. What is this? It means the pressure is little increasing. This is the super important MCQ. Super important MCQ. Put 10 star marks. Even that is less. It is that important. C wave. Why that C wave is? Let me tell you. Let me draw here and let me tell you. Sir, here I am only talking about right side of the heart, right atria and right ventricle. Right atria, right ventricle ke beech mein. What is there? Which valve is there? tricuspid valve is there. Okay, tricuspid valve. This is the tricuspid valve. Here is the tricuspid valve. Now, when the right ventricle is contracting, see, when the right ventricle, when it is contracting, this tricuspid valve, it will bulge, it will little bulge into the right atria. So what happened to the pressure here in the right atria? Little increases because it's bulging. The valve is bulging into the right atria. So in the right atria, the pressure is going to little increase. Automatically in the internal jugular vein also, the pressure is going to little increase. So that's why. So C wave, I have written here. The C wave is due to bulging of tricuspid valve into right atria during ventricular contraction. So AXCR completed. Okay, the same. This is also during atrial relaxation only. Don't go too much into it. Okay, A completed, C completed, X completed. Now, bad. Okay, so after this, now what is this V wave? V wave is a positive wave. The pressure in the internal jugular vein is increasing, which means the pressure in the atria is also increasing. So remember V for V. What is that V for V? It's a venous filling of atria, right atria. Right atria is receiving the blood. Right atria is getting the blood. Okay, right atria, what it is doing? Right atria will receive the venous blood. So when right atria is receiving the venous blood, what happened to the pressure here? The pressure here increases. It's filling with the blood. Okay, it's filling with the blood. Gradually, it is filling with the blood. So the pressure in the right atria increases. Also, the pressure in the internal jugular vein increases. So V wave is due to venous filling of the atria, the passive atrial filling. The atria is getting filled. So the pressure in the atria increases. Also, the pressure in the internal jugular vein also increases. Okay. Next, Y wave. Y wave is a negative wave. It is decreasing. The pressure is decreasing. Y for, remember, Y for Y. Empty, EMPTY. Emptying. So atria are emptying the blood into the ventricles. Atria, rapid ventricular filling. You know it, right? So when the atria is emptying the blood into the ventricles, that's the opening of the tricuspid valve, 70% filling of the ventricles. So here the atria pressure decreases. Also in the internal jugular vein, pressure decreases. So Y wave is due to atrial emptying with the opening of tricuspid valve. The tricuspid valve open ho gaya, so the blood is coming into the ventricles. So the pressure in the right atria decreases. Also the pressure in the internal jugular vein decreases. So that's it. Okay. So these are the pressure changes in the internal jugular vein. Okay, these are the pressure changes in the internal jugular vein. A, C, X, V, Y. These are the pressure fluctuations in the internal jugular vein according to the pressure changes or according to the cardiac events of the right atria. According to the cardiac events of the right atria, the pressure in the internal jugular vein also changes. Sometimes increases, sometimes decreases. So these are the A, C, X, V, Y waves. A, C, V are the positive waves and X and Y are the negative waves. So is that clear? Guys, is that clear? So X dash, it's unnecessarily, it was given over there. It will unnecessarily confuse you. See, when the tricuspid valve goes up, it causes C wave. When the tricuspid valve will again come back to normal, that causes X dash. Don't go through that X dash. Not needed. When the tricuspid valve, if you want to know it, here it was already given. See, that X dash is the downward movement of the tricuspid valve. When the tricuspid valve come back to its normal, again the pressure decreases. Okay, that's it. At the same time, ventricle is also relaxing. So these are the ACX VY waves. ACX VY. So now I will be asking you some questions. You just try to answer them. So questions. Y wave is because of. Try to answer it. Y wave occurs during which phase? Y wave occurs during which phase of the cardiac cycle? Y wave. Y. Y means decreasing the last Y wave. Atrial emptying. Atria is emptying the blood into ventricles. Atria is emptying the blood into ventricles. That is rapid ventricular filling. Okay. Atria is emptying. See, atria is emptying the blood into the ventricles. With the opening of the tricuspid valve, 70% of the blood will fall into the ventricles. That is rapid ventricular filling. Okay. So Y wave is because of atrial emptying. Atria is emptying the blood. Okay. Next, so C wave is seen during. C wave is seen during. C wave is seen during ventricular contraction. Ventricular contraction. When the ventricle is contracting, that causes the bulging of the tricuspid wall. Leading to formation of C wave. Okay, the right ventricular contraction leading to the bulging of the tricuspid wall, leading to C wave. Okay, excellent, guys. Excellent. Okay. So you know about the jugular venous pressures also, AC, XV waves. Now what you have to know is, now this is the real topic. Abnormalities. JVP abnormalities. Now look carefully. Now look. No one will ask about the waves. Forget about the waves. No one is going to ask you about the waves. Okay. What they will ask you is, which condition may, right? Don't write everything. Only write absent A waves. In which pathological conditions A waves are absent? In which pathological conditions A wave are absent? There is a condition called as atrial fibrillation. In atrial fibrillation, atria is not contracting. Atrial fibrillation mein atria is not contracting. Atria is just quivering. It's just quivering. So when atria is not contracting, no A wave. Simple. You know, see, look, A wave is because of what? Tell me. A wave is due to atrial contraction. If there is no atrial contraction, no A wave. So there is a condition called as atrial fibrillation. In atrial fibrillation, A waves are absent. That's it. Simple. Only one thing. Next, large A waves are seen in which condition? Large A wave. For example, look, guys, once look here. Sir, this is right atria. This is right ventricle. Here is the tricuspid wall. Right? And this is the pulmonary trunk. Here is which wall? Pulmonic wall. If there is a stenosis, see, there is a stenosis. This valve is stenosed or this valve is stenosed. Okay. So now the blood can't go forward. The blood is not able to go forward because of the pulmonic stenosis or tricuspid stenosis. The blood is not able to go forward. So now right atria have to generate more pressures. To push the blood forward. So what happened to the pressures in the right atria? More. So what happened to the pressures in the internal jugular vein? More. So that's why large A waves. Okay, there is large wave. The pressure is increasing in the internal jugular vein. The pressure, because the blood is not going forward easily. Back pressures are generated. Because of the back pressures, there is more. There is a large A wave. So large A waves are seen in tricuspid stenosis or pulmonary stenosis. You can say pulmonic embolism, pulmonary hypertension also. Okay. So large A waves are seen in at least tricuspid stenosis, pulmonic stenosis. Done. Next, canon A waves. Okay, canon A waves. I have said you in the beginning, sir. First atria should contract. Later on, the ventricle should contract. First atria should contract. Later on, ventricle should contract. But there are conditions where both atria and ventricle are contracting at the same time. That is called as AV dissociation. Okay, AV dissociation, atrioventricular dissociation, or complete heart block, or third degree heart block. In third degree heart block, there is no coordination. Atria are beating on their own, ventricle is beating on its own. So both atria and ventricle can beat at the same time. When they are beating at the same time, now tell me what happens. So when they are beating at the same time, means the whole heart, the atria and ventricles, they are contracting at the same time. So what happened to the pressure in the atria? It increases so much because the blood is not able to go down. Because at the same time, ventricle is also contracting. Okay, let me draw it again for you. For some students who doesn't understand, look. Normal. What is normal? Let me write here. What is normal? Normal is, first the atria should contract. When the atria is contracting, the blood should go into the ventricle. But right now, what I'm teaching you, right now, the valve is closed. The tricuspid valve is closed. Atria is contracting as well as ventricle is contracting at the same time. So the blood is unable to go down. So the valve is closed here. So what happened to the pressure here? Increases. Both atria and ventricle are contracting at the same time with the closed tricuspid valve. Tricuspid valve is closed. So what happened to the pressure here? Increases, and JVP may also increases. The pressure, right? The A wave is going to be like this. Canon A waves. So what is this? Right atria is contracting while the tricuspid valve is closed. During right ventricular systole, both means right ventricle is contracting as well as right atrium is contracting at the same time. It is seen in AV dissociation or third degree heart block. That's it.
three things completed. What are they? Large A waves seen in tricuspid stenosis, pulmonic stenosis. Canon A waves. Canon A waves are seen in third degree heart block or AV dissociation. And absent A waves. Absent A waves are seen in atrial fibrillation. Absent A waves are seen in atrial fibrillation. No doubt. After this, what else you should know for your exam? For your exam, what you should know is look the pattern. Okay, I want you to look the pattern. Look the pattern. See, it's just looking like this, right? First, look at this pattern. Okay, it's like a wolf. Okay, something like this. So the same pattern, I will show you one more place. The same pattern, sideways, like it's the same pattern. And let me show you in one more place. Same pattern. Here also look. Okay, so what I'm trying to put into your mind is there is a condition called as tricuspid stenosis. Okay, tricuspid stenosis. One. Second, tricuspid, again here also. See, severe tricuspid. Sorry, not tricuspid stenosis, guys. Tricuspid regurgitation. Sorry, tricuspid regurgitation. One. Here, severe tricuspid regurgitation. Two. And third one here. Here also see tricuspid regurgitation. So in tricuspid regurgitation, in one single condition called as a tricuspid regurgitation here, as well as here tricuspid regurgitation, and as well as here tricuspid regurgitation. So three JVP abnormalities are going to be seen. What are those JVP abnormalities? So this is the question which was asked in the recent FMG exam. So let me write here. If a patient is having tricuspid regurgitation, three JVP changes can be seen. What are those three JVP changes? One is tall V wave. Okay, tall V wave, blunted X descent, and prominent Y descent. Okay, prominent Y descent. So this is what you want to know. They will ask you in your exam, in tricuspid regurgitation, all of the following are seen except. So if a patient is having tricuspid regurgitation, tricuspid valve is not closing properly, the blood is going back, tricuspid regurgitation, there will be tall V wave. Okay, tall V wave, blunted X descent, and prominent Y descent. Okay, these three things. So this is a super high yielding thing. Tricuspid regurgitation, these three things. Okay. So again, I'm asking you, let me see whether you can answer it or not. Guys, try to answer this. Atrial systole. Sorry, not atrial systole. Atrial asystole. Atrial asystole means atria is not contracting. So A waves are absent. Seen in which condition? Absent A waves are seen in which condition? Absent A waves. AF, atrial fibrillation. Next, canon A waves are seen in. Canon A waves are seen in. Canon A waves. Third degree heart block or complete heart block or AV dissociation. Okay, AV dissociation or third degree heart block. Excellent guys. Next, tall A waves or large A waves. Tricuspid stenosis, pulmonic stenosis. Okay, if a patient is having tricuspid regurgitation, three JVP changes are going to be seen. What are those three JVP changes? Tall V waves, prominent Y descent, and blunted X descent. Blunted X and prominent Y. Okay, so even just wait. I want you to know a little bit more. See here, the rapid revision sessions also I gave. See, the C is given a bold letter. Why C? Because C is the most important thing. C is due to bulging of the tricuspid valve during isovolumetric contraction. Okay, you know it. When the ventricle is contracting, tricuspid valve bulges. Okay, now look here. You try to answer them. Absent A waves, you know it. Already you know it. Atrial fibrillation. Large A waves, tricuspid stenosis, pulmonic stenosis. Okay, tricuspid stenosis, pulmonic stenosis. Okay, canon A waves, you know it. Canon A waves are seen in
Third degree heart block, complete heart block, AV dissociation, you know it. Now, tall V waves, blunted X descent, and prominent Y descent, these three things are seen in tricuspid regurgitation. Till here, you know it. Till here, you know it. But I'm adding a little bit more. Guys, a prominent Y descent, hai na? The prominent Y descent. Just wait for a minute. Yeah. This prominent Y descent, it is seen. Yes, of course, it is seen in tricuspid regurgitation. Of course, it is seen in tricuspid regurgitation. But the prominent Y descent is also seen in, please write. Prominent Y descent is also seen in constrictive pericarditis. There is a condition called as constrictive pericarditis where prominent Y descent is seen. Okay. And the same constrictive pericarditis in this condition, constrictive pericarditis, okay, even prominent X descent is seen, which means prominent X descent as well as prominent Y descent. You have to by heart this. It's a total pathology thing. In medicine, they will come again. So prominent Y descent, prominent X descent, prominent X, prominent Y, both prominent X, prominent Y, both are seen in constrictive pericarditis. Okay. In constrictive pericarditis, both X descent and Y descent are prominent. Okay. Done. So again, from the beginning, from this same thing, absent A waves, atrial fibrillation, large A waves, tricuspid stenosis, pulmonic stenosis, also seen in pulmonary artery hypertension, but that's not that important. Canon A waves are seen in third degree heart block, complete heart block, AV dissociation. See, these three things together, tall V waves, blunted X descent, prominent Y descent, these three things are seen in tricuspid regurgitation, but this prominent Y descent is also seen in, okay, prominent Y descent. Okay, let me add with some other color. Prominent Y descent is also seen in constrictive pericarditis, and in constrictive pericarditis, X descent is also prominent. Okay. Now, there is a condition called as cardiac tamponade, CT. Cardiac tamponade. Even in this cardiac tamponade, the X descent is prominent. Cardiac tamponade, X descent is prominent. Cardiac tamponade, X descent is prominent. So I will give you one question. You just try to answer them. Okay, you just try to answer them. Answer. Sir, if a patient is having constrictive pericarditis, what are the JVP changes that are going to be seen? Constrictive pericarditis. In a condition called constrictive pericarditis, what is the JVP changes that are going to be seen? Both prominent X and Y. Okay, both prominent X and prominent Y. Tell me, in cardiac tamponade, what you will see? Prominent X. Okay, sir, in tricuspid regurgitation, what you will see? Three things: tall V, blunted X, prominent Y. Okay, prominent Y. Sir, in tricuspid stenosis, what you will see? Tricuspid stenosis, large A. So this is what you need to by heart. Okay, I'm taking this and I'm keeping in our PDF also. I'm just keeping it. Paste. So all things in one single place, I have kept it over here. So with this, jugular venous pressure is also important. Jugular venous pressure abnormalities also completed. Okay. Important for your exam, whatever is needed for your exam. If you know this much, not NEET PG, even INICT also, only these are the abnormalities what they will ask you. In INICT, they can't discover something new, same things. Okay. Thank you, Jyoti. Yeah, I'm trying to integrate as much as possible, because medicine, these are all medicine things. Even in medicine also the same things will come. So when Priyansh sir, most probably Priyansh sir will be taking your medicine. When Priyansh sir is taking your medicine, it will be easy for you. Something like that. Okay. Rekha, you're asking, sir, there is a possibility to upload the first half of the today's class, 2 hours lecture early in the app. I don't have any command over that, but if you want that, I will ask the people to do it.
Okay, I will ask the management to do it, to upload it as app. Okay, as soon as possible. Okay, chalo. Next, the last slide before the break. After this, I'm going to give you the break. Sir, what is Kusumal sign? क्या है Kusumal sign क्या है? Let me tell you what is Kusumal sign. Now, when you actually do inspiration, don't write anything. Listen carefully with both your ears. Inspiration. When you do inspiration, what happened to your thoracic volume? So thorax, okay, thoracic volume increases. When I do inspiration, try to do it once, do it inspiration. When you do inspiration, your thorax is going to expand, your chest wall is going to expand. Your chest wall is going to expand. Aha, okay. When your chest wall is expanding, what happened to the pressures in the thorax? Pressures decreases. The pressure in the thorax decreases. The pressures decreases. When the pressure is decreases, also the right atrial pressure. Okay, the right atrial pressure decreases. Okay, actually, to be very frank, let me tell you what exactly happens. Look, alright guys, look. I'm trying to do the inspiration. See, I'm trying to do the inspiration. When I'm trying to do the inspiration, thoracic volume expands. Thoracic volume expands. When volume expands, pressure decreases. You know Boyle's law. When volume expands, pressure decreases. Pressure decreases. Whenever the pressure decreases, also in the jugular venous pressures, the pressure decreases, sir, actually. Okay, when the thorax is expanding, look, when the thorax is expanding, actually here the pressure decreases. Negative pressure is generated here. Negative pressure in the thorax, negative pressure is generated. That the negative pressure is called as a vacuum. That the vacuum sucks the blood towards the heart. The vacuum, it sucks the blood towards the heart. So the blood pressure here in the internal jugular vein decreases. So normally during inspiration, let me write here. This is, don't confuse. Let's make it as simple as possible. During inspiration, your JVP should decrease. It should decrease. If it is not decreasing or increasing, if it is not decreasing or increasing, if it is not decreasing or increasing, then it is called as Kusumal sign. This is called as what? Kusumal sign. Okay, look here. Here I have written very clearly. Typically means normally the JVP should decrease with inspiration. Why it should decrease? Because the negative intrathoracic pressure, when you are inspiring, the vacuum is developed in your thorax. It sucks the blood towards the vena cava. Okay, it sucks the blood, okay, from the internal jugular vein into the vena cava and towards the heart. When there is a lack of decrease, it is not, if it is not decreasing, or rather if it is increasing in the JVP during inspiration, this is called as, this finding is called as Kusumal sign. This is called as what? Kusumal sign. And this Kusumal sign is seen in which condition? Kusumal sign is classically seen in two conditions. That is constrictive pericarditis. Don't forget, previously we have discussed in constrictive, prominent X descent, prominent Y descent, both are prominent. In constrictive, don't forget, don't confuse. See, constrictive pericarditis, pericarditis, both are prominent. Prominent Y, prominent X. Okay, so that same constrictive pericarditis. How to remember, sir? Constrictive, something like K. So similar thing, right? Constrictive Kusumal sign. Constrictive Kusumal sign. So in constrictive pericarditis, as well as one more pathological condition called as restrictive cardiomyopathy. At least these two you should know for your exam. At least these two. So constrictive pericarditis and restrictive cardiomyopathy, the patient is going to have Kusumal sign, which means the jugular venous pressures are not going to decrease. They will not decrease. They won't decrease in these two pathological conditions. Okay, because in this condition, heart is not going to relax. Heart is not going to relax properly. So the pressures here are going to be more. The pressure here is going to be more, because in constrictive pericarditis and restrictive cardiomyopathy, heart is not relaxing properly. So it is not receiving the blood properly. So the pressure here, the back pressures are going to be elevated. So that will cause Kusumal sign. Okay. So with this, Kusumal sign also completed. So shall we take a break? Now what's the time now? It's 1:12 in India here. Shall we take a break? Yes. Now the break is going to be till 2 o'clock. Okay, the break is going to be till 2 o'clock. That's a 50-minute break. I believe that Priyansh Jain sir is going to take the class. Najib, I want to take the break because this is the time. 1 to 2 o'clock is my break. Okay, the food is ready in this time, so I have to go and get it. Okay, so that's why. Okay. Okay, Raj, I exactly don't know who's taking the classes. I think that Priyansh Jain sir is going to take the class because my notes and his notes are like little similar because I am trying to integrate as much as possible, which is going to be similar to his notes. Okay. Yeah. Break. See you at 2 o'clock, guys. Bye bye. If you have any doubt, please put it in the chat box. Bye bye. Guys, can you see me? Hello guys, it's 2 o'clock. Can you see me? Okay, yes. Okay, now we have to complete the cardiovascular system. ASAP, you got the full energy. Good. So yeah, breaks are much needed so that you can refresh yourself and you'll get the energy. Yeah, without break, if you are going continuously, that will make us tired. You'll get tired very easily. Okay, so what happened? 5 minutes, power gone. Just 5 minutes, sir, please. So anyway, let's try to have the recap. Okay, let the others join. Just let me do the just normal recap. Okay, so in cardiovascular system, the ventricular myocyte action potential, 5 important questions. Same. Ventricular myocyte action potential. The depolarization is due to ventricular myocyte. Ventricular myocyte depolarization is dependent on which ion? Ventricular myocyte, think. Sodium. Okay, if I'm talking about SA node, it is calcium. If I'm talking about SA node, it is calcium. If it is ventricular myocyte, it is sodium, right? Next thing, sir, in which condition the patient is going to have both prominent X descent and prominent Y descent? Both prominent X and Y descent are seen in constrictive pericarditis. Okay, constrictive pericarditis. Excellent. Okay, excellent. Now, what is the condition in which you are going to have large A waves? Large A waves. Tricuspid stenosis, pulmonic stenosis. Okay, tricuspid stenosis, pulmonic stenosis. Not aortic, tricuspid. Tricuspid, right side. We are talking about right side. JVP is all about the right side. Okay, Sai Pranati, JVP is all about the right side. So no aortic. So aortic stenosis, tricuspid stenosis, pulmonic stenosis. If you can remember also pulmonary artery hypertension. Even pulmonary artery hypertension, large A waves can be seen. Okay, large A waves can be seen. Tell me, sir, in which conditions you will see the Kusumal sign, K, Kusumal sign. Kusumal sign means JVP is increasing. JVP is increasing during inspiration. Constrictive pericarditis and restrictive cardiomyopathy. Constrictive pericarditis and restrictive cardiomyopathy. These are the two conditions in which you are going to see the Kusumal sign. Sir, in the left ventricular pressure volume loop. Okay, in the left ventricular pressure volume loop, let me see whether you can answer it or not. In the left ventricular pressure volume loop, can you tell me this kind of pattern? Okay, this kind of pattern is seen in which abnormality? Both sides. Red is abnormal. So this red color thing is seen in which abnormality? Mitral regurgitation, MR. In mitral regurgitation, mitral stenosis mein chota. Okay, mitral stenosis small, mitral regurgitation, both sides is going to extend. Okay, can you tell me how much percentage of the ventricular filling is active? How much percentage of the ventricular filling is actively done? How much percentage? 30%. Sir, can you tell me in which phase you will see the S3? In which phase you will see S3? Rapid ventricular filling. Rapid filling. Okay. S2 heart sound is heard during S2. S2. Protodiastole. S2, protodiastole. Okay. Sir, here I want to add a point. Okay. Look, please add this point. S2 is heard during protodiastole. Every student knows this. Look here carefully. S2 is heard during protodiastole, that is 80 to 79, such a small phase. But in one of the Indian exams, the protodiastole is the best answer, no doubt. In one of the Indian exam, protodiastole was not given. Protodiastole option was not given. Then the next best answer is the beginning of the isovolumetric relaxation. Simple, right? It's the same thing. In the beginning of the isovolumetric relaxation. So please take it as a note. If S2 is heard
please take it. S2 is heard in protodiastole. If you don't see this, if this is not available, this is the best answer. If you don't find this, then you can also mark isovolumetric relaxation. That's also correct. Okay. S2 is heard in protodiastole. If you don't find protodiastole, then answer isovolumetric relaxation. That's it. So recap completed. Now let's go further. So central venous pressures, not that important, but long back the questions has been asked in FMG exam. So what is the central venous pressure, sir? Let's make it as simple as possible. Central venous pressure. Central venous pressure is the right atrial pressure. Okay, let me draw here. So this is the heart, the 4 chambers of the heart. What is this one? Pulmonary trunk. The pulmonary trunk later divides into pulmonary arteries. And where it is going? The pulmonary trunk will go to the lungs. It will go to the lungs. And from here, oxygenated blood will come to the left atria. This is the left atria. This is the right atria. Now, what is central venous pressure? Central venous pressure is the pressure in the right atria. That's it. So central venous pressure is the right atrial pressure. Simple. Let's remember it as simple as possible. Right atria mein how much pressure is there? See, all the venous blood will come to where? Right atria. So the name itself is center for the venous blood. Center for the venous blood is right atrium. So the right atrial pressure is nothing but the CVP, central venous pressure. Okay. Okay. Now, in which conditions the CVP will go up? In which conditions may the central venous pressure will go up? Okay. For example, look, what is this wall? This wall is the tricuspid wall. Okay. What is this wall? This is pulmonic wall. Okay. Let me write here. Pulmonary wall. This is the tricuspid wall. Okay. Now, this here is the left ventricle. Look here very carefully. Left ventricle. From here, who is going to go out? This is the aorta. Now, listen carefully. Sir, this is the normal pathway, right? This is a normal pathway. Let me put in the green color. The blood have to come like this. The blood have to move like this, move like this, move like this, move into the lungs. Blood have to go like this. Go. This is the normal route. How the blood is going to travel. Array, here, for example, left ventricle is not contracting properly. Left ventricular failure. Okay, left ventricular failure. What happens? There will be back pressure that is generated. See, back pressures are going to generate. The pressures increase like this, increase like this, and increase like this. So what happened to the CVP? CVP increases. So in which conditions the CVP increases? See, in cardiogenic shock or left ventricular failure. Yes, CVP increases. Cardiogenic shock means left ventricular failure, right? Both are same, cardiogenic shock or left ventricular failure. In left ventricular failure, CVP increases. And not only that, even right ventricular failure. If right side heart failure, for example, see, this right side heart is not contracting. If right side heart is not contracting, again back pressure generates. The pressure in the right atria increases, CVP increases. So both, the point which I want you to know is, both in right ventricular failure as well as left ventricular failure. Right ventricular failure, left ventricular failure, the CVP increases. Okay. Okay. Now, imagine if you are having a thrombus here, that is, for example, like pulmonary embolism. Now you are having pulmonary embolism, pulmonary artery embolism, pulmonary artery embolism. If there is a pulmonary artery embolism, what happened to the back pressure? Back pressures are going to be more. Okay, the blood is not going in forward direction. So there is development of back pressures. So again, in pulmonary artery embolism, CVP increases. The same thing I have written here. See, pulmonary embolism, CVP increases. Okay, CVP increases. Next, for example, here pulmonary artery pressure is more. Pulmonary artery hypertension. The patient is having pulmonary artery hypertension. If the patient is having pulmonary artery hypertension, again here the blood is not able to go forward. Okay, because already here the pressures are high. Pulmonary artery pressures are high. So now the blood can't go in the forward direction. So the pressures are going to be more. So in the pulmonary artery hypertension also, see, pulmonary hypertension also, the CVP is going to be more. Okay. So again, for easy understanding purpose, let me draw. Okay, simple diagram in a minute. Sir, this is your heart. Okay. From here, the blood is going to the lungs. Okay, the blood is going to come back to the left atria. From here, the blood will go to the aorta. So one by one. In left ventricular failure, back pressures are generated. Okay, back pressures are generated, you know it. And right ventricular failure also, back pressures are generated. So that will lead to right atrial pressure. Right atrial pressure increases, which means CVP increases. In pulmonary artery hypertension, back pressures are going to be more. And in sorry, in pulmonary embolism also, the blood is not able to go forward. So central venous pressures are going to be more. Okay. Now look here carefully. In the conditions like tricuspid stenosis, this tricuspid valve is stenosed. This tricuspid valve is stenosed, or pulmonary stenosis. Again, the blood is not able to go forward. So back pressures, the pressures are going to be more. So in tricuspid stenosis, in pulmonary stenosis, again CVP increases. So let me write here. I need to add this. So tricuspid stenosis and pulmonary stenosis, and even in tricuspid regurgitation. Okay, what is tricuspid regurgitation? Tricuspid regurgitation means, see, the blood is going back from the tricuspid wall. The blood is going back. Let me just erase this. Tricuspid regurgitation means unnecessarily blood is going back. So again, CVP increases. So let me write here. Tricuspid stenosis में, pulmonic stenosis में, tricuspid regurgitation, pulmonary artery hypertension, pulmonary embolism, right-sided heart failure, left-sided heart failure, all these conditions. Okay, constrictive pericarditis. What is constrictive pericarditis? In constrictive pericarditis, see, for example, if this is the heart, the pericardium around the heart is totally calcified. Okay, so heart is not able to relax. Heart is not able to relax properly. So what happened to the pressures inside the heart? All the pressures inside the heart increases. All chambers may pressures increases. So automatically, right atrium may pressure also increases. Right atrium may pressure also increases. So even in constrictive pericarditis, this example, the pericardium is calcified. So even in constrictive pericarditis, the CVP increases. Okay. And what is cardiac tamponade? What is cardiac tamponade? Cardiac tamponade means if this is the heart, for example, the heart is totally surrounded by blood. For example, this is the pericardium. This is the pericardium, and blood is leaking here. See all this place in the pericardial cavity, blood is getting accumulated. The blood is going to clot. Okay, the blood is going to clot, and what it's doing? It's going to compress the heart from all the sides. It's going to compress the heart. This blood which is present in this area, it's going to compress the heart, and the pressures inside the heart are going to be more. So even in cardiac tamponade, the CVP is going to be more. Central venous pressures are going to be more. So that's it. That's it. So guys, now please tell me what are the conditions in which the CVP increases. First, CVP means right atrial pressure. CVP का meaning है what is the pressure in the right atrium. What are the conditions in which the CVP increases? Right sided heart failure, like cardiac tamponade. I will come there. Right sided heart failure, left sided heart failure, right sided heart failure, left sided heart failure. Tricuspid stenosis, tricuspid regurgitation, pulmonic stenosis, pulmonary artery hypertension, pulmonary embolism, constrictive pericarditis, cardiac tamponade. अरे पूरा का पूरा conditions में CVP is going to be more. You can ask me why you are teaching this, sir. Because previous years में like somewhere around 2016-15 area FMG exams में like long back this question was asked. Two times this question was asked. All of the following conditions में CVP increases except kind of question. Okay. All of the following conditions CVP increases except this will also come in surgery also. Okay, the same thing will come in surgery also. CVP means right atrial pressure. CVP means right atrial pressure. Okay, so someone is asking, what is cardiac tamponade? Just give me a minute. Let me show you in reality. Let me stop the screen sharing for a second. Let me stop the screen share for a second. Just wait. Let me show you. Okay, it's not there. Okay, I think I have uninstalled it, but no issue. I will show you my mobile. So first look.
You can also watch this in my Instagram page. See, look here. This is how the cardiac tamponade is going to be. The person is going to have, see, this is how the cardiac tamponade. See, there is total blood accumulation around the heart. This is how, okay, there is total blood accumulation around the heart. So that blood clot will compress the heart. That blood clot will compress the heart. Okay. So when the blood is compressing the heart, see, there is a, I will explain you. Don't worry, I will explain you. Okay, see, that's the blood clot. Now, why it happened? Why it happened? Let me tell you. Yes, heart swings, heart swings. Look at this. Let me explain you what exactly happens here. Guys, imagine this is your heart chamber. Okay, this is your 4 heart chambers. Okay, now heart is surrounded by what? Heart is surrounded by pericardium. Okay, now this patient had a myocardial infarction. See, this part of the heart is dead. Myocardial infarction. This part of the heart is dead. Okay, this part of the heart is dead. Now, after some time, if that's the dead area, it's going to be weak. It's going to be weak. What happens is there is a chance that this part will undergo rupture. This part rupture ho gaya. That part is ruptured. So whenever it's ruptured, blood will start to come out into the pericardial cavity. Blood will start to come out into the pericardial cavity. Now, see, now the blood is going to surround the heart. Now this blood will start to compress the heart. Now this blood is compressing the heart. Okay, so right atrium pressure, what happens? Increases. So CVP, what happens? CVP increases. So in cardiac tamponade, okay, in cardiac tamponade, the CVP is going to be more. In constrictive pericarditis, also same thing. The heart is surrounded by the calcified pericardium. This is also there in my Instagram. Okay, this is also there in my Instagram page. So calcified pericardium. The pericardium is calcified. It will start to compress the heart. So in all these conditions, CVP increases. By heart rate. Okay. Then, sir, in which conditions the pressure in the right atria decreases? In which conditions? Okay, in which conditions the CVP decreases? Or if less venous return, if less blood is coming to the heart, CVP is less. In hypovolemic shock means hypovolemia, there is less blood volume. Hypovolemic shock means the patient is having, for example, hemorrhage. Okay, he is having hemorrhage, means blood loss. If he is losing blood, what happened to blood volume? His blood volume is less. If his blood volume is less, what happened to his venous return? What happened to the venous blood that is coming to the heart? Less venous return. When there is less blood coming to the right side of the heart, what happened to the pressures in the right atria? Automatically decreases. So in hypovolemic shock, not cardiogenic, in hypovolemic shock, CVP decreases. Whenever venous return decreases, CVP decreases. Okay, excessive, this is C. Okay, excessive vasodilation or venodilation. This is very, very important. Most of the students will get confused over here. Look, this is your heart. This is the inferior vena cava. Okay, this is the veins. These are the veins and inferior vena cava. Here is the superior vena cava. What happens if there is vasodilation or venodilation? There is venodilation. Whenever there is venodilation, the venous return decreases. Now venous return decreases. Whenever venous return decreases, what happens to the CVP? Central venous pressure decreases. Less blood is coming. Less venous blood is coming. So venodilation, when the veins are dilated, very, very important. When your veins are dilated, blood will pool. Okay, blood is going to pool in your extremities. Okay, so venodilation decreases the venous return, decreases the CVP, central venous pressure. So that's why excessive vasodilation or venodilation decreases the venous return. So automatically CVP also decreases. So that's it. This topic is also completed. Small topic. In which condition CVP increases, which condition CVP decreases. Okay. So for me, please close your eyes once and think. CVP is increased in which conditions? Okay, CVP increase in which conditions? Think, close your eyes and think. Sir, CVP is increased in right-sided heart failure, left-sided heart failure, tricuspid stenosis, tricuspid regurgitation, pulmonary stenosis, pulmonary artery hypertension, pulmonary embolism, okay, constrictive pericarditis, cardiac tamponade. That's it. That's it. CVP is the pressure in right atria. CVP is the pressure in right atria. Okay? Done. Now, after this, the next topic that I'm going to discuss here is the concepts of preload and afterload. For the next 15-20 minutes, we have to discuss this concepts of preload and concepts of afterload. What is this concept of preload and afterload? Now you already know about the preload. Let me draw here. What is preload? For example, here I am talking about the left ventricle. How much blood is going to be there in the left ventricle before contraction? Before contraction, there will be 120 ml. Okay, 120 ml of blood. Okay, so that 120 ml of blood is called as the end diastolic volume. That is nothing but preload. So preload depends on what? If more blood is coming to the left ventricle, preload automatically increases. So preload is the blood volume. Preload is how much amount of blood. Preload is the blood volume. It depends on what? Venous return. Venous return. So students will have it out. Okay, let me draw it in a better way. Look at this. This is aorta on this side aorta. And what is this? This is inferior vena cava. Okay. Here I'm drawing. This is pulmonary trunk. Here I'm showing the pulmonary trunk in green color. These are the lungs. Here is the pulmonary. These are the pulmonary veins. These are the pulmonary veins. Now look, from your body, this is the inferior vena cava, IVC, inferior vena cava. Imagine more blood is coming. More venous blood is coming to the heart. If more venous blood is coming to the heart, more is coming in the right atria. More blood will be there in the right ventricle. More blood will go to the lungs. Okay, more venous blood will go to the lungs. More blood is getting oxygenated. So more blood will come to the left atria and more blood will come to the left ventricle. So more blood, instead of 120, maybe it will become 160. So what happens to the end diastolic volume? End diastolic volume increase. So if more is the venous return, more will be the preload. So preload is dependent on how much is the venous return. Preload is dependent on how much is the venous return. So that's the key point. So preload depends on what? Venous return. Venous return. Okay, done. Then what is afterload? And it is dependent on what? Okay, then you need to know what is afterload. Afterload. Any one of you, do you know what is afterload? Preload is 120 ml blood. Preload is 120 ml blood. What is afterload? Ye kya hai? Afterload, look. Draw this diagram. This is very important. It's not there in your book. Let me draw it in red color. Just its color change. Nothing much. So draw this. Now here I am talking about the left ventricle. Okay, left ventricle. Can you tell me what is this wall? If it is the left ventricle, what is this wall? This is your aortic wall. Okay, here is your aorta. Now what is afterload, sir? Afterload means how much pressure is required by the left ventricle. How much pressure is required by the left ventricle to open this aortic wall? Aortic wall को open करने के लिए how much pressure is required? See, for example, in aorta, how much is the pressure? 80. Now, left ventricle have to generate how much pressure? 81. To open this aortic wall, to open the aortic wall, the left ventricle have to generate how much pressure? At least 81. So, what is afterload? Pressure required by left ventricle to open aortic wall. Okay. So, that is called as afterload. That is called as afterload. For example, now let me tell you. Here the pressure is not 80. Normally it should be 80. Now imagine the pressure here is maybe 110, for example. Now how much pressure the left ventricle have to generate? 111. The left ventricle have to generate a pressure of 111. So what happened to the afterload? Now afterload increased. Now left ventricle have to work more. Now the load is more. Load is more. Now the left ventricle have to generate more pressure. Okay, more pressure to open the aortic wall. Okay. Now you know what is afterload. It's the pressure required by the left ventricle to open the aortic wall. It depends on what? Afterload depends on what? Let me tell you. Okay, let me just erase this here. What afterload is dependent on what?
See, this is aorta. After aorta, what do you have? Arteries. These are arteries. These are arterioles. These are the arterioles. Okay, arteries and arterioles. Now, your arterioles are having smooth muscles. Okay, your arterioles, they are having what? Smooth muscles. They are surrounded by the smooth muscles. Arterioles are having smooth muscles. Okay, let me show it with the dotted lines. Arterioles are surrounded by what? Okay, let me show it the green color. Okay, arterioles are surrounded by smooth muscles. Now, right now, your arterioles are totally dilated. Your arterioles are dilated. Okay, your arterioles are dilated, which means they are wide open. They are wide open. So left ventricle is contracting. Blood is coming into the aorta. The blood can easily go into arteries. From here, the blood can go into arterioles and later it will go into the capillaries. Easily. The blood is moving easily. Easily like this. Easily. Okay. But now, let me take a condition where your arterioles are constricted. Your arterioles, they are totally constricted. They are constricted, sir. Because of the contraction of the smooth muscles, your arterioles are constricted. Now you tell me, sir, do you think the blood can go easily in the forward direction? The blood is not able to go easily. Easily it can't go. So what happened to the pressures in the arteries? Badh jayega. The pressure in the arteries badh jayega. So what happened to the pressure in the aorta? Automatically increase, sir. It's not going to be 80. Now maybe it's going to be 130, for example. So now if it is 130, left ventricle have to generate a pressure of 131. Aha, so afterload increased. So now tell me, afterload depends on what? Afterload depends on arteriolar resistance. Arteriolar resistance. If arterioles are constricted, more resistance. Now more afterload. More afterload. If arterioles are dilated like this, see, if the arterioles are dilated, now there is less resistance. Now, what happened to the pressure here? 80. You need to generate a pressure of just 81 is enough. Aha, okay. So now tell me, sir, afterload depends on what? It depends on vascular resistance. Okay, that is also called as total peripheral resistance. Total peripheral resistance. Total peripheral resistance. So one by one, let me write here. Say the afterload depends on what? Total peripheral resistance, TPR, total peripheral resistance. Okay, whether the resistance is more or less. This total peripheral resistance is maximum with which blood vessels? Arterioles. Arterioles have maximum resistance. Why arterioles have maximum resistance? Because they have maximum smooth muscles around them. Okay, so afterload, it is dependent on what? Afterload dependent on the vascular resistance, whether the vessels are dilated or constricted. Okay, so afterload depends on the total peripheral vascular resistance, or simply total peripheral resistance. The total peripheral resistance is maximum with arterioles. Why? Because they have maximum smooth muscles. So, do you understand what is afterload? This is what I want. Afterload is the pressure. Afterload is the pressure. Preload is the blood volume. Okay, afterload is the pressure, preload is the volume. So is that clear, guys? This is a little difficult topic, but easy. If you understand, it is easy. Pressure required by the left ventricle to open the aortic wall is called as the afterload. Afterload dependent on vascular resistance. If the vessels are constricted, if the arterioles are constricted, the afterload will be more. If the arterioles are dilated, the afterload will be less. Easily the blood will go. So less pressure is enough. Less pressure is enough. Okay. So same things. Let's go one by one. So afterload depends on what? Total peripheral vascular resistance. I have explained you. Total peripheral TPR is maximum with what? Arterioles. Total peripheral resistance is maximum with arterioles because they have maximum smooth muscles. Okay, which blood vessels have maximum smooth muscles? Which blood vessels have maximum smooth muscles? Arterioles, MCQ. Which blood vessels have maximum smooth muscles? Arterioles, MCQ. Okay, done. Now, first let's talk about some changes in the venous return. Changes in the venous return with the different positions, how venous return changes. Okay. So there is a muscle in your leg, guys. There is a muscle in your leg called as a soleus. There is a muscle in your leg called as a soleus. If that muscle is contracting, if you walk, if you run, if you jog, that soleus muscle in your leg will contract. It will compress the veins in your legs. Okay, it will compress, it will squeeze the veins in your legs. So when the veins are squeezed, more blood is pushed towards the heart. When the veins are being squeezed, the blood will be pumped towards the heart, will be pushed towards the heart. So when you compress, see the soleus, which is a calf muscle, which is there in your leg, it compresses the veins in leg and increases the venous return. Increase the venous return. Done. Completed. Okay. So one thing, soleus increases the venous return. Whenever venous return increases, what happened to the preload? Preload also increases. You know it, because preload depends on venous return. Okay. You already know it, right? If you increase the venous return, more venous blood is going to the heart, so more will be the preload. Simple. When you do inspiration, simple. When you do inspiration, I have said you, sir, whenever you are doing inspiration, in your thorax, vacuum is developed, your thoracic volume increases. That creates vacuum, negative pressure. That vacuum will suck the blood towards the heart. So, okay, more blood is going to the heart. During when you do inspiration, more blood will go towards the heart. So what happened to the venous return? Venous return increases. Okay, when during inspiration, more blood will be pumped towards the heart, or more blood will be pushed towards the heart. So venous return increases. Okay, when you go from standing position like this, see, when you go from standing position to lying down position. Okay, when you go from standing position to lying down position, now when you are standing, gravity is dragging the blood down. Gravity is trying to pull the blood down. But when you go and lie down like this, more blood will go to the heart, because there is no gravity. More blood will be pumped towards the heart, will be pushed towards the heart. When you are standing, the blood will be gravitated. But when you are lying down, more blood will go to the hearts, because there is no effect of gravity. So lying down position increases the venous return. Inspiration increases the venous return. Soleus muscle increases the venous return. Okay, I have said you, already discussed with you, the vasodilators. When the veins are dilated, venous return decreases. But when the veins are constricted, more venous return. Okay, and arterioles also I have discussed. Just now I have discussed the arterioles. Sir, when the arterioles are dilated completely, here, look here. Look at this diagram. When the arterioles, when they are dilated, like this, when the arterioles are dilated, what happened to the total peripheral vascular resistance? Resistance is going to be less. So afterload is going to be less. When the arterioles are constricted like this, what happened to the resistance? Resistance is more. What happened to the afterload? Afterload also increases. So same thing. Arteriolodilators. When you dilate the arterioles, resistance decreases. Say total peripheral resistance decreases. Automatically afterload also decreases. So with this, the concepts of preload and afterload are completed. And I will ask you, okay, the concepts of preload and afterload. So now let me ask you some questions. Okay, now let me ask you some questions. You just try to answer them. Okay. Let me see who can answer this. These are a little tricky, but anyway. Preload. Is it blood or is it pressure? Preload. If I'm talking about preload, is it blood or is it pressure? It's blood. It's all about the blood. Okay, what is the normal preload? Can you tell me? What is the normal preload? How much value? Preload value 120. 120. What about the afterload? Is it blood or is it pressure? It's a pressure. Which pressure? Pressure generated by the left ventricle to open the aortic valve. Aortic valve ko open karne ke liye, to open the aortic valve, how much pressure is required? What is the normal afterload? 81. Simple. 81. Simple. Normal afterload is 81. Okay. Now tell me, afterload, it is dependent on what? Afterload is dependent on TPR. Afterload is dependent on the total peripheral resistance. How much is the resistance? More resistance, more afterload. More resistance, more afterload. So total peripheral vascular resistance, okay, total peripheral vascular resistance, or simple TPR, is maximum with which blood vessels? Aorta, arteries, arterioles, venules, veins.
arterioles. TPR is maximum with arterioles. TPR is maximum with arterioles. Because arterioles have maximum smooth muscles. Arterioles have excellent, guys. Excellent. Okay, excellent, guys. Arterioles have maximum smooth muscles. Done. Now, let me ask you one question. Sir, if the patient is going from lying down position to standing position, listen carefully. The patient is going from lying down position to standing position. What happened to the venous return? Lying down position to, he is going to standing. Now he is going to stand. What happened to venous return? Venous return decreases. Venous return decreases. See, lying down position to, he is now standing. Because of the gravity, blood will cool down. So venous return decreases. Vijay Krishna, think like this. When the patient is going from lying down position to standing position, blood will gravitate down. So venous return decreases. Okay, understood, right? So now again, think once. CVP. What is the CVP? Central venous pressure. We have discussed central venous pressure is the pressure in right atria. Okay, right atria. Sir, any PYQ question from this one, sir? I want to know how difficult the question is phrased. Which from which topic? Central venous, like this one. Preload and afterload. Simple questions. Preload and afterload. They will ask you. Inspiration ke time mein what happened to venous return? Inspiration ke time mein venous return increases. Okay. So okay, let me tell you what was the question in the NEET PG exam. All of the following conditions. In all of the following conditions, venous return increases except. In all of the following conditions, venous return increases except. Venous return is increased during lying down position. Venous return is increased during inspiration. Venous return is increased during walking. When you walk because of the contraction of the soleus muscle, can push the blood. Venous return increases. Venoconstriction. The veins are constricted. Okay, listen carefully. If your veins are constricted, more blood will be pushed towards the heart. Okay, venoconstriction, more blood will be pushed towards the heart. So such kind of questions will come. So done. This topic is also completed. This integrated question, this is not needed right now. For you, this is not needed. It will anyway come in your pharmacology. Just leave it. So after this, two laws, you can say, which was repeatedly tested somewhere around 2017-18 years. 2017-18 years, the same question was asked twice. 2 times the same question was asked. What is that? It's the Frank-Starling law. Frank-Starling's law. Okay, Frank and Starling, not your darling. It's a Starling. Okay, Frank-Starling law. See, what is this Frank-Starling law tells you? See, Frank-Starling law tells us that preload, that is end diastolic volume, is directly proportional to stroke volume. What does it mean by? What is the normal end diastolic volume? Tell me. 120. If there is 120 ml in the heart, how much blood is going into the aorta? With one heart contraction, with one heartbeat, how much blood will go? Sir, somewhere around 70 ml. That's the stroke volume. 70 ml will go. Okay. Now I am keeping 200 ml in the heart. Do you think same 70 ml will go? No. Now maybe 160 may be going. 160 ml will go. Okay, something like that. So if you increase the preload, automatically stroke volume also increases. If you increase the end diastolic volume, automatically stroke volume is increasing. That's simple. You keep more in the heart is going to eject more. Okay, something like that. So this is the Frank-Starling law. End diastolic volume or preload is directly proportional to stroke volume. The more you keep in the heart, more will be ejected. That is called as Frank-Starling's law. Okay. Next thing. What is this fixed principle? Like a fixed principle है क्या है? Now let me make it easy for you. Guys, listen. Look at me. I want to know, for example, Vijay Krishna is the last one who is messaging, right? I want to know how good Vijay Krishna is studying. Like how good he is studying, Vijay Krishna. So how can I know how good he is studying? So what is the parameter by which I can know how good he is studying? Anyone? I have to look at what? The exam marks. Exactly. I have to look at the exam marks. I have to look at his report card or rank card. Okay. So by looking at the rank card, I can estimate, at least I can have an idea how good he is studying. In the same way, how to estimate the cardiac output? We know our cardiac output is 5 liters per minute. Our heart will pump 5 liters of blood. How can we know that 100 years back, 200 years back, if they want to calculate the cardiac output? How? So that is fixed principle. Okay, fixed principle.
See, what you are doing, you are estimating the cardiac output, just like I am estimating how good the person is studying by looking at the rank card. So estimation of what? Cardiac output by the rate of oxygen consumption, by looking at how much oxygen he is consuming, I can actually calculate the cardiac output. I can come to an understanding that how much is his cardiac output. So what is the formula? Let me tell you. The formula for the fixed principle is, it's fixed principle, sir. Okay, the letter I is very much important, otherwise it will change. Okay, so what is this fixed principle? So fixed principle is Q, the cardiac output. Q for cardiac output. So cardiac output is directly cardiac output is equal to the amount of oxygen he's taking. We know, like, he's breathing from the cylinder, so we can know how much oxygen he's taking. So volume of oxygen consumed divided by arteriovenous oxygen difference. Volume of oxygen consumed by arteriovenous oxygen difference. See, our arterial blood, look, in my arterial blood, this much amount of oxygen is there, 190 ml of oxygen is there. In my venous blood, 140 ml of oxygen is there. Okay. There is more oxygen, there is less oxygen. You know it, arterial blood may more oxygen, venous blood may less oxygen. So what is the difference? 190 minus 140. That is the arteriovenous difference. How much? 50. So that's why here 50. Now, my subject, like, the person who is, the person whom I have taken for the experiment, my subject is taking how much oxygen? 250 ml of oxygen. He is breathing 250 ml of oxygen. So write 250 divided by 50. How much? 5 liters. So this is how you can calculate the cardiac output. Maybe I'm changing that value. See, for example, this is constant, 50 is constant. I'm changing this value. Maybe he is taking more oxygen. He is running a marathon race. Instead of 250, he is taking 300 ml divided by 50. So 300 divided by 50, how much? 6 liters. So if you take more oxygen, more cardiac output. Simple, right? Marathon race, when he is doing the marathon race, his heart will pump more. So automatically, see, his cardiac output is also increasing. From 5 liters, it is increasing to 6 liters. So if you change this value, automatically cardiac output will also be changing. So based on the amount of oxygen consumption, you can actually estimate the cardiac output. That principle is called as fixed principle. That's it. VO2, volume of oxygen consumed by arteriovenous oxygen difference. So Frank-Starling law completed. Fixed principle also completed. Just sit back, relax, take a deep breath. Okay, take deep breaths. Okay, take deep breath, take some water. So, is it clear? Now, actually, I forgot to mention here one of the important topics that I was missing here, that I have missed here, is baroreceptor reflex. In cardiac reflexes, okay, cardiac reflexes are different. There is one more reflex called as a baroreceptor reflex. This is also very important. And the cardiovascular system, directly, indirectly, with medicine integration, patho integration, from that book, whatever I am teaching, you will get 3 MCQs. Okay, 3 MCQs. No doubt. We are learning each and everything. We are not leaving any, topics. So 3 questions will be definitely coming. Chalo. Now let's continue with the blood pressure, the topic of the blood pressure. Now, what is the normal blood pressure? You know it. What is the normal blood pressure? It's 120 during systole, say systolic blood pressure. When your heart is contracting, how much pressure is generated by the heart? 120 pressure. And when your heart is relaxed, okay, when your heart is relaxed, how much blood pressure is there in your aorta? 80. So this is the normal blood pressure, 120 by 80. Your normal blood pressure. When your heart is contracting, how much blood pressure is there in the aorta? 120. When your heart is relaxing, how much blood pressure is there in the aorta? 80. Okay. So for those students who doesn't know what is a blood pressure, let me tell you. Array, this is your left ventricle. From here, who is coming out? This is aorta. When your heart is contracting, your heart will generate how much pressure? 120 pressure. The same 120 pressure will come into the aorta. So during systole, what is the blood pressure in the aorta? 120. And when the heart is relaxed, what is the baseline blood pressure here? 80 is always maintained. 120 by 80. Okay. Now, pulse pressure. What is pulse pressure? Difference between systolic and diastolic. Systolic blood pressure is 120. Diastolic blood pressure is 80. So 120 minus 80. How much? 40 mmHg. So the pulse pressure is 40 mmHg. And now what is the mean arterial pressure? Mean arterial pressure. It's very simple. Mean arterial pressure is the average BP. I used to understand the mean arterial pressure like average BP. Average BP. Now, for example, say I'm asking, let me take one student from here, from our chat. Let's take Vamsi. Okay, let's take Vamsi. See, I'm asking Vamsi what is the blood pressure. He's saying 120 and 80. I have asked you one question. What is the BP? So you should have to tell me one answer. Why you are telling me two answers? 120 by 80. I don't want these many answers. I want only one answer. You tell me one answer. So you have to take an average, not 120, not 80, in between value. You have to take an average value. Average BP is called as a mean. Mean means average, mean arterial pressure. So the mean arterial pressure, the formula is diastolic blood pressure, that is 80, divided by 1/3 of the pulse pressure. What's the normal pulse pressure? 40. 40 divided by 3, how much? 13. 1/3 of the pulse pressure. Pulse pressure, normal pulse pressure is 40. So 1/3 of the pulse pressure means 40 divided by 3, 1/3. Okay, so it will be 13. So 80 plus 13 is 93. Okay, this is my average BP. Not 120, not 80. In the middle value. This is my average BP. So that's the mean arterial pressure. Okay. So BP, pulse pressure, mean arterial pressure. Okay, done. Now our BP need to be regulated. BP regulation. In the BP regulation topic for your FMG exam, this is enough. Short-term regulation. That is called as baroreceptor reflex. Your BP need to be regulated, sir. Okay, it should be regulated. How much? Like, it should be always maintained 120 by 80. Our mean arterial pressure should be somewhere around 93. It should be regulated. Now, what if it is going down? Or what if it is going up? Both are bad. So this baroreceptor reflex, it will help you to maintain our mean arterial pressure. Okay, simple. How my BP is going to be regulated? With the help of baroreceptor reflex. If it is going up, that's bad. If it is coming down, that's bad. So whenever it is going up, the baroreceptor reflex will try to bring the BP down. Whenever my BP is going down, baroreceptor reflex will try to increase the BP, something like that. Okay, so let's discuss about the baroreceptor reflex now in detail. Baroreceptor reflex. Okay, so chalo start. What are baroreceptors? First of all, they sense baroreceptors. They sense what? They sense BP. Which BP? Systolic BP or diastolic BP? These baroreceptors, they are always checking the BP. Which BP? They sense mean arterial pressure. That's the MCQ. Baroreceptors, they are checking which BP? They are checking the mean arterial pressure. How much is the mean arterial pressure? Is it normal or not? So this baroreceptors, where they are present? They are present in our aorta and the carotid sinus. Look, this is our heart. Okay, this is our heart. See, baroreceptors are present where? In the aorta, in the arch of aorta. And the baroreceptors are also present in this area called as a carotid sinus. So this is the common carotid artery. See, this is the common carotid artery. The common carotid artery will be divided into internal carotid as well as external carotid. Okay, so in this area is called as a carotid sinus. So in the carotid sinus, what do we have? Baroreceptors are present. Okay, now tell me where the baroreceptors are present, students. Baroreceptors are present in carotid sinus as well as the baroreceptors are present in aortic arch. What they are checking? What they are always checking? They are always checking how much is the mean arterial pressure. That is 93. Okay, now this information, your brain knows how much is the mean arterial pressure, how much is the BP in your body. Your brain knows. How How means, look here carefully. Now these baroreceptors, they will sense what is the BP. Here also baroreceptors are there. From here, the same information, look, is going to your central nervous system, to your medulla. The information is going. Here also see, through these wires, okay, through these wires, which are nothing but the neurons, the information is going to the medulla. So what are these wires? They are nothing but the 9th cranial nerve, glossopharyngeal nerve, and the branch of the 10th cranial nerve, that is Science nerve. Okay, Science nerve is the branch of vagus nerve. Herring's nerve is the branch of glossopharyngeal nerve. See, both these nerves, there's a 9th cranial nerve branch and a 10th cranial nerve branch. They are taking the information about the mean arterial pressure to the medulla, to the medulla. In the medulla, which nucleus receives this information? In the medulla, the nucleus of tractus solitarius. The nucleus of tractus solitarius, which is there in the medulla, receives this information. So your central nervous system always knows how much is your BP. How much is your BP? Okay. So the questions which are going to ask in your exam, how the information is going to the central nervous system via 9th cranial nerve and 10th cranial nerve. These are the afferents. Information, afferents means the information is sensory. Afferents means sensory. The information is going via the 9th and 10th cranial nerve in the baroreceptor reflex. Where that information is going? To the medulla, to the nucleus of tractus solitarius. Okay, these baroreceptors, they are sensitive to what? They are sensitive to mean arterial pressure. If the mean arterial pressure is decreasing from 93, it is decreasing to 70, they are activated. If the mean arterial pressure, if it is increasing up till 150, they are activated. So during this pressure range, they are activated and they will give the information to the central nervous system. Understood? So there is someone in your body, again listen carefully, there is someone in your body who is always checking what is your BP. Those receptors are called as baroreceptors. They are present in arch of aorta and carotid sinus. The information about the mean arterial pressure will go to the central nervous system via the 9th and 10th cranial nerves. The information is going to the medulla, to the nucleus of tractus solitarius. And it will, from the nucleus of tractus solitarius, from here, it will regulate the BP. How? I will tell you in a minute. Now, look. Now what happened is, for example, the patient is having more BP. BP is increasing. His mean arterial pressure is increasing because of some reason. He is having a girlfriend and girlfriend is irritating him. Okay, the girlfriend is irritating him, so his BP is going up. So what is happening? The baroreceptors are activated. The baroreceptors are activated due to increase in the BP. So that information, see, increased firing. Now the 9th and 10th cranial nerve, they are taking this information. Now this 9th cranial nerve and 10th cranial nerve, they are producing the electrical impulses, and this information is going to the nucleus of tractus solitarius. What's the problem? Mainly more BP. More BP. Now, what this nucleus of tractus solitarius will do? Questions which were previously tested so many times in FMG and NEET PG exam. Only one time in FMG, many times this question was asked in FMG, NEET PG. Look, nucleus of tractus solitarius ఇప్పుడు ఏం చేస్తుంది? What it's going to do? Okay, the nucleus of tractus solitarius. See, it is going to activate the CVLM, caudal ventrolateral medulla. So this, once the CVLM, caudal ventrolateral medulla, if it is activated, it releases GABA. So RVLM, rostral ventrolateral medulla, this is inhibited. Rostral ventrolateral, RVLM is, it's a sympathetic center. It's a sympathetic center. So what happens immediately in the body? Sympathetic activity decreased. Look, the sympathetic activity is gone. The sympathetic activity decreases. So what happened to the heart rate? Heart rate decreases. If heart rate decreases, what happened to the BP? BP decreases. Okay. Now the problem is increased BP. See here, I have written the problem is increased BP. The baroreceptors via the 9th and 10th cranial nerves activates the nucleus of tractus solitarius. Nucleus of tractus solitarius finally inhibits the RVLM. When the RVLM is inhibited, heart rate decreases, BP comes to normal. The mean arterial pressure will come back to 93. Okay. At the same time, this nucleus of tractus solitarius, okay, it's like a brain, right? The nucleus of tractus solitarius, see what it is doing? It is activating the parasympathetic neurons. The parasympathetic neurons. So when the parasympathetic neurons are activated, parasympathetic activity, heart rate decreases. When the heart rate decreases, again BP decreases. Okay, so this is the baroreceptor reflex. Okay, baroreceptor reflex. When your BP increases, okay, mainly this is when your BP increases, your heart rate is decreasing. Your heart rate is decreasing, right? When your BP increases, that will decrease the heart rate reflexly. First, when BP is increasing, first heart rate decreases. Later on, BP will come to normal. Okay, later on, BP will come to normal. First, what happens in first beginning? When BP increases, heart rate decreases. This is called as Mary's law. Mary's law. Okay, sir, Mary's law. So what is Mary's law? Mary's law tells us whenever there is increase in BP, there is a reflex decrease in heart rate. There is reflex decrease in heart rate. This is called as Mary's law. Okay, that was tested many times in the exam. Now, one more question, which was asked regarding this baroreceptor reflexes, which was asked is baroreceptor reflex, is it a positive feedback reflex or negative feedback reflex? See, increase in the BP, it's a decrease in the heart rate. So this is a negative feedback because inhibition, right? So whenever BP increases, heart rate is decreasing. Negative feedback. It's giving negative feedback. Array, BP is more, decrease the heart rate. So this is a negative feedback reflex tested in the exams. Okay, just let me show you. Just give me one sec. Let me show you the exact question. Yeah, this is the exact question which was asked. Which of the following mechanisms are seen in the baroreceptor reflex? Feed forward, positive feedback, negative feedback, adaptive regulatory control. It's the negative feedback reflex. Okay. So with this, baroreceptor reflex is also completed. So shall I continue, guys? Is that okay? Oh. Shall I continue? Are you getting bored? Of course, studying is boring. Even who likes to study? Huh? Boring things, right? If you feel physiology itself is bored, then what about in other subjects, like certain subjects like microbiology, totally by heart thing, pharmacology, you need to totally by heart the things. Okay, at least physiology is of concepts. Or if it happens, it's all concepts. Okay. So let's continue. Now, look at this and try to answer. This is your arch of aorta. Here is the common carotid artery. Okay, common carotid artery. This is the carotid sinus. This is the external carotid, and here is the internal carotid. External carotids as well as the internal carotid. Okay. Now, can you tell me what are these things that I am drawing here? These things, they are small receptors here. What are they? They are the baroreceptors. They are the baroreceptors. Now, these baroreceptors, they sense what? They sense mean arterial pressure. They are always sensing the mean arterial pressure. Okay. Done. Now, from here, what is this cranial nerve that is taking the information? Which cranial nerve takes the information? Ninth cranial nerve. Here also baroreceptors are there. Which cranial nerve takes the information? 10th cranial nerve. Okay, that's the science nerve. 10th cranial nerve, the branch of the vagus nerve. That's the science nerve. Now, what I want you to know is, this question was asked in NEET PG exam where most of the students have gone wrong. Okay, where most of the students have gone wrong. Let me tell you. See, how these receptors will fire. Let me tell you, whenever there is more mean arterial pressure, see map, mean arterial pressure, when it is more, it will cause, you see, here the pressure is more, sir, now. Here the pressure is more. Now that will cause stretching of these receptors. Now these receptors, because of the more pressure here, there will be stretching or distension of the receptors. Baroreceptors, they will distend, and that is what is going to fire the receptors. Now the receptors will generate the electrical impulse. So that's why, look, here also, distension of the baroreceptors due to increase in BP. Later I will show you that question. Whenever the pressure increases, listen here guys, ikkada pressure increase aite, okay, whenever, see here, whenever the pressure increases, that will cause a stretching of the receptors or distension of these receptors. That is responsible for the generation of action potentials, and information is going. Okay, now look what I have did. I have taken a clamp, theoretically talking, I have taken a clamp. I have put a clamp over here above the carotid sinus. Whenever I keep the clamp above the carotid sinus, what happens? Sir, now the blood can't go forward. Now all the blood is accumulated here, sir. All the blood is accumulated over here. So what happens? It causes the distension of these receptors. Okay, it causes the distension of these receptors. Now the nerves are firing. Ninth cranial nerve is firing. Now your central nervous system, that's the nucleus of tractus solitarius, it is receiving the information that what this nucleus of tractus solitarius is thinking. Oh my god, mean arterial pressure is increasing, mean arterial pressure is increasing. But not, actually it is not increasing. Only in this area it is increasing. Okay, so immediately nucleus of tractus solitarius, what it will do? The nucleus of tractus solitarius, it will try to decrease the heart rate. Okay, it will try to decrease the heart rate. So clamping above the carotid sinus, if you clamp above the carotid sinus, the nucleus of tractus solitarius is receiving the information that there is more BP. So immediately nucleus of tractus solitarius try to decrease the heart rate. So look here, clamping above, see, above means up. Clamping above, decrease the heart rate. Decrease the heart rate. Then what happens if you clamp below? If you do the clamping below the carotid sinus, same thing. Here are the internal carotid, external carotids. This is the carotid sinus. There is a common carotid artery. Now you have kept a clamp here below, which means no blood is going up. The blood cannot go up. So what happens? These baroreceptors, they are not activated. They are not activated. So information is not going to the nucleus of tractus solitarius. There is no information going. So nucleus of tractus solitarius will think, array, in the body BP decreased. So immediately it will try to increase the heart rate. It will try to immediately increase the heart rate so that BP will go up. So that further later the BP will go up. So clamping below, if you clamp below, blood is not coming to this area. So the information is going that BP decreased, BP decreased, BP decreased. So immediately nucleus of tractus solitarius will immediately increase the heart rate. So trying to increase the BP. So clamping below, increase the heart rate. That's it. So the same thing, clamping below the carotid sinus will cause increase in the heart rate. And final thing, carotid sinus massage. Whenever we do the carotid sinus massage, what happens? See, from outside, you are compressing the carotid sinus. Okay, look, imagine this is the carotid sinus. Here is the carotid sinus. Both external carotids, internal carotids. Now, from outside, you are compressing the carotid sinus. When you compress, what happens if the pressure here? Pressure increases. So what happened to the baroreceptors? Baroreceptors are stretched. Baroreceptors are distended. So the information is going. Array BP is increased because you are stretching from outside. You are compressing from outside. So information is going that array there is more BP in the body. So what nucleus of tractus solitarius will do? Nucleus of tractus solitarius will try to decrease the heart rate. That's it, simply. So carotid sinus massage, immediately heart rate decreases. That's it. When you do carotid sinus massage, heart rate decreases. Heart rate decreases because you are compressing from outside. When you are compressing from outside, baroreceptors are going to be activated. Baroreceptors are going to be stretched. That causes decrease in the heart rate. That's it. With this baroreceptor topic, all important MCQs are completed. Okay. Just give me a sec. Let me show you what was the question which was asked regarding the baroreceptor reflex.
Baroreceptor reflex. I think I forgot to keep it here. Okay, I forgot to give it here. But anyway, that's the question. The question which was asked in the baroreceptor reflex is when the mean arterial pressure increases. Okay, when the mean arterial pressure increases, the baroreceptors are going to distend, the distension of the baroreceptors. That's the point which I want you to know. When the mean arterial pressure increases, that causes a distension of the baroreceptors, that causes the firing of the 9th and 10th cranial nerve. So you know the story. Okay, done. Next, the BP variations with the position. This is a bullshit topic, not needed. Okay, not needed for your exam. Next topic which I want you to know is cardiac reflexes. Cardiac reflexes, super important. Okay, super important. If you want to go through this, you can go through this, but not that important. This is just for the first year students. Okay, questions were not asked, just leave it. Cardiac reflexes. See, first itself I am telling you, all cardiac reflexes, whatever I'm going to talk, all cardiac reflexes are bradycardics. At the end of the day, heart rate should decrease. All cardiac reflexes are bradycardic. All cardiac reflexes means the heart rate should come down. Okay, except, sir, clamping above the carotid sinus, there will be any information from aortic arch. See, aortic baroreceptors are very less sensitive. Okay, whatever you are asking, Jyoti, you are true. Aortic baroreceptors, their function is just 10%. It's the main carotid baroreceptors are the real baroreceptors. Carotid baroreceptors are highly sensitive to mean arterial pressure. Of course, aorta mein baroreceptors are there, but they are very less sensitive. Their firing is less, not that important. Okay, carotid baroreceptors are more important. Okay, so what I'm discussing, all cardiac reflexes, right? All cardiac reflexes are, first statement, all are bradycardiac. Cardiac reflexes mein all cardiac reflexes, whatever you see, are bradycardiac. Means they have to decrease all the cardiac reflexes. They will decrease the heart rate, except Bainbridge. Except Bainbridge reflex. See here, except Bainbridge, which is a tachycardiac reflex. TR means tachycardic reflex. All are bradycardiac except Bainbridge. So now, what is Cushing reflex? First of all, let me tell you what is Cushing reflex. Strike this first point. This is not needed. Strike this first point. Don't write this first point. That's a typing mistake. What is Cushing reflex? A Cushing reflex means, look, whenever the patient is having increase in intracranial pressure, okay, patient ko, let me write here. So patient's intracranial pressure is increased. Intracranial pressure means the pressure inside the brain increase. Intracranial pressure, maybe because of some tumor or maybe because of some hemorrhage, hematoma, intracranial pressure increased. When intracranial pressure increases, vagus nerve is activated, 10th cranial nerve. Vagus nerve is activated. Vagus nerve is a parasympathetic nerve. When vagus nerve is activated, what happened to the heart rate? Heart rate decreases. Okay. So that's why those patients who is having a tumor in their head, their heart rate is going to be low. Those patients who are having a hematoma in their head, their heart rate is going to be low. Because increase in intracranial pressure, when intracranial pressure increases, the patient's heart rate will be less. This is called as Cushing reflex. See, it's a bradycardic, heart rate is going down. So that's the same thing. Seen in the conditions causing increase in the intracranial pressure. Cushing reflex, it's a bradycardic reflex. Whenever intracranial pressure increases, what happened to heart rate? Heart rate decreases. That's it. Cushing reflex ho gaya. It's done. Next, what is Bainbridge reflex?
Bainbridge reflex, don't go through each and everything. Simple. Let me tell you what is Bainbridge reflex. Let me write here Bainbridge reflex. Now you give saline to me. I am coming to you. You give saline, normal saline. If you give saline, what happened to my blood volume? Blood volume increases. Okay, increase in the blood volume. When blood volume is more, what happened to the venous return? Venous return. More blood will go to the heart. There is more blood volume. More blood will go to the heart. More venous return. So more blood is coming into right atria. So right atria is receiving. Right atria is receiving more blood. You tell me logically. You tell me, guys. Whenever there is more blood in the body, heart have to beat more number of times or less number of times? They have to beat more number of times. So what happens is, say, whenever there is more venous return in the right atria, there are volume sensing receptors present. More blood is coming to the right atria. So that will cause a distension of right atria. Distension of right atria. Here, when the distension of right atria occurs, when the right atrium is distended, listen carefully, when the right atria is distended because of more venous return, more blood volume, these receptors are activated. These volume sensing receptors are activated. From here, the information will go to the central nervous system. There is more blood in the body. The right atria is getting distended. More blood in the body. More blood in the body. So immediately central nervous system is going to increase the heart rate. The sympathetic nervous system is activated. Sympathetic nervous system is activated. So heart rate increases. This is simple logic. Whenever you are having more blood, heart have to beat more number of times. When you are having more blood, heart have to beat more number of times. That's it. So saline infusion. Question asked in FMG exam. Saline infusion increases the heart rate. This is called as Bainbridge reflex. Okay, same thing. Look here. What is the stimulus? Increase in the venous return to the heart. So what happens? Sir, in the both right and left atria, there are volume sensing receptors present. Both in right and left atria, even in the left atria, they are present. Both in right and left atria, the volume sensing receptors are present. Now from here, from the atria, this information is going to the central nervous system via the vagus nerve. Okay, look here carefully. So this is the vagus nerve. Vagus is also taking the information. Vagus nerve takes the information to the brain. There is more blood volume. The information is going to the central nervous system. The central nervous system is going to activate the sympathetic neurons. So heart rate increases. So sympathetic neurons are activated. Heart rate increases. Tachycardia. That's it. Okay. So Cushing reflex is tachycardic reflex seen in intracranial pressure cases. Bainbridge reflex is seen in conditions where there is right atrial distension or simply atrial distension. So that's why Bainbridge reflex is also called as atrial reflex. Atrial reflex. Hope you understand. Body में ज़्यादा blood है तो heart have to beat more number of times. Simple. Body में ज़्यादा blood है तो more venous return is there to the heart. The atria are going to stretch. This information is going to the central nervous system via the vagus nerve. Vagus nerve takes the information. So central nervous system is going to activate the sympathetic nervous system. Heart rate increases. So how I used to remember when I was a student, I used to remember something like this. Sir, especially China mein, like Chinese students, it will be very easy for you to understand. There are tall bridges. There are super high bridges. When you go and stand on a high bridge, okay, when you see down from there, when you see down into the abyss, okay, when you see down, what happened to you? You are going to get panicked. Okay, when you are going to get panicked and your heart rate increases, right? Your heart rate increases. So when you are on a bridge, your heart rate increases. Remember it like that. I used to remember something like that. Okay, so when you are on a bridge, your heart rate increases. So Bainbridge reflex is a tachycardic reflex. Okay, done. And we are coming to an end. The Bezol-Jarisch reflex. Okay, Bezol-Jarisch reflex is oculocardiac reflex. It was not needed. Anyway, it's not given in your book also. This is not needed. Next, Bezol-Jarisch reflex. Kya hai Bezol-Jarisch reflex? Simple, sir. When you keep certain chemicals in the heart like serotonin, veratridine, capsaicin, if you keep these chemicals, just inject these chemicals into the heart. Simple. Okay, scientists were doing a lot of experiments. They don't have any time. They will do all this nonsense. When you inject these chemicals into the heart rate decreases. Okay, So look, something like this. Look. These are like, cardiotoxins. You can say, like, these are like toxic substances in high quantities. Look, now what I'm doing, I'm injecting these substances like serotonin, veratridine, capsaicin. Now these substances came into the heart. These are bad substances. Okay, these are bad substances. Now, if these are bad substances, tell me. Now, if heart is beating more number of times, you think logically and tell me. If the heart is beating more number of times, all these chemicals will be spread throughout the body, right? That's not good. That's not good. Then when you keep the cardiotoxic substances or some chemicals like serotonin, veratridine, or capsaicin into your blood, now there are receptors. These are different receptors. These are the chemoreceptors. These chemoreceptors in the heart are activated. Oh my God, there are these chemicals, not good chemicals. So this information is going to the central nervous system. Array, there are some bad chemicals in the body. So immediately central nervous system is going to decrease the heart rate. Okay, your central nervous system is going to decrease the heart rate. Heart rate will be decreased. So information is going to the central nervous system. Via which nerve? It's also vagus. So information is going to the central nervous system via unmyelinated vagal C fibers. So central nervous system is receiving the information. There are some chemicals, there are bad chemicals in the blood. So central nervous system, it will inhibit the sympathetic nervous system. It inhibits the sympathetic nervous system. So heart rate decreases. Okay, so there will be bradycardia, heart rate decreases. Later on, when sympathetic nervous system is inhibited, also hypotension, your BP decreases. So bradycardia and hypotension, these are the two important things. Bradycardia and hypotension, that's it. Bradycardia and hypotension. So bradycardia, heart rate is decreasing because of these chemicals. So this is also called as chemoreflex. This is also called as chemoreflex. Basal-Jarisch reflex is chemoreflex. Okay. Now I will show you certain questions. I will show you some questions. You just try to answer them. Before showing you the questions, you tell me, do you understand? Let me ask you one by one. Answer me. No, I haven't even stepped. Like you are asking, no, I haven't stepped my foot into China. No, I don't know anything about China. Just I'm watching the Instagram, those videos where the top bridges are there. That's why I said no, I don't have any relation with the China. Now let me ask you some questions regarding the reflexes. Try to answer them. Increase in the intracranial pressure. Okay, increase in the intracranial pressure. If you increase the intracranial pressure, what happened to the heart rate? If we increase the intracranial pressure, what happened to the heart rate? Come on. That reflex is called as what? Pushing reflex. Excellent. Sir, keeping some chemicals in the heart. If you keep certain chemicals in the heart rate decreases. If you keep some chemicals in the heart rate decreases. What is that reflex? If you keep certain chemicals like veratridine, capsaicin, serotonin, that is a basal-Jarisch reflex. Chemoreflex, basal-Jarisch reflex. Saline infusion. Okay, saline infusion. If you give saline, if I give saline, or if I increase the blood volume, or if I cause the distension of the right atrial distension, more blood volume, right atrial distension. Which reflex? Bainbridge reflex. Remember, atrial distension. More blood volume means more venous return. More venous return means right atrial distension. When right atria is distending means heart rate increases. If you distend the right atria, heart rate increases. Heart rate increases. That is Bainbridge reflex. Very, very important. It's a tachycardic reflex. Now, can you tell me, sir, if I put more blood in the heart, more will be the stroke volume. What is that? If you increase the preload, stroke volume directly proportional, it increases. If you increase the preload, stroke volume also increases. What is this? Increase in the preload increases the stroke volume. What is that? Frank-Starling law. Excellent, Vishnu. It's a Frank-Starling law. Okay, Frank-Starling law. Next thing, sir, if you increase the BP, heart rate decreases. What is this? If you increase the BP, there is a reflex decrease in heart rate. What is that? Mary's. Excellent. Mary's. Okay, Mary's law. Okay, Mary's law. M-A-R-I-E-S. Mary's law. Okay. So now let's see the MCQs. Dicrotic notch.
You don't know about this, I have to explain you. Okay, no issue. Where are the reflexes? See, this is a question asked. You already know it. So which reflex is responsible for tachycardia during right atrial distension? Just now I have explained. If you distend the right atria, why? Because of the saline infusion, more blood volume, right atrial distension. Okay. So tachycardia, the moment you see the tachycardia, you have to answer it as vein bridge reflex. This is a previous year question. This is not something I'm taking it out from, like, some question bank. This is a previous year FMG question. Which reflex is responsible for tachycardia? Vein bridge reflex. Okay. Next, let me show you some other reflex. Now look at this. Which of the following is not a component of Bejoel-Jaris reflex? Bejoel-Jaris reflex, you already know it. Are Bejoel-Jaris reflex mein, see, chemoreceptors are activated. Bejoel-Jaris reflex. There will be bradycardia, hypotension. Okay, bradycardia and hypotension is going to be there. Okay. So I have told you, Bejoel-Jaris is bradycardic. Every damn reflex is a bradycardic reflex. So which of the following is not a component? Tachycardia. See, tachycardia is not seen. Tachycardia is not seen. That's a blunder. Which of the following is not a component? Tachycardia is not a component. The patient can have bradycardia. True. The patient can develop hypotension. Even sometimes, if it's severe, the patient can have apnea also. But tachycardia is never seen. Okay. So these are the questions. Next, look at this. Yeah, cardiac reflexes. You know all the cardiac reflexes. We have discussed about the Cushing reflex. Yes. We have discussed about the Bejoel-Jaris reflex, vein bridge reflex, baroreceptor reflex, and what you don't know is just the Valsalva maneuver. Okay, what you don't know is the Valsalva maneuver. What is Valsalva maneuver? Simply, Valsalva maneuver means take the inspiration. You just do the inspiration. Okay, you have taken the inspiration. And close your glottis. Glottis, you close your nose and try to exhale. Okay, try to exhale. Take inspiration and try to exhale by closing your nose. That is called as Valsalva maneuver. Okay, so when we do Valsalva maneuver, what happens to the heart rate? Heart rate decreases. Simple. Remember that one point. I'm not going to in detail because it will give you too much detail, so many details. Simple. Remember, when you do the Valsalva maneuver, okay, your heart rate will come down. Okay, your heart rate will come down. Valsalva maneuver Valsalva maneuver decreases the heart rate. Okay, our students will be like, too much. They want to know. So much time is there, right? But okay, let me tell you. Say Valsalva maneuver. If you do Valsalva maneuver, what happened to your pressure in the chest? Tell me, what happened to the pressure in the chest? Try to do it. Inspire. Take the inspiration. Close your nose. Try to exhale. By closing the mouth. Mouth should be closed. Nose should be closed. Try to exhale. See, the pressure in the thorax increases. So, intra-thoracic pressure increases. So, your aorta is also in the thorax. Your aorta is also in the thorax. So, aorta is also getting compressed. When you do the Valsalva maneuver, aorta is also getting compressed. Means what happened to the pressure in the aorta? Increased. So, aorta में pressure increase होने तो aortic baroreceptors are activated. Aortic baroreceptor, ABR means aortic baroreceptor activated. So from here, information is going to the nucleus of tractus solitarius. Oh my God, more BP is there because the aorta is getting compressed. More BP is there. So immediately nucleus of tractus solitarius will try to decrease the heart rate. So that's it. So whenever you do the Valsalva maneuver, heart rate decreases. Okay. So if a patient is having tachycardia, you just ask them to do a Valsalva maneuver. If you do the Valsalva maneuver, automatically heart rate decreases, BP will be decreased. So all the cardiac reflexes are also completed. Okay, all the cardiac reflexes are also completed. Please add Valsalva maneuver. If you do the Valsalva maneuver, heart rate decreases. So tell me, see, this is also bradycardic reflex. Valsalva maneuver is also a bradycardic reflex. It also decreases the heart rate. Every damn thing decreases the heart rate except vein bridge. So with this, that topic completed. Okay, let me take this one slide, copy, and let me have it here. See, students will say like, sir, why so many pages are there? Here it's showing 85. Array, guys, here I have, see, this is also one page. It is considered as one page, but information won't be there. Okay. If you keep all these PPT slides, it will be like, 25 pages. That's it. Okay. This is also one page. This is also one page. So slide wise more are there, but in papers, they are less only. Completed. Most important topics are completed. Reflexes are completed. Done. All the cardiac physiology completed. What we are left with is vascular physiology. Okay, vascular physiology. So shall we continue with the vascular physiology? Yeah, Najib, you are true. Whatever you are saying, you are true. Like, Valsalva is just like, trying to bear down. Okay, trying to bear down as if you are like, if the patient is having constipation, if he's trying to bear down, yes, that's the Valsalva. True. ABR, aortic baroreceptor. What is ABR? It's aortic baroreceptor. Najib, it's aortic baroreceptor. When you are doing Valsalva, see, when you are doing Valsalva, here the pressure increases. Aortic baroreceptors are activated. Aortic baroreceptors are activated. Once the aortic baroreceptors are activated, they are taking the information to the central nervous system. There is more BP, more BP, more BP. So immediately heart rate will come down. Whenever you do Valsalva, heart rate comes down. That's it, simple. Whenever you do Valsalva, here pressure increases, aorta mein pressure increases, baroreceptors are activated, baroreceptors are firing. The science now, 10th cranial nerve is firing, giving the information to the central nervous system. More BP, more BP, more BP. So immediately central nervous system will decrease the heart rate. According to Mary's law, heart rate will come down. Okay. So now what's the time? The time is exactly 3:29. Just take a break of 1 minute. 1 minute break. Just simply sit and relax. I will start the vascular physiology and I will complete the vascular physiology in the next half an hour. Okay. The next half an hour, the vascular physiology will be completed. And you believe me, in the recent exam, the question was asked in the vascular physiology. See, we have discussed about so many things, right? Of course, questions came, but question came from the last slide of the vascular physiology. See, from this slide, the last slide, question was asked. Okay, in the recent exam, the question was asked from the last slide of my vascular physiology. We take a break of 1 minute. Okay, done. 1 minute break completed. Now, let me show you something. See, as a doctor and as a teacher who is in this profession, we have to collect all the MCQs, right? Recent exam questions. I was like, no, just checking the recent exam questions in the YouTube. See, in yesterday's class, have we discussed about this? This is the recent FMG exam question. Have we discussed this? Which of the following? It's there in the Prepladder platform also. Like, you know, the students were discussing. So these questions came. Which of the following regulates the body temperature? What is the answer? Hypothalamus. In yesterday's class, I have discussed hypothalamus regulates the body temperature. That's the question which was asked in the recent exam. Look, see this from cardiovascular. Today's cardiovascular. Can you answer this? Can you answer this? Which of the following JVP findings is typically associated with cardiac tamponade? You know, cardiac tamponade. You know, okay. What will be seen in cardiac tamponade? Cardiac tamponade. You know, sir. We have discussed. Have we discussed or not? This was a recent FMG exam question. Okay. But anyway, in cardiac tamponade, JVP, which JVP? See, which of the following JVP findings? Which of the following JVP findings is seen in the cardiac tamponade? I have discussed with you. Look here. See here. In cardiac tamponade, the last thing in cardiac tamponade, there will be prominent X descent. I have discussed in prominent X descent will be seen. Okay, prominent X descent will be seen. That's the recent question. Okay. And in yesterday's class, endocrine physiology, have I discussed this? Have I discussed this? Skeletal muscle and skeletal muscle and what? Skeletal muscle and adipose tissue. Skeletal muscle and adipose tissue have which glucose transporters? In yesterday's class, skeletal muscles and adipose tissue have glucose transporter type 4, GLUT4. Okay. So this was the question which was asked. And this is one question. Have I discussed this question in yesterday's class? Endocrine, in GIT, have I discussed this? Are you able to see this? Okay, let me read. A patient has a decreased iron level, okay, and he is taking iron medication. Which of the following decreases the iron absorption from gut? Which of the following decreases the iron absorption from gut? Which of the following decreases the iron absorption from gut? Yesterday, you know it. Tea. In yesterday's class, I have explained you tea and milk. Tea and milk. Tannins and phytates decreases the, see, here the option T. This is a recent FMG exam question. So, just trust your teacher. All questions will be done. But the one bad thing with my teaching is I will teach more. No doubt in that. My material is going to be vast. I teach more because I don't want any question to come out of the syllabus. Okay, every question should come from that notes, and that note should help you even to solve medicine and patho related questions. That's it. Okay. Then, chalo, let's continue. My screen is sharing, right? My screen is sharing. Yes, sharing. So let's start with the vascular physiology. Also completed. So yeah, vascular physiology. So now we are going to discuss about the vessels. Okay, vessels. So in vascular physiology, the first vessel that I'm going to discuss is the beautiful big blood vessel, which is called as aorta. Okay, aorta, sir. So aorta, the major blood vessels, not only just aorta, major blood vessels. Major blood vessels, not only aorta, all the major blood vessels, they will show an effect called as Wind-Kessel effect. What is this Wind-Kessel effect, sir? Wind-Kessel effect means, say if this is your left ventricle, if it is contracting, it will send the blood into the aorta. When the blood is coming into the aorta, what should happen to the aorta? First of all, the aorta should expand in order to receive the blood. Later on, the aorta should recoil back to push the blood forward. So this is called as Wind-Kessel effect. So it's the elastic recoil nature of the blood vessel. First, it should expand and later it should recoil back. So it's the
elastic recoil nature of a blood vessel after stretching. First it should stretch, later it should recoil back. So that is called as Wind-Kessel effect. Okay, Wind-Kessel effect. So aorta is having maximum Wind-Kessel effect. Not only aorta, other blood vessels also have the other major blood vessels also have the Wind-Kessel effect. Now, why I'm so particular about this? Because in one of the FMG exam, this question has been asked. Now try to answer this. Try to answer this. Yeah, this is the question. This is the question. All of the following arteries demonstrate Wind-Kessel effect except. All arteries will show the Wind-Kessel effect except. Say aorta will show the Wind-Kessel effect. From direct branch of aorta, carotid artery, it also shows the Wind-Kessel effect. Renal artery is a direct branch of aorta. It also shows the Wind-Kessel effect. But radial artery, when compared to the other arteries, is the minor artery. Because radial artery is there in your, the forearm. It also have Wind-Kessel effect, but less Wind-Kessel effect. Less Wind-Kessel effect. So this is the answer. Okay. So I am taking this. This was a previously asked question. So copy and paste. Okay, done. I have kept it here. Now, other important points about the aorta. See, aorta have the maximum blood pressure. Maximum BP is there in the aorta. Minimum BP is there in the vena cava. Okay. In aorta, there is maximum turbulence. Means if in the aorta, the blood is not going in laminar fashion, the blood is not going smoothly, the blood is going turbulent. Means like a whirlpool. Okay, the maximum turbulence is seen in aorta. True. This aorta have least cross-sectional area. This is where most of the students will confuse. Look here, this slide. Look here. This is your aorta. Come to this slide, aorta. You are having how many aortas? One aorta. And these are arteries. These are arterioles. Here are the capillaries. Okay, here are the capillaries. These are the capillaries. Students will think aorta is having maximum cross-sectional area and capillaries are having least cross-sectional area. Students will think like that. No, aorta is only one in number, but capillaries are millions in number. So capillaries have more cross-sectional area. Aorta have less cross-sectional area. Okay, aorta is having less cross-sectional area and capillaries have more cross-sectional area combined. Okay, so that's why here also see total area, cross-sectional area. Aorta is having less cross-sectional area, but at the level of capillaries, see, capillaries are having more cross-sectional area. Wherever there is less cross-sectional area, look at the velocity of the blood. If the cross-sectional area is less, what is the velocity? Velocity is more. But in the capillaries, wherever there is more cross-sectional area, here more cross-sectional area, what about the velocity of the blood? Velocity of the blood is least. Okay. So this is the same thing I have written here. Look. Aorta have less cross-sectional area. So maximum velocity of the blood. Capillaries have maximum cross-sectional area. Maximum cross-sectional area means least velocity of the blood. Done. Now, some important points about the aorta which were asked previously. These are integrated things. There is a disease called as a tertiary syphilis. If you get this tertiary syphilis, like it's a sexually transmitted disease, if you get this syphilis, your aorta will be affected. After the death, if you do the autopsy, the aorta will show tree bark appearance. So question asked, tree barking appearance from the patho, tree barking appearance of the aorta is seen in which disease? Syphilis. We are discussing about aorta, right? So that's why I have it included here. Okay. Now there is a aortic problem called as aortic dissection. And aortic dissection is the most common cause of death in which people? Marfan syndrome, connective tissue disorder. So there is a condition called as Marfan syndrome, very important, autosomal dominant disorder. Marfan syndrome, F. What is that F? Marfan, fibrillin gene defect. Fibrillin 1 gene defect. The fibrillin 1 gene defect. In Marfan syndrome, the patients will die because of aortic dissection. Okay, aortic dissection. Okay. Now, there is one more aorta-related problem. There is something called as a bicuspid aortic valve. Aortic valve should be having 3 cusps. But there is a condition called as a bicuspid aortic valve. Seen in which people? Bicuspid aortic valve is the most common cardiac anomaly in Turner's. Turner is trisomy. How much? Turner is not trisomy. Turner is 45x0. Yeah, this is Turner. Okay, 45x0. One X chromosome is lost. So this Turner females, if a female is a Turner, she may have bicuspid aortic valve. Okay, Turner females will have bicuspid aortic valve. Okay, but that's not the only thing. This Turner female, they will also develop one more abnormality. One more abnormality related to the aorta. Can you tell me what is that? Turner females ki inkoka aorta related problem kuda untundi. What is that? Turner female will also have one more problem with aorta. Can you tell me what is that? Turner females. Okay, let me see who can answer. Excellent, guys. It's a coactation. Rekha said first, it's a coactation of aorta. Satish Kumar, Rasul, Shalu, yeah, Najib, you are all true. Okay, it's a coactation of aorta. Remember that. So bicuspid aortic valve is the most common cardiac anomaly in the Turners. Also, there is coactation of aorta. Aortic coactation. So all aorta related points are completed. You know it. Vindicasal effect. What is vindicasal effect? You know it. Recoiling nature after stretching. Now, arterioles. You already know every point about the arterioles. What are they? Arterioles I have discussed. They have maximum smooth muscles. As they are having maximum smooth muscles, they show maximum peripheral resistance. TPR. Maximum TPR is there with the arterioles. As they are having maximum resistance, they are called as resistance blood vessels. Okay. Arterioles have maximum smooth muscles. Arterioles show maximum TPR. And arterioles are also called as resistance blood vessels. Now tell me, sir, arterioles, if they are constricted, arterioles are constricted, you know the thing. Sir, when arterioles are constricted, what happened to the resistance? Increases. When resistance increases, afterload also increases. You know it. Okay, you know it. So arterioles are constricted, TPR, total peripheral resistance, increases, afterload also increases. When the arterioles are dilated, when arterioles are totally dilated, there is no resistance. Blood can go easily. So when the arterioles are dilated, total peripheral resistance decreases and afterload also decreases. Okay, done. So with this, arterioles are also completed. Okay, next thing is Starling laws. Okay, Starling laws are not the Starling laws, sorry, Starling forces. Let me explain you the Starling forces in a minute. Starling forces. Sir, what are the Starling forces? Simple. Now here I am talking about a capillary. This is one capillary, sir. Okay. Where are the capillaries present? Capillaries are here in the tissues. These are the tissues, cells. Okay, these are the tissues. Okay. Now, this is starting point. This is ending point. Ending means near the veins. From here, veins are starting. Here are the arteries present. Arteries. This is the arteriolar end. This is the venular end. Okay. Now, blood is coming like this. The plasma is coming like this. Okay, plasma is coming like this. Now, my question to you. Will the plasma comes out or not? Yes, the plasma will come out. Why the plasma is coming out? How and why the plasma is coming out? Because you should know. Here in the blood vessel, there is something called as hydrostatic pressure. Let me write with a bold letter. So there is something called as hydrostatic pressure represented with P. Hydrostatic pressure means what? Plasma always exert pressure on the walls. Okay, the plasma is exerting the pressure on the walls. So that pressure is called as hydrostatic pressure. And how much is that hydrostatic pressure? Look, that hydrostatic pressure is 35 mmHg. That hydrostatic pressure is how much? 35 mmHg. That hydrostatic pressure, what it is trying to do? It's trying to push the plasma out of the blood vessel. In the same here, there is one more pressure called as oncotic pressure. What is this oncotic pressure? How to understand this? Now imagine you keep sponge pieces. For example, you take a beaker. Okay, beaker this one. You just take a beaker and you have some sponge pieces. Keep sponge pieces. And what the sponge pieces will do? Tell me. The sponge pieces will attract the water. Okay, absorb the water. So the sponge is trying to keep the water with them. Sponge is trying to keep the water with them. So in the same way, in our blood also, there is something called as albumin. There is something called as albumin. What this albumin will do? Albumin will generate a force called as oncotic pressure. It will try to hold the plasma. It will try to hold the plasma within the blood vessel. It is trying to hold the plasma within the blood vessel. So this opposite force is called as oncotic pressure. How much is that? 25 only. So who is more? Sir, hydrostatic pressure is more. It is trying to push the plasma out. And how much is the oncotic pressure? Just 25. So that's why the net pressure that is more. Okay, 10 mmHg more. So that's why fluid is going out. Okay, fluid is going out. Okay. Now my question to you. Sir, do you want the fluid accumulation in your tissues? Do you want to accumulate the fluid inside your tissues? Definitely not, sir. Definitely not. We don't want to accumulate the fluid inside our tissues. So what happens is at the end of the capillary side, what happens is here the hydrostatic pressure, as already the fluid came out, hydrostatic pressure is decreasing. For example, it became 18 mmHg. But what about the oncotic pressure? Oncotic pressure is more now here. Here it is 25 mmHg. Here it is more. So what it will do is the oncotic pressure, this is like a sponge base, they will absorb the water back. They will absorb the plasma, I should say that. They will absorb the plasma back into the blood vessel. Okay. So these pressures, hydrostatic pressure and oncotic pressure, these are the Starling forces. Okay. So let me show you the conclusion. Conclusion is shown here. Conclusion is beginning of the capillary, the starting point of the capillary, hydrostatic pressure is more than the oncotic pressure. Hydrostatic pressure is 35, oncotic pressure is 25. So fluid moves out. At the end of the capillary, hydrostatic pressure is less, only 18. Oncotic pressure is 25. So fluid comes back into the blood vessel. Okay, done. So conclusion is done. So conclusion important. Right? Next, veins. Let me discuss points about the veins. So veins, the recent FMG exam question. Do you know what is the recent FMG exam question? I will show you in a minute. See, in veins, it contains maximum blood volume. Our veins contain maximum blood volume. Okay. Our veins contain what? Maximum blood volume. Now, if you take a vein, see here, if I am showing you a vein like this, in the vein, who is there in the center? Which cells are going in the center in the veins? The RBC. RBC going in the center. Okay, center. After that, what is there? After that, platelets are there. Small platelets are there. And later, WBCs are there. Bigger cells. WBCs are there. So in the center of the vein, which blood cells are there? Which blood cells are there? This is the RBC. Just look at me. Sir. RBC, this is the question. See, this is the question. The recent, it was there in the PYQ. It's a PYQ. Yeah, it's not just a PYQ. It's a recent. 20 days back, this question was asked. See, central veins. Okay, central veins have which type of cells? In the center, answer is RBC. Okay, answer is RBC. So, know that one point. Veins have maximum blood volume. 55% of the blood is there in the veins. As they're having more capacity to hold the blood, they're called as capacitance blood vessels. Veins have maximum diameter. If you look at a vein will be something like this. They are a very thin wall. Veins have very thin wall. Okay, so they're having maximum lumen, maximum diameter. Okay, and inside the veins, if you look, the veins have something called as valves. Inside the veins, you have valves, just like a hot valve. Okay, the veins have valves. Okay, done. So veins contain valves. True. Veins have maximum diameter. Veins have more blood volume, and maximum capacitance is there. So they are called as capacitance blood vessels. Veins are called as capacitance blood vessels. Okay. Arterioles are called as resistance blood vessels. Okay. Arterioles are called as resistance blood vessels. And if you want to know capillaries, these capillaries, okay, this is a capillary, right? They are exchange vessels, exchange. Because there is exchange of the fluid. See, the fluid is going out and the fluid is coming in. So there are exchange of materials that are happening. The nutrients will go to the tissues, waste products will come back. So they're called as exchange vessels. Capillaries, done. Okay. Now, let me tell you something. Look here. Normally, what is the normal order? Normal order. So there is artery. There will be arterioles. Later on, there will be arterioles. There are capillaries. Capillaries are fusing with the venules. Venules with the veins. Veins with the vena cava. You know this stuff. Okay, normal. That's something normal. Sir, artery, aorta, artery, arterioles, capillaries, venules, veins. That's a normal thing. But there are certain places in the body. Okay, certain places in the body where artery is directly going to fuse. For example, look at here. There are certain places in the body. This is normal. Top thing is normal. But look here. Certain places in the body where artery is directly fusing with a vein. Arteries are directly fusing with a vein. This is called as AV anastomosis. Arteriovenous anastomosis. This is something special. This arteriovenous anastomosis, it is present under your fingertips. It's there under your fingertips. It helps in maintenance of the temperature. Okay. So this AV anastomosis, where they are present is fingertips and in the earlobes. This AV anastomosis have a role in thermoregulation. Okay, they have a role in thermoregulation. See, this AV anastomosis identify the surrounding temperature and they will maintain the body. They will maintain our body temperature. Okay, not too much important. Just remember, AV anastomosis seen in fingertips. AV anastomosis seen in fingertips. Okay, that's called as a glomus body. Glomus body. Okay, in the fingertips, there is something called as a glomus body, which is nothing but AV anastomosis. Okay, let me write here. If you want to know, that will come in your pathology also. Glomus tumor, something called as a glomus tumor. But anyway, so glomus body under your fingertips. Okay, that's glomus body is nothing but the AV anastomosis. Yeah, done, completed. Next point which I want you to know is this clinical link is not that important. Next point which I want you to know is lymphatics. Sir, what are these lymphatics? What are these lymphatics? Lymphatics, let me explain you. Same thing. This is a capillary. Here is a capillary. What are these? These are the tissues. Now fluid is coming out. Look, fluid is coming out. Fluid is going in again. For example, 100 ml fluid, 100 ml plasma came into the tissues. 90 ml is going back. So 10 ml is left over in the tissues. 10 ml is left over. Do you want any fluid accumulation in your tissues? No, we don't want any fluid accumulation inside our tissues. We don't want any such fluid. So even this fluid need to be removed. We have to remove this fluid, and that will be removed by special blood vessels called as lymphatics. So the leftover fluid in the tissues will be removed by lymphatic blood vessels. Look here carefully. See, these green color channels are the lymphatic blood vessels. They will collect the leftover fluid, or if there is any leftover fluid is there, that will be removed. Okay, so this lymphatic blood vessels. Okay, now tell me, what if this lymphatic is blocked? What if this lymphatic is blocked? Sir, now fluid will start to accumulate inside the tissues. That is called as lymphedema. Okay, so look here. What are lymphatics? Any fluid left in the tissues will be brought back into the veins. See, all this lymph is coming, and where it is going? Again, going back into the venous blood. Okay, so any fluid left in the tissues will be brought back into the veins via lymphatics. Lymphatic obstruction. If the lymphatics are obstructed, lymphatic obstruction causes lymphedema. Fluid is getting accumulated inside the tissue. See, this is the lymphedema. Image-based question in the last FMG exam, not the recent one, the previous one. Okay, last but one exam. This is the exact image-based question was asked. Okay. They have asked which blood vessels are blocked. Which blood vessels are blocked? It's the lymphatics. Lymphatics are blocked. This condition is called as elephantiasis. Like elephantiasis. So lymphatic obstruction causes lymphedema seen in filariasis or elephantiasis. Filariasis or elephantiasis. The treatment for this condition is albendazole, diethyl carbamazine. Okay, diethylcarbamazine and albendazole, they are the drugs which are used, but still you can't treat this condition. Okay, it's not treated permanently, but you can use those drugs. So lymphatics also completed. Image based question, important. Previous exam, not the previous one, that previous one. Okay. So the last two slides is the hemodynamics. Okay, hemodynamics. Question which was asked in the 2019 FMG exam, direct question was asked. What you need to know in hemodynamics? Only one formula. Most of the student knows this. The formula which I want you to know is Poiseuille-Hagen formula. This Reynolds number, this is all for the first year students, not needed. What is this Poiseuille-Hagen formula? What is this Poiseuille-Hagen formula? Poiseuille-Hagen formula tells us blood flow is dependent on 4 parameters. Okay, blood flow is directly proportional to pressure difference. I will explain, don't worry. Blood flow is also dependent on the radius, but blood flow is inversely proportional to length and viscosity. Okay, let me write here. Blood flow is directly proportional to pressure difference, delta P. What does it mean by, sir? What is this? First, let's discuss about what is this. Blood flow is directly proportional to delta P. What is this? For example, let me take two blood vessels, blood vessel A and blood vessel B. Okay, let me take X and Y. For example, X, blood vessel X and blood vessel Y. This is point A and this is point B. Point A and point B. Now here, the pressure in the starting point is 100 mmHg. Here at the point B is, for example, 1 mmHg. In the blood vessel is Y, here the starting point pressure is 100 mmHg. At Y, the pressure is 99 mmHg. Where do you think blood flow will be there? Where do you think blood flow will be there? Where do you think the blood will flow from A to B? In which blood vessel? X or Y? In which blood vessel do you think blood will move from A to B? X or Y? Everyone is saying X. Why you are so much, like, what is your love with that X? Mariam is correct, both. Okay, both. The answer is both. Okay, because fluids will move from high pressure to low pressure. Okay, fluids, see, here it's the higher pressure, here it's the lower pressure, here it's the higher pressure, here it's the lower pressure. In both the cases, the blood will move. But here, what is the delta P? What is the difference? The delta P means difference. What is the pressure difference? Here it is 100, here it is 1. So here the delta P is 99 mmHg. But here the delta P difference is how much? Only 1 mmHg. So here there will be more flow. Here there will be more blood flow. Here there will be less blood flow. Okay, so that's what Poiseuille-Hagen's formula is telling us. More the pressure difference, more flow will be there. Okay, more the pressure difference, see, that's why. See, more the pressure difference, more blood flow. Okay, so one thing is completed. Next, let's talk about the radius. Let's talk about the radius. Now, what about the radius? See, according to Poiseuille-Hagen's formula, Q is directly proportional to R to the power of 4, means blood flow is directly proportional to the radius. Okay. Now, let me explain you with the two examples. Here, there is one blood vessel, same X. Here there is other blood vessel, that is Y. Okay, X and Y. Point number A, point number B. Also, no need of points. The radius of this blood vessel is R. The radius of this blood vessel is 2R, means double the radius. Okay, the length of this blood vessel is L. The length of this blood vessel is also L. Lengthwise same length, but just what is doubled? Radius is double. So now tell me, where do you think more blood flow will be there? So definitely here, sir, more blood flow will be there because it is having more radius. So it's double the radius. So how many times the blood flow is going to be there? When compared to X, in Y, how many times more blood flow is going to be there? The radius is doubled. So how many times? 2 times, the blood flow will be doubled, right? The blood flow will be doubled, right? Tell me. The blood flow will be doubled or tripled? When compared to X, Y will be having more blood flow because it's having more radius. How much blood flow is going to be there?
Doubled or tripled? Alisha, Vamsi. You're saying double. How many times do you think more blood flow will be there? Yes, Viraj, you are excellent. Viraj is correct here. Viraj, Salva, you are true. It is 16 times. The blood flow is going to be 16 times. 16 times more blood flow is going to be there. Okay? Because look at the formula. R to the power of 4. So here, according to the formula, let's write. Q is directly proportional to R to the power of 4, which means Q is equal to R to the power of 4. What we have done with the radius in our question? What we have done with the radius? We have doubled the radius. So 2 to the power of 4. How much? 16 times. 16 times. When you double the radius, 16 times more blood flow is going to go. When you triple the radius, how much blood flow will go? When you triple the radius, 81 times more blood will go. 81 times more blood flow will go. So that's why R to the power of 4. R to the power of 4. So the same question was given here. Look at this. Sir, if the radius of the blood vessel doubles, what happened to blood flow? 16 times increases. If the blood vessel radius is tripled, what happened to blood flow? What happened to blood flow? 81 times more blood flow. Okay, 81 times more blood flow. Yeah, here it was given 81 times more blood flow. Okay, now let me answer. Let you guys answer this. Look at this. Sir, again, I'm taking a blood vessel X and blood vessel Y. This is X. Here is Y. Okay, X and Y. What is the difference? Here the radius is R. Here the radius is 2R. Here the length is L, and here the length is 2L. Now, when compared to X, what is the blood flow in Y? Okay, blood flow in Y. Tell me, what is the blood flow in Y? How many times? Here the radius is R. Here the radius is 2R. When compared to the blood vessel X, how many times more blood flow will be there in the Y? Let me see who can answer. Raj, Salva. 8 times. Excellent, guys. 8 times. 8 times. Not 16. Don't say 16. Satish, it's not 16. It is 8 times. Because, see, what you need to understand is length is also doubled. Length is also doubled. Now, what is the formula? Formula is Q is directly proportional to radius to the power of 4. But inversely proportional to length. According to Poiseuille-Hagel's formula, length is inversely proportional. Inversely proportional. So, here what I have to do? Radius double 2 to the power of 4. 2 to the power of 4 divided by what happened to the length? Length also doubled. So 2 to the power of 4 is 16. 16 divided by 2 is 8. So there will be 8 times more blood flow. So 8 times more blood flow. Because length is also increased. Length is also increased. The same question was given here. In your book, it is there. The same thing. The amount of blood flow in vessel A compared to B. This is A. This is A and this is B. Okay. Here it is L. Here it is 2L. Okay. The answer is 8 times. Okay. So the answer is 8 times. It was already given in your book. 8 times. Next. Almost the last topic in the hemodynamics. The relationship between, okay, not the wife and husband, the relationship between a radius and resistance. Okay. What is the relationship between the radius and resistance, sir? Here's the formula. Resistance is inversely proportional to radius to the power of 4. You understood? Resistance is inversely proportional to radius to the power of 4. If you ask me, sir, is that important? Should we have to remember? 100% important, no doubt. Questions has been asked. Resistance is inversely proportional to radius to the power of 4. So what does it mean by? Look, if you double the radius of a blood vessel, what happened to resistance?
resistance decreases by 16 times. You know the formula. Resistance is inversely proportional to radius. So resistance decreases by 16 times. Okay. Now it makes sense. See, what I want you to know is, when radius doubles, 16 times more blood flow will be there. But why 16 times? Why not 17 times? Why not 20 times? When radius is doubled, first resistance decreases by 16 times. So blood flow increases by 16 times. First, what happens? When you double the radius, first resistance in that blood vessel decreases by 16 times. Resistance in that blood vessel decreases by 16 times. So there will be 16 times more blood flow. 16 times more blood flow. Okay. So the relationship between radius and resistance. Resistance is inversely proportional to R to the power of 4. Okay. Now you tell me, okay. You tell me, sir, when you triple, okay, try to answer this. What I have done is triple the radius. What happened to resistance? Tell me. Resistance in the blood vessel. If I triple the radius of the blood vessel, what happened to resistance? What happened to resistance? Everyone, if I triple the radius, what happened to resistance? Resistance decreases by 81 times. Excellent. Yes. Resistance decreases by 81 times. So done, sir. Vascular physiology also done. Okay, vascular physiology. Sorry, that hemodynamics is also done. Okay. Last 2 slides. That's the clotting pathway, clotting cascade. This question was asked in the recent 20 days back exam. No, this was not asked 20 days back. The question was asked in the last FMG exam, June attempt. In the last June, question was asked. Do you know what is that question was asked? Anyone, have you gone through the PYQs? Do you know what is the question that was asked in the FMG exam regarding this clotting cascade? It is also a topic of physiology. It will also come in pathology, but physiology, little detail. Anyone knows what is the question? Najib, you are asking if you double the radius. I'm talking if I double the radius. Okay. If I double the radius means doubling the radius means what? I'm just causing the dilation. If I'm doubling the radius means I'm causing the vessel to dilate. If I cause the vessel to dilate, more blood will go. Not 2 times, but 16 times more blood will go. If I do the dilation of the blood vessel by giving some vasodilators, I have taken some nitrate. Okay, sorbitrate or isosorbide dinitrate, isosorbide trinitrate. If I take nitrates, my blood vessels will dilate. More blood flow will be there. How much more? 16 times more blood flow will be there. Okay, so he's asking the previous slide. This one, I think, triple the radius, resistance decreases by 81 times. Next. So clotting cascade. Is it important? Keep 10 star marks. That much important. Super high yielding topic for FMG exam. Okay. Now, sir, what is this clotting cascade? Sir, it's a little hard for you to go through each and every step, but let me make it as simple as possible. Okay, just follow me for the next 10 minutes. Just follow me. I will make it easy. What is the goal of clotting? What is the goal of clotting? What is the final step in the clotting? What you need to do is you need to convert what? A soluble fibrinogen. Okay, a soluble fibrinogen need to be converted into fibrin. Okay, the soluble fibrinogen need to convert it into insoluble fibrin. Okay, soluble fibrinogen need to be converted into insoluble fibrin. That's the goal of clotting. Okay, I will explain you what is this. How many clotting factors are there? Clotting ke liye, how many clotting factors are there? So there are almost 12 clotting factors are there. Okay, 12 clotting factors are there. Okay, so like 1, 2, 3, 4, 5, 7, 8, 9, 10, 11, 12, 13. Okay, so which clotting factor is missing? Clotting factor number 6 is missing. There is no such thing as clotting factor number 6. Clotting factor number 6 is missing. So if you count total, there will be 12 only. Okay, number wise it will be 13, but if you count total, there are 12 clotting factors. 12 clotting factors. Now, if you want to know this pathway, intrinsic pathway and extrinsic pathway, let me explain you in just 5 minutes. First, always write 10 in the center. Write 10 in the center. Okay. How many clotting factors are there? Sir, there are 12 clotting factors. Write 12 here. Okay, 12. Before 12, what is the number? 11. Before 11, what is the number? Already 10, it was written here. Before 10, 9. Before 9, 8. Before 8, 7. Okay, so that's it. Here it is completed. This pathway, which I have shown here, is called as intrinsic pathway. Intrinsic what? Pathway. So this pathway, which I have shown here, 7 and 10, this is called as extrinsic pathway. Extrinsic pathway. How much is 10, sir? How much is 10? How much is 10? 5 twos are 10. So 5, 2, 1. Okay, 5 to 1. 5 to 1. So this is the common pathway. Okay, this is the common pathway. Here is common pathway. So now you'll have it out, sir. What is this? First of all, I don't understand what is intrinsic pathway, what is extrinsic pathway, and what is the common pathway. I don't understand it. Don't worry. Simple. First, in intrinsic pathway, first clotting factor number 12 is activated. Okay, first clotting factor number 12 is activated. It activates 11. It activates 9. 9 activates 8. 8 activates 10. 10 activates 5. 5 activates 2. 2 activates 1. Aha, okay. So what is 1? 1 is, see, first of all, 2 is thrombin. 2 is thrombin. 2 is thrombin. What this thrombin will do? What this thrombin 2 will do? It will convert soluble fibrinogen into fibrin. Insoluble fibrin. It will form the clot. This insoluble fibrin will form the clot. Okay, it will form the clot. It will form the meshwork. It traps all the platelet. It traps the RBC and it forms the clot. Okay. Now, just wait. Just wait. Now you'll get it out. Sir, why this clotting factor number 12 is activated? First of all, why it is activated? Why clotting factor number 12 is activated? See, the name itself is an intrinsic pathway, right? Your blood vessel, let me show you here. Let me show you here. Array, this is your blood vessel. This is your blood vessel. Your blood vessel is lined by which cells? Endothelial cells. These are all the endothelial cells. Okay. These are all the endothelial cells. The endothelial cells, they are lying on what? They are lying on the basement membrane. So this is what? Basement membrane, which is made up of collagen. Whenever the blood vessel is damaged, look, normally clotting factor number 12 is inactive. Initially, the clotting factor number 12, which is there in the plasma, this is inactive. When the blood vessel is damaged, look carefully. See, when the blood vessel is damaged, for the first time now, this subendothelial collagen is exposed. Now the subendothelial collagen, it is exposed. Now, whenever the subendothelial collagen is exposed, now this clotting factor 12, see, when the clotting factor 12, when it comes into contact, clotting factor number 12 is activated. That's it. So it's the subendothelial collagen, which is intrinsic to the blood vessel, which is there within the blood vessel. It activates clotting factor number 12. Okay, so 12 is activated by subendothelial collagen, which is there within the blood vessel. So that's why it's called as the intrinsic pathway. Once 12 is activated, 12 activates 11, 11 activates 9, 9 activates 8, 8 activates 10. That's it. Okay. Then what is this extrinsic pathway? Extrinsic means from outside. Extrinsic from outside. And if there is any damage, do you think only blood vessels are damaged? If there is any injury, do you think only blood vessels are injured? No. Tissues are also damaged, surrounding tissues. Okay, tissues damaged. So the damaged tissue will leak a substance called as tissue factor. They will release a substance called as tissue factor. This third is nothing but tissue factor. So this tissue factor, it will come into the blood from outside, from the damaged tissues. From the damaged tissues, this clotting factor number 3, that is nothing but the tissue factor, it will come into the blood and it activates 7. 7 activates 10. Once 10 is activated, you know the story. Common pathway is activated. So that's it. So this is the common pathway. Do you know what is the question which was asked in the FMG exam? The question which was asked in the FMG exam is clotting factor number 7 is involved in which pathway? That's it. That's the question. Now you tell me. Clotting factor number 7 is involved in which pathway? Clotting factor number 7 is involved in which pathway? Extrinsic. Clotting factor number 7 is involved in extrinsic pathway. Right? Now you tell me clotting factor number 8 is involved in which pathway? Clotting factor number 8 is involved in which pathway? Intrinsic pathway. Clotting factor number 2 is involved in which pathway? Common pathway. Common pathway. So deficiency of clotting factor number 8 affects which pathway? Clotting factor number 8 deficiency. Clotting factor number 8 deficiency affects which pathway? Intrinsic pathway. Okay. So in the laboratory, even the small laboratory, roadside laboratories, they can measure this time. How much time is taking for the intrinsic pathway? How much time is taking for the extrinsic pathway? There is a study. There is a study to estimate the time for intrinsic pathway and estimate the time for extrinsic pathway. Do you know what is the time? Do you know what is the time? An intrinsic pathway is a bigger pathway, right? Bigger pathway. So it have a bigger name. Bigger name. What is that? PTT is the study. Partial thromboplastin time. PTT is the time for intrinsic pathway. Extrinsic pathway is a smaller pathway. So the small time. PT. PT is the time for extrinsic pathway. PT measures. Now tell me. PT measures extrinsic pathway. PTT measures intrinsic pathway. So in FMG exam, that question which was asked, now you tell me, sir, factor number 8 deficiency. Factor number 8 deficiency elevates which time? Are factor number 8 deficient hai to, now which time is going to be more? It takes a lot of time. Which time is going to be more? PTT time is elevated. PTT time is elevated. Factor number 7 deficiency. Factor number 7 deficiency. PT time elevated. PT time elevated. PT. Okay. So these are the things which I want you to know. And again, other previous year FMJ questions from this topic. Sir, if you are a really good student, you should have asked me something. Sir, there is some clotting factor that is missing. Can you tell me what is the clotting factor that is missing? There is this one clotting factor that is missing. Can you tell me what is that? Which clotting factor is missing? Which number is missing? 6. First of all, 6 is not there. 6 is not there. Forget about it. Which clotting factor is missing? 4. Clotting factor number 4 is missing over there and 13 is missing over there. First of all, 4 is missing. Where is 4? Sir, clotting factor number 4 is nothing but calcium. Okay, so calcium is required everywhere. Every place may you require calcium. So calcium is, let me write here, calcium is clotting factor number 4. And you need it every place. Okay, so everywhere you require the calcium. So right, calcium is the clotting factor number 4. And you need it. For the activation of clotting factors, you require calcium. For the activation of clotting factors, you require the calcium. And where is 13? Once you have fibrin, you need to stabilize it. So clotting factor number 13 is the fibrin stabilizing factor. Not needed, never ask. Just if you want to know it. It's a fibrin stabilizing factor. It's a fibrin stabilizing factor. Factor number 13. It stabilizes the fibrin, cross-links the fibrin, and it makes the fibrin stronger. So that's it. Now let me show you questions which were asked in the previous year exams. See, look here. You know it. This is the Poiseuille-Huygens formula. Just wait 1 second. Yeah. See, you know, blood flow is directly proportional to pressure difference, directly proportional to radius to the power of 4, but inversely proportional to length and viscosity. Okay, inversely proportional to L means length and N means viscosity. This is the Poiseuille-Huygens formula. If the radius of the blood vessel is doubled, What happened to the blood flow? Increased by 16 times. 2019. This question was asked in FMG. Okay, 2019 mein this question was asked. Next question. Next question. Which I want you to know. Just wait. I think I kept it in endocrine. Here. So this one. So prothrombin to thrombin conversion. So prothrombin to thrombin conversion means clotting factors are getting activated. Conversion. Which of the following is required? Calcium is required. Calcium is required for the activation of clotting factors. Okay. For the activation of clotting factors, what do you require? You require calcium at every stage. See, calcium is everywhere. So calcium is required. Calcium everywhere. See, there is intrinsic pathway, there is extrinsic pathway, and this is the common pathway. Okay. What is the final event that should happen? The fibrinogen should be converted into fibrin. And after that, it should be stabilized. That's the clotting factor number 13 is the fibrin stabilizing factor. Okay. That's it. Now, last slide. Last slide is this one. What is this last slide, sir? I have said you from the last slide, one question was asked. Okay, let me tell you what is that. Say factor number 2, 7, 9, 10. Okay, for the function of this factor number 2, 7, 9, 10, if you want the factor number 2, factor number 7, factor number 9 and 10, if you want these factors to function, you need to do something special. What is that? That is called as a gamma carboxylation. Okay, gamma carboxylation. See, look, just wait. Look at here. See, there is reduced vitamin K in your body. This is good. This is a really good guy. Okay, reduced vitamin K. Now, what is this reduced vitamin K will doing? Reduced vitamin K with the help of this enzyme, gamma glutamyl carboxylase. In the name itself is there gamma carboxylation. Okay, so vitamin K, reduced vitamin K, with the help of this enzyme gamma glutamyl carboxylase, what it is doing? It activates factor number 2, 7, 9, 10. It will cause gamma carboxylation of, see, now the factors are getting activated. Factor number 2, 7, 9, 10 are getting activated with the help of enzyme gamma glutamyl carboxylase, with the help of vitamin K, reduced form of vitamin K. But during this process, the reduced vitamin K itself is getting oxidized. It is getting oxidized. Okay. But what do you need? You require which form of vitamin K? You require reduced form of vitamin K. So this oxidized vitamin K, see, it will be converted back. It is getting converted back into reduced vitamin K. It is converted into reduced vitamin K with the help of a different enzyme called as vitamin K epoxide reductase in the liver. In the liver, the oxidized vitamin K will be converted into reduced vitamin K. Reduced vitamin K. Okay, this is something normal. Till here it is normal. Now, look, again I am repeating. Reduced vitamin K with the help of enzyme gamma glutamyl carboxylase causes the gamma carboxylation of which factors? 2, 7, 9, 10. So they are activated. During this process, the vitamin K is getting oxidized. So you need to regenerate the reduced form of vitamin K back. For that purpose, who is helping? Vitamin K epoxide reductase is helping. Okay. Now, look, if you use a drug called as warfarin, if you use this drug, what happens? This enzyme will not function. Vitamin K epoxide reductase will not function. So you are not generating the reduced form of vitamin K. So gamma carboxylation will not occur. So factor number 2, 7, 9, 10 are not activated, not gamma carboxylated. That's it. So no clotting. So that's why warfarin is a anti-clotting drug. Now you understand why warfarin is the anti-clotting drug. Warfarin is anti-clotting drug because it inhibits what? It inhibits vitamin K epoxide reductase in the liver. Okay, so this is the thing. So this is the point which I want you to know. Okay, so vitamin K. See, how I used to remember, how I used to remember, war mein what happens? War. If there is a war, there will be killing. So war farin. So something like to war mein killing. So it inhibits the vitamin K epoxide reductase. So vitamin K is not available. No gamma carboxylation. 2, 7, 9, 10 factors are not activated. That's it. Now tell me, sir, now you tell me, in vitamin K deficiency, if vitamin K is deficient, 2, 7, 9, 10 are not activated. If 2, 7, 9, 10 are not activated means, if 2, 7, 9, 10 are not activated means, which pathway is affected? Now tell me, last thing, final thing. In vitamin K deficiency, factor number 2, 7, 9, 10 are not activated. So which pathway is affected? Is it intrinsic pathway, extrinsic pathway, or common pathway? Which pathway is affected in vitamin K deficiency? All pathways will be affected. Okay, all pathways are affected. Okay, all pathways will be affected. Yes, it's an anti-clotting, right? So no coagulation is going to happen, no clotting is going to happen. So done, sir. Done. So with this, all things whatever I need to teach, all things are completed. Okay, now some of you might have gone through, like, for example, after the class, what you guys will be doing is, you will be doing like, for example, some marrow Q bank or preparator Q bank, or you might be going through some, like, some Q bank, like, FMG solutions or Kamal KV solutions. So you might be going through them, and you might say, like, sir, I can't answer all the questions. Like, see, not you. No one can answer all the questions. Okay, no one can answer all the questions. Those Q banks are mainly designed for the NEET PG purpose, INICT purpose. Okay, and they're all hypothetical questions also. If you know this much, that's more than enough. Okay, more than enough. So with this, all the cardiovascular topics are completed. And mainly physiology, mainly cardiovascular physiology topics are completed. Now, one thing is left over, which I have missed to add it in the book. One thing which I have missed to add it in the book. Let me tell you what is that, which is also important, equally important. Where it is. Let me show you. It's missing. It's very important. Yeah, this one. Dicrotic notch. So this is the thing which I want you to know. Let me add the same thing in your book also. Copy. Done. Let me add dicrotic notch after the cardiac cycle. That's the appropriate place. So now, any one of you know what exactly is the dicrotic notch? So dicrotic notch is the due to dicrotic notch. Now, most of the students don't know what is dicrotic notch. Let me tell you what is dicrotic notch. This is your left ventricle. Look. Okay. This is your left ventricle. Here are your major blood vessels. That's the aorta, arteries, you know the stuff. And what is this wall? This wall here is the aortic wall. Aortic wall. When left ventricle is contracting, tell me, how much pressure is generated? 120 mm Hg pressure is generated. From 5, the pressure is increasing to 80. From 80, the pressure is increasing to 120. Pressure is increased. So when the pressure is increasing in the ventricle, blood is going out. Same pressure is also transmitted. No, along with the blood, pressure is also transmitted. So the pressure in your blood vessel, see, the pressure in your blood vessel also increases like this. Increased. The pressure is increased. Later on, what happens? Now the pressure is coming from 122 back to 80. Pressure is decreasing. So also in your blood vessel, Pressure is decreasing. Pressure is decreasing. Okay. Now, when the pressure becomes 79, immediately what happens? When the pressure becomes 79, now this aortic valve closes. Okay. Now what happens? Now this aortic valve closes. Now aortic valve closes. But you need to understand then what is the status of this aorta. And during the time, the aorta is stretched like this with lot of blood. Lot of blood is there. Now the blood, now the valve is closed. First of all, the valve is closed. Now the blood will rush back. Now the blood will try to go back, but the valve is closed. Now what happens is now the aorta will squeeze. I have said Windkessel effect. The aorta will squeeze to push the blood forward. That's why there is a little elevation in the pressure. Okay, there is a little elevation in the pressure. See, this is the place where aortic valve closed. After the once the aortic valve is closed, again there is a little elevation pressure. Why there is little elevation pressure? Because your aorta is squeezing to push the blood forward. Okay, your aorta is squeezing to push the blood forward. Again, it will come down like this. Okay, so this is called as this notch which I am showing you here. This notch which I have shown you here. This notch is called as a dicrotic notch. When do you have this dicrotic notch? Exactly when the aorta is closed. Sorry, aortic valve is closed. When the aortic valve is closed, you are having this dicrotic notch. After the dicrotic notch, what happens? Now aorta is squeezing to push the blood forward. So that's why there is a little increase in pressure. And later on, the pressure here also decreases because all the blood is moving forward. So the pressure also gradually comes down. So the same thing here. Look. Now, when the heart is contracting, when the left ventricle is contracting, see, the blood pressure is increasing and blood pressure decreases. Here you are having dicrotic notch. After that, there is a little elevation pressure because the aorta is squeezing. There is a little elevation pressure. Later it decreases. So this notch is called as, this little dip is called as dicrotic notch. So during exactly this time, okay, exactly this time, what is happening? See, aortic valve closes. At this area, aortic valve is closing. Okay, so that's it. So dicrotic notch is due to closure of aortic valve. Or I should say, when you are having dicrotic notch occurs when the aortic valve is closed. Okay, so this is the one MCQ which was tested 2-3 times. So I have included here. Simple. In your blood vessel, first pressure increases and decreases. When it is decreasing, there is a little elevation. That's it. This notch area is called as a dicrotic notch. When it will occur? When the aortic valve is closed. When the aortic valve is closed, here you are having a notch. Once the aortic valve is closed, there is a little elevation pressure. That's it. This is called as a dicrotic wave. This is a little elevation is there. No, this is called as a dicrotic wave. But that is not important. Leave it. So, done, sir. I hope I have done justice from my side. No need of Vickers diagram. Forget about the Vickers diagram. No need. No need. It's not even asking in the NICT exams. Not at all needed. Just strike it out. The Vickers diagram is not needed. Just leave it. So I believe I have done the justice from my side for the cardiovascular system, all the cardiovascular system. When we are doing the rapid revision, final at the end, we will be doing the rapid revision. At that time, I will include little bit more things. I will include, like, I will show the ECG. I will show the ECG and I will ask you, what is this? I will teach you ECG only in the rapid revision, not now. Because I can't teach ECG right now because you have to do the medicine. Without doing the medicine, I can't teach you the ECG. Even if I teach you, it will unnecessarily create, like, havoc. I don't want that. So done, sir. Cardiovascular completed. Next topic. Which topic do you want me to teach? I will give you a break, a little break, small break I will give you. After that, which topic do you want me to teach? Just wait. First of all, let me share this PDF now itself. Just keep it in the chat box. Let me share it. Export and send PDF, export. Continue. Let me share it with Arise Handy. Done. A PDF is shared and you can get from him.
Hello, guys, are you there or not? Guys, are you there? Disconnected? Oh, I'm there, I'm there. Yeah, even my energy is deteriorated. Yeah, I will give the break. I will give you the break. I will teach the small topic. Okay, I will teach the small topic. Which topic? Central nervous system or respiratory or renal? Three major systems are there. Three major systems are there. Renal, respiratory, CNS. So respiratory. Okay, respiratory. It's done. Harish said respiratory. Yeah, we will go with the Harish. Alisha, Jitendra, you are all saying respiratory. Okay, we'll start the respiratory system. Go and have a tea. Now the time is 4:40, right? I will start it. How much time? 10 minutes break is needed? 10 minutes or 5 minutes? Respiratory, I will do. Okay. Take a break. Take a break. Exactly, I will meet you at 4:50. Exactly, I will meet you at 4:50. Sir, of course, even my energy will be draining from morning if I'm teaching. Like one-to-one class is different. Like one-to-one class, I'll be having more jokes. Like we can enjoy the things. But online class, I'm not seeing you. I'm looking at my camera. I don't know whether you guys are listening or not. I'm doing it. It's a little tough. Online classes are little tough, but okay, we'll do that. Okay, done. 10 minutes break. Hello guys, am I visible? Please confirm me because I can't see my face. Yeah. Yes, I'm visible, right? Okay. So let me stop the screen sharing for a second. I'm stopping the screen sharing. Let me download the respiratory. Respiratory physiology downloaded, and let me open this. Okay, done. Which Q bank is good? Like every Q bank is good, but try to do it in FMG mode. You can try to do it in FMG mode. Rather than going through the Q banks, go through the books. Like, because most of the Q banks are designed for PG. Most of the Q banks are designed for the PG and INICT. So you'll have very high level questions. Okay. Rather than going through those Q banks, you can go through the FMG books. FMG, books. Like FMG solutions, one book is there. Kamal KV solutions, one book is there. Okay, FMG solution, Kamal KV solutions. They are more than enough. Okay. FMG solutions and Kamal KV, like FMG solutions and Kamal KV. One FMG book is there. You can go through them. So, okay. Before starting the respiratory. Okay, now I'm going to start the respiratory. Now, before entering into the respiratory, first itself I'm telling you, see, in physiology, the highest conceptual topic is not cardiovascular, it's not endocrine, it's respiratory. Even most of the teachers find it difficult to teach respiratory physiology because it's very hard for the students to understand the respiratory physiology. At student level, it's little hard. Okay. What is that? Compliance, elasticity, like surfactant, surface tension, all these things. Okay. So from my side, I will try to do it as easy as possible. But what I need is your attention. Okay. Please be attentive. Even teachers find it difficult to understand and explain. So please be attentive. Okay. But initially, small topics only will be there. First topics are easy topics. No issue. So let me share the screen. The screen is being shared. Okay, let's jump and let's fight the war. So respiratory physiology, there is this one useless scientist. He doesn't have any work. What he did is he have taken the respiratory tree. You know the respiratory tree, right? From the trachea, bronchi, bronchioles, like all this stuff. What he did is he have divided the respiratory tract into small segments. Okay, he is very poor in English. That scientist is poor in English. What he did is he called each segment as a generation. He named them as generations. Okay, so according to the scientist, how many generations are there? There are 23 generations, 23 anatomically different areas. These are anatomically different. So we will airway generations. How many generations are there? 23, starting from 0. So trachea is generation number 0. Okay, trachea is generation number 0, and the alveoli are generation number 23. In these 23 generations, the first 16 generations, okay, the first 16 generations are a part of conducting zone. The first 16 generations are the part of conducting zone, where there is no gases exchange. Here in this area, gases are coming, but there is no gases exchange. Gases will not exchange here. So there is no gases exchange. So that's why this area is called as dead space. Okay. How much volume? If you take the volume,
of this area, it is 150 ml. So dead space volume, how much? So that area volume is 150 ml, that area. And what is the last part of the conducting zone? The last part of the conducting zone is terminal bronchioles. So terminal bronchioles are the last part. Done. Next, the from the 17 to 23. From 17 to 23, what do you have? Respiratory zone. Here gases exchange will occur. Here gases exchange will occur. Now, what are the parts of respiratory zone? In the respiratory zone, see, respiratory bronchioles, alveolar ducts, alveolar sacs are present. All these three structures. These three structures, respiratory bronchioles, alveolar ducts, alveolar sacs. Yes, gases exchange will happen in all these areas. Okay. All these three structures together called as one sinus. It's a functional unit. Okay, sinus, which includes respiratory bronchioles, alveolar ducts, and alveolar sacs. That's it. Okay. First slide completed. Now, next. See, I'm talking about the terminal bronchiole. What is something important about the terminal bronchiole? Where we have discussed terminal bronchiole is the last part of conducting zone. Last part of conducting zone. Terminal bronchiole. So it have maximum airway smooth muscles. Okay. Remember, arterioles have maximum smooth muscles. Arterioles have maximum smooth muscles. In the same way, here terminal bronchioles in the respiratory system, they have maximum smooth muscles. So these terminal bronchioles can undergo dilation or constriction, bronchodilation or bronchoconstriction. So these terminal bronchioles, they regulate the airway resistance because they have maximum airway smooth muscles. Okay, they can undergo bronchodilation or they can undergo bronchoconstriction. It's a sympathetic nervous system. See, the sympathetic nervous system acts on beta-2 receptors on the smooth muscles. There are beta-2 sympathetic receptors. When you stimulate this beta-2 sympathetic receptors, there will be bronchoconstriction. The bronchus will be constricted. There will be bronchoconstriction. Sympathetic nervous system causes sorry. Oh my god. Wait. The sympathetic nervous system is going to cause bronchodilation, sir. Sorry, that's wrong from my side. Sympathetic nervous system is going to cause bronchodilation. When you are sympathetically active, when you are fear, or when you have to fight, you have to get more air. So sympathetic nervous system will cause bronchodilation. Sorry. Mistake. Okay. And parasympathetic nervous system. It will act on its receptor. Here, parasympathetic receptors are also there. What is the parasympathetic receptor? M3. Okay, M3 muscarinic receptors. When you stimulate this M3 muscarinic receptors, that will cause bronchoconstriction. Okay, histamine can also cause bronchoconstriction. Histamine, in yesterday's class, I have discussed histamine. Secondary messenger. Which secondary messenger? Histamine on H1 receptors. Here, H1 receptors are also present. Histamine can cause bronchoconstriction. Histamine uses IP3. Secondary messenger. In yesterday's class, I have discussed. Okay. So, simple thing. The point is, here there are sympathetic receptors. See, this is a sympathetic receptor. This is a parasympathetic receptor. This is the histamine receptor. Okay. Stimulation of histamine receptor and parasympathetic receptors will cause bronchoconstriction. Stimulation of sympathetic receptors will cause bronchodilation. Stimulation of parasympathetic receptor will cause bronchoconstriction. That's it. Okay, that's it. Enough. Now after this table is there, which is not important. Who will cause bronchoconstriction? You already know it. Just now we have discussed who causes bronchoconstriction. Who causes bronchoconstriction? Just now we have discussed parasympathetic neurotransmitter, acetylcholine, histamine. Okay, but important MCQ is the most potent bronchoconstrictors are leukotrienes. Okay, the most potent, powerful bronchoconstrictors. Most students will think histamine is the powerful bronchoconstrictor. No. Yes, of course, histamine will cause bronchoconstriction, but leukotrienes are most potent bronchoconstrictors. Okay, leukotrienes like LTD4, not B4, LTD4 is the most potent bronchoconstrictor. And thromboxane, serotonin, platelet activating factors, all of the following are bronchoconstrictors. True statement. All of the following are bronchoconstrictors. True. If you have to remember one thing, for exam, leukotrienes, most potent bronchoconstrictor. Only one, this thing is enough. Then who causes bronchodilation? It's the sympathetic neurotransmitters. Sympathetic neurotransmitters like epinephrine, norepinephrine. Okay, sympathetic stimulation because of epinephrine or norepinephrine, or substances like nitric oxide, prostaglandins, prostacyclins. They all causes bronchodilation. Enough. And drugs like beta 2 receptor stimulants, beta 2 like salbutamol, albuterol, those things. Okay. So nitric oxide, prostaglandins, prostacyclins, epinephrine, norepinephrine, they cause bronchodilation. That. Okay. I believe it was already given in your book. I don't know whether you have to fill them or I don't know. But if you haven't, if you don't have these things, you please fill them. Okay. Next. So let's begin our topic with the conducting zone. Okay, let's begin with the conducting zone. Conducting zone means first 16 generations. Don't forget. First 16 generations. Now, in the conducting zone, what is the lining epithelium? There will be lining epithelium, no? There should be some lining. Okay. So, the lining epithelium is a pseudo-stratified ciliated columnar epithelium, MCQ. The lining epithelium in the respiratory tract is a pseudo-stratified. Okay, it's not really stratified. It's a pseudo-stratified ciliated columnar epithelium. Okay. Now, what is the function of cilia? Now, what is the function of cilia is, cilia will clear the sputum. Okay, cilia, every day in our respiratory tract, mucus is going to be produced. Okay, in our respiratory tract, who is going to be produced? Mucus is going to be produced, and you need to clear that mucus, right? You have to clear that mucus. So, to clear that mucus, what do you require? You require cilia. You need to have what? Cilia. Okay, let me show cilia here. So, like 6 cilia will be there. The cilia will clear the mucus. For example, imagine you are living in the Delhi. Okay, you are living in Delhi. So much pollution is there these days. So much pollution is there. Okay. Now, every day you are inhaling lot of that particles. Okay, you are inhaling lot of solute particles. So you need to clear those particles. You need to clear the mucus. Who is going to clear that mucus? Every day, every second, it's the cilia. Cilia will clear the mucus, clear the sputum. Okay. Sputum is nothing but the mucus with the dust particles, right? Dust particles and cells. Now, the same cilia, I'm little deviating from the topic. The same cilia, it helps in organ movement. Okay, when you are an embryo, your heart is more towards the right. Your heart is more towards the right side. And the cilia, you know, our gut will rotate. Our gut will rotate with the help of cilia. Okay, the cilia is helping in the movement of the organs when you are an embryo. Now, why I am discussing this here, you will understand. You will understand. In our conducting zone, there are some stem cells. Okay, there are some stem cells called as basal cell and Clara cell. These are the stem cells. Okay. Now, let's discuss about cilia-related disorders. The first cilia-related disorder is Cartaginer syndrome. Cartaginer syndrome. Second cilia-related disorder is cystic fibrosis. Cystic fibrosis is autosomal recessive disorder. This was a recently asked question. Autosomal recessive disorder. Okay, that was a recently asked NEET PG question. Okay. Now, what are the ciliary disorders? Sir, Cartaginer syndrome, also called as primary, right? Primary ciliary dyskinesia. It's a primary ciliary dyskinesia. Cartaginer syndrome. Now, what is this Cartaginer syndrome, sir? Let me explain you. Guys, in your MBBS or class 11th and 12th, you have seen, if you do the cross section of cilia, there will be a central, doublets, and like this. In the periphery also, 9+2 configuration, something will be there, like this. Okay. So when you do the cross section of the cilia, the structure is going to be like this. Here are the microtubules. These are the microtubules. Peripherally, these are the microtubules present. Okay. These are the microtubules. Now, there is a special structure called as the Dynein arms. There are structures called as Dynein arms, which connects these microtubules. Those Dynein arms are very much important for the bending of the cilia. These Dynein arms, whichever I'm showing you here, they are very much important for the bending of the cilia. So those Dynein arms are gone. Those Dynein arms are mutated. So that's it. Here I have written defect in the Dynein arms. Cartaginer syndrome low. In Cartaginer syndrome, what is the problem? It's a defect in the Dynein arms. Okay, so look, it's Cartaginer syndrome. In this syndrome, there is a defect in the Dynein arms. Okay, so because of the defect in the dynein arms, the cilia, not only cilia and flagella, okay, they cannot move properly because cilia and flagella, for their movement, what they require? They require dynein. Cilia and flagella moves because of the dynein. In this syndrome, there is a defect in dynein arms. So the patient is going to have which symptoms? If the cilia is not moving, you tell me, the mucus is going to accumulate inside the respiratory tract. That mucus accumulation can lead to the infections. So the patient is going to have recurrent sinusitis. The patient is going to have the mucus accumulation inside the sinus, our sinus, paranasal sinus. The mucus accumulation in the paranasal sinus can lead to infection and leading to sinusitis. Okay, the patient is going to have sinusitis, one thing. And the mucus accumulation in our respiratory tract, bronchi, bronchioles, will lead to bronchiectasis. Okay, will lead to bronchiectasis. Okay, infection and inflammation of the bronchi leading to the necrosis of the bronchi is called as bronchiectasis. Infection in the sinuses can lead to sinusitis. And not only that, I have said you, cilia are very much important for the organ movement, for the movement of the organs. For the movement of the organs, what do you require? Cilia. When the cilia is not working, organs will not move. So the heart, which was supposed to be on the left side, it will stay in the right side itself. Heart is going to be placed more towards the right side. Okay, so the patient is going to have situs inversus. So that is example of situs inversus is dextrocardia. Means heart placement is more towards the right side. The apex of the heart is facing the right side. That because the cilia is not working, the heart is not moving to the left side. Okay, so these three are the triad symptoms. Infertility is not there in the triad. Forget about it. Infertility is not there. So what are the triad symptoms, right? Sinusitis, bronchiectasis, and situs inversus. These are the three important triad symptoms. Of course, these patients can also have male infertility, but that's not there in the triad. Male infertility because dynein arms are not there. Okay, dynein arms are not there. So if dynein arms are not there, why the patient is having infertility? Can anyone tell me? Can you tell me why there is male infertility? Can you tell me why there is male infertility, guys? What? Jyoti Sharma. I don't know. Jyoti Sharma, is it male or female? I don't know. But what you are saying? Sperm needs cilia. Sperms are going to look like this or what? I believe sperm is like this. You are saying sperms have cilia. Does sperms look like this? What kind of sperm is it? Is it an alien sperm or what? Sperms have flagella. Even flagella require dynein. Okay, flagella is not functioning, not the cilia. Okay, so why there is infertility is because the sperm, what it requires? The sperm requires the flagella movement. Okay, sperm have flagella. Not the cilia. Okay, so that's why the patient can have infertility. So now tell me Carter-Jenner syndrome. Carter-Jenner syndrome. Defect in the dynein arms. Defect in the dynein arms. The cilia are not beating, and as well as the flagella are not beating. The patient can have sinusitis, sinus infections, because mucus is accumulating in the sinuses also, leading to inflammation. That is sinusitis. And mucus accumulation inside the respiratory tract can lead to bronchiectasis. And situs inversus can be there, and as well as male infertility can be seen. Okay, done. The next ciliary disorder I want you to know is cystic fibrosis. Okay, come to the cystic fibrosis. I have said cystic fibrosis is autosomal recessive disorder. Now, what is the problem with the cystic fibrosis? Look here carefully. Normally, this is your respiratory tract. Let me keep it as simple as possible. This is your respiratory tract. Okay. Here are your epithelial cells. These are your epithelial cells. Okay, let's say black color. These are your epithelial cells. I'm showing only on one side. These are your epithelial cells. Okay, let me draw on the other side also. These are your epithelial cells. Pseudo-stratified ciliated columnar epithelial cells. So what do they have? They have the cilia, but I'm not showing here. They do have the cilia. Okay, cilia are there. Cilia are there. Okay. Now, look. See, normally there is a channel called as a CFTR channel. Okay, there is a channel which is called as CFTR channel. Okay, there is a gene first, and there is a gene. This gene is called as CFTR. That gene is responsible for this protein, which is called as the CFTR chloride channel. This is a chloride channel. Okay, this channel is CFTR. Cystic fibrosis transmembrane regulator channel. It's a chloride channel. What it will do always? It will always send chloride out. What it will do? It will send the chloride out. Out into where? Out into where? Out into the mucus. Here is the mucus. Every day mucus is going to be there. Here into the mucus. It's sending the chloride into the mucus. Okay. Now, in cystic fibrosis, what happens? Now, what is the problem with the cystic fibrosis? The problem with the cystic fibrosis is the CFTR gene is mutated. Gone. When the CFTR gene is mutated, okay, when the CFTR gene is mutated, do you think chloride is going out? No, the chloride is not going out. Okay, the chloride is not going out. When the chloride is not going out, so chloride concentration increases inside the cell. Simple. The chloride is not going out, chloride concentration increases inside the cell. In order to balance this chloride, okay, in order to balance this chloride, now the sodium will be reabsorbed back. Okay, from the mucus, the sodium is brought into the cell. In order to balance the negativity, with the help of sodium potassium ADPases, sodium is brought into the cell. Okay, and wherever sodium goes, water also follows. Wherever sodium goes, who follows? Water also follows. So the water is being taken from the mucus. This is exactly what happens. So sodium is coming into the cell. First sodium is coming into the cell, and sodium comes automatically with the sodium. Water also comes into the cell. Now when the water is coming into the cell, what happens to the mucus thickness? You tell me. So the outside mucus, what is happening to the mucus which is there outside? It's becoming more and more concentrated. The mucus is getting more and more concentrated. Okay, because the mucus is getting thick, concentrated, because you are removing the water out of it. So now tell me, such thick mucus, thick secretions, can your cilia, can those cilia clear these thick secretions? Now your cilia cannot beat. So your cilia are now cannot clean this mucus because the mucus is thick. So it's not the cilia problem. It's not the cilia problem. The main problem is thick secretion. Secretion is going to be thick. Not only in the respiratory tract, also in the GIT. Also in the GIT, the secretions are going to be thick. In the pancreas, the pancreatic secretions are going to be thick. That will lead to pancreatitis. So many problems. So basically, the patient here is having thick secretions due to CFTR gene mutation, the chloride channel mutation. Okay. So it's not the cilia problem. That is the reason why I said, Carter-Jenner syndrome is primarily the cilia problem, primary ciliary dyskinesia. But cystic fibrosis is not primary ciliary dyskinesia. There is no problem with the cilia. In cystic fibrosis, the problem is with the channel, thick secretions. Okay, so let's write one by one. Cystic fibrosis, autosomal recessive, which is gene mutation, CFTR gene mutation. So defect in the chloride channels. Because of the defect in the chloride channels, there are thick secretions. Okay, there are thick secretions which makes the cilia immobile. So the mucociliary clearing mechanism, the mucociliary, like the mucus should be cleaned by the cilia. That function is called as mucociliary excalatory function. Means it's just like an escalator. You know the escalator, right? How it moves. In the same way, the cilia also clears the mucus. That function is going to be lost here. Okay, so cystic fibrosis people will have what? Bronchiectasis. True. Bronchiectasis. Even these people will have bronchiectasis, respiratory tract infections. So how to treat this? By using a drug called as ivacaftor. The treatment of cystic fibrosis is ivacaftor. If you give this ivacaftor, again this chloride channel will function. Ivacaftor will make the chloride channels function again. Look, this is a normal person. There is no mucus accumulation. But in the CFTR channel mutation, see the thick mucus. Mucus is thick. See here, the mucus, thick mucus accumulation. So that will lead to respiratory tract infections and bronchiectasis. Okay. So what is the drug that is used for cystic fibrosis? Ivacaftor. Little bit integration. Cystic fibrosis patients have which GI problem? The CFTR, cystic fibrosis patients will have pancreatitis. The most common GI problem is pancreatitis. Baby with a cystic fibrosis, baby, newly born baby, newborn baby, newborn will have what? Which problem? Failure to pass. Yesterday's class I have said, you see, in this patient they are having thick secretions, so their feces is also the first feces, the meconium is also going to be very thick, it won't come out. So failure to pass what? Meconium. Failure to pass meconium. Cystic fibrosis baby, if you kiss this cystic fibrosis baby, if you kiss the baby is going to be taste salt. So these baby cystic fibrosis babies are called as salty babies. Usually 10 years back, if the patient is having cystic fibrosis, they will die by 10 years. Okay, within 10 years they will die. But these days, cystic fibrosis patient, after the invention of ivacaftor and lumacaftor, the life expectancy has increased almost to 50-55 years. Okay, ivacaftor is a wonderful drug. Ivacaftor, it makes the CFTR channels function again. Ivacaftor and lumacaftor, ivacaftor and lumacaftor. Okay, these are the points which I wanted to know regarding cystic fibrosis. Is that clear, guys? Yeah, salty babies. These babies are salty babies. If the mother kisses the baby, mother will feel like, my baby is tasting salty. Okay, something like that. Okay, why? We will study it in medicine, not in the physiology, definitely not in the physiology. These babies are called as salty babies. Okay. Next. Now, after the conducting zone, let's start with the respiratory zone. Now, respiratory zone. In the respiratory zone, what is the lining epithelium? In conducting zone, the lining epithelium is pseudostratified ciliated columnar epithelium. Pseudostratified ciliated columnar in conducting zone. Now I talk about the respiratory zone. In respiratory zone, the lining epithelium is simple squamous epithelium. For example, say if this is alveolus, in the alveolus, what kind of epithelium is going to be there? Very thin, simple squamous epithelium, very thin lining. Why, sir? For decoration purpose or what? No, for gases exchange ke liye. See, the oxygen which is present over here, it have to easily diffuse. It have to diffuse into the blood vessel. Okay, so that's why there is a very thin lining. So simple squamous epithelium for the exchange of gases. And these cells, okay, these cells which I am showing you here, these cells are called as the pneumocytes. And how many types of pneumocytes are there? There are two types of pneumocytes. Okay, there are two types of pneumocytes. For example, let me draw here one pneumocyte, little different. Okay, so there are two types of pneumocytes. This is type 1 pneumocyte. This thing is the type 2 pneumocyte. There are two types of pneumocytes. One is type 1 and type 2. Type 2 pneumocytes, two important points are, type 2 pneumocytes produce something called as surfactant. Type 2 pneumocytes, what it will produce? Surfactant. A substance called as surfactant, FMG question. And type 2 pneumocytes are also stem cells. Okay. Where we have discussed about the stem cells just previously. Basal cell and Clara cell, don't forget. Sir, basal cell and Clara cell are the stem cells in conducting zone. They are the stem cells in the conducting zone. And in respiratory zone, who are the stem cells? Who are the stem cells? It's the type 2 pneumocytes. Okay, it's the type 2 pneumocytes. Okay. Whenever there is any damage to type 1 cells, these type 2 cells, they will divide and replace type 1 cells. Okay. If type 1 cells are having any damage, type 2 cells will divide and replace them. Okay. Now, guys, I'm going to enter into the concept. Okay, now I'm starting to enter into the concept, sir. Surfactant. What is this surfactant? Now look. First of all, what is this surfactant? And what is surface tension? If you understand this, the respiratory physiology is going to be very easy. For the next 3-4 concepts, the next 3-4 topics is going to be very easy. Okay. Kya hai surface tension? Kya hai, sir? Look, imagine this is your alveolus. One alveolus. Alveolus is like this, right? Now in your alveolus, which cells are there? See, these are the pneumocytes. Okay, I'm not drawing the pneumocyte, just leave it. Your alveolus, it is lined by thin film of water. what do you have on the pneumocytes? You are having light water lining. Okay, because oxygen will be dissolved later, diffusion happens. Thin lining of water will be there. Yeah, thin water lining will be there. Okay, they are not dry. Your alveolus are not dry. Thin water film is there. Water is there. This is water. Okay. Now, what you are breathing air? You are breathing air, right? Air is also coming. So, who are meeting with each other? Who are meeting with each other? Air and water are meeting with each other. So, in your class 11th and 12th physics, wherever water and air molecules, wherever they meet, okay, wherever they meet, there develops in the junction. For example, look, array, imagine this is a glass. Okay, glass. Now you keep water in the glass. Okay, you keep water in the glass. Simple like this. Okay, and what is there in the top? Here there is air. Air is there. Now in this junction point, wherever the air and water are meeting in this junction point, there develops a collapsing force. There develops a destructive force. It's called as surface tension. ఎక్కడైతే air and water meet అవుతాయో, wherever air and water meet, okay, wherever the air and wherever the water molecules, wherever they come and meet in that junction point, there develops a collapsing force or destructive force called as surface tension. So even in our lungs, who is there? Surface tension. In our lungs, surface tension is there. Okay, in our lungs, surface tension is there. What it will do? It will try to collapse our alveoli that lead to atelectasis. It will try to collapse our alveoli. But my alveoli, are they collapsing? My alveoli, are they collapsing? I'm asking you. No, my alveoli are not collapsing. Why my alveoli are not collapsing? I will tell you the reason. See, let's come to this example. Same example. Now here air and water are there in the beaker. Look, here air is there, water is there. Now I'm asking you, you have to put something. You put something so that air and water molecules should not meet. Array, you just keep something. Okay, you just add something so that air and water molecules, they should not meet. So what is that thing that you will add? If you add something, it will come and float here so that air and water molecules, they will not meet. What is that? What you add? Tell me. మీరు ఏమి యాడ్ చేస్తారు? What you are going to add? Can you tell me? Exactly oil. Exactly oil. Oil. Okay, oil. If you add oil into it, oil will float. Lipids. Okay, oil will float so that air and water, they will not come and meet. They will not meet. So there is no surface tension. Yes, exactly. Surfactant works like that. So in our lungs also, the same oil is there. Who is that oil? See, surfactant is coming and floating here. Who is that oil here in our lungs? That is our surfactant. So surfactant, what it will do? It will neutralize the surface tension. Aha, okay. So you need to understand surfactant, right? It decreases. Surfactant decreases what? Surface tension. Surfactant decreases surface tension. And can you tell me what is surfactant? The surfactant molecule, is it a carbohydrate, protein, or fat? Is it a carbohydrate, protein, or fat, or like what is it? Is it a lipid or not? Yes, it is lipid because it is floating on the water. Yes, yes. So now look here. Surfactant, what is it? It is lipoprotein. Mainly it is lipid. 90%. See here, 90% it is lipid. Okay, but let's go one by one. First, let's go one by one. Okay, surfactants are okay. When it is produced, it is produced by type 2 pneumocytes. Okay, it is produced by type 2 pneumocytes, you know it. When it is produced, 28 to 32 weeks of period of gestation, you can see this in amniotic fluid. Actually, it is produced by almost 20 weeks. It is produced. Okay, by 20 weeks it is produced, but you can see it in the amniotic fluid by 28 to 32 weeks of period of gestation. You can see it in the amniotic fluid. Okay, see it in the amniotic fluid. By 22 to 32 weeks of period of gestation, you can appreciate the surfactant in the amniotic fluid. Okay, and where is this a surfactant stored? The surfactant, it is stored. For example, say this is a type 2 pneumocyte. You know it, type 2 pneumocyte. It produces the surfactant. And these surfactant molecules, they are stored in the vesicles. These vesicles are called as lamellar bodies. Okay, surfactant is stored in lamellar bodies. Done. And what is surfactant? I have said you surfactant is mainly lipid. 90% it is lipid. 10% it is protein. Okay, 10% is protein, 90% is lipid. Don't write each and everything, not needed. Right? Surfactant is mainly a lipid, 90% lipid. 10% it is protein. Then what is the lipid type? What is the lipid? Phospholipid. What is the major lipid? What is the major lipid in the surfactant? What is the major lipid? The major surfactant lipid is, see, dipalmitoyl phosphatidylcholine. It's a phospholipid. Dipalmitoyl phosphatidylcholine, also called as lecithin, is the most important lipid in the surfactant. It's the most important lipid in the surfactant. Okay, simple. DPPC, dipalmitoyl phosphatidylcholine, is the major lipid, major phospholipid. Major phospholipid. The word is important. Major phospholipid in the surfactant. Okay. And one more major lipid is phosphatidylglycerol. Okay. Other major lipid is phosphatidylglycerol. These two are the major lipids. Dipalmityl phosphatidylcholine as well as phosphatidylglycerol. And proteins, regarding proteins, this is not that important. No need to remember. Two major lipids. Two major lipids are dipalmityl phosphatidylcholine as well as phosphatidylglycerol. Now, please add here. There is a minor lipid. There is also something called as a minor lipid. The minor lipid is called as sphingomyelin. Okay, sphingomyelin. Sphingomyelin, it's a minor lipid. It's a minor lipid. Okay. So, sphingomyelin is a minor lipid. Dipalmityl phosphatidylcholine is a major lipid. Sphingomyelin is a minor lipid. Okay, done. Functions of the surfactant, you already know it. What are the functions of the surfactant? Surfactant, it decreases the surface tension. It decreases the surface tension, true. Surface tension is what kind of force? It's a collapsing force. It collapses the lungs. Okay. Now, other functions, these functions are bullshit, not needed. Just throw it out. Next important MCQ, especially from obstetrics. How can we know whether the fetal lungs are matured or not? What does it mean by fetal lung maturity? Look, if surfactant is produced, if it is produced, it means fetal lungs are matured. Okay, fetal lungs are matured. If surfactant is there, fetal lungs are matured. If surfactant is not there, fetal lungs are not matured. So how can we know that fetal lungs are matured or not? Now, how we are going to do it is, look at guys. Now, look at me. A baby is in the uterus. Imagine there is a baby. Look at me. Imagine there is a baby. Baby is where? Baby is in the uterus. Now, what this baby is going to do is, baby is going to take the amniotic fluid. He is going to take the amniotic fluid. The amniotic fluid will go into the fetal lungs. The amniotic fluid will go into the fetal lungs and the amniotic fluid will come out. The amniotic fluid will go into the fetal lungs. The amniotic fluid will come out. Which means surfactant will also come out into the amniotic fluid. Okay, surfactant is also coming into the amniotic fluid, right? So now what you have to do is first collect the amniotic fluid. So to assess the fetal lung maturity, what you have to do? Collect amniotic fluid by amniocentesis. By doing the amniocentesis, collect the amniotic fluid. Okay, via the injection. Now check for lecithin and sphingomyelin. If you see lecithin and sphingomyelin are present, if the ratio of lecithin and sphingomyelin is 2, question, then the fetal lungs are matured. This is the question. Lecithin to sphingomyelin ratio, if it is greater than 2, it indicates that fetal lungs are matured. Okay. Now, one thing completed. Second thing, look, I'm asking you, take a small box or some small thing. Okay, small box or some small jar. Put water into it. Okay, and close the lid. You close the lid and just shake it. Normal water. I'm talking about normal water. Do you think any bubbles are going to form? If you shake the water bottle or something, yes, of course, bubbles will form. They will disappear within a fraction of seconds. The bubbles will disappear. Okay, they will pop out. But you put some oil into it. Look, put some oil into it. Add some oil into it, and now you shake it. Now bubbles will form. Which means wherever there is oil, there bubbles will form. In the same way, apply the same concept. Now collect the amniotic fluid. Okay, collect the amniotic fluid. Okay, put it in a small container. Okay, I'm keeping the amniotic fluid here. Okay, put it in the small container. See, amniotic fluid have what? Amniotic fluid. If the fetal lungs are matured, amniotic fluid will also have surfactant, because amniotic fluid goes into the fetal lungs and surfactant will also come into the amniotic fluid. Now you shake it, bubbles will form. If there is surfactant, if there is this oil, if there is surfactant is oil, right? Bubbles will form. So this is called as shake test or bubble test or Clement test. If bubbles are forming, it indicates fetal lungs are matured. If bubbles are forming, fetal lungs are matured. If no bubbles, no surfactant. No bubbles means no surfactant. Bubbles means surfactant is present. That's it. So this is a second test. What else you can do? So 2 tests completed. What else you can do is collect the amniotic fluid again. Okay, look at here. Collect the amniotic fluid, and in the amniotic fluid, what will be there? You will be having type 2 pneumocytes. In the amniotic fluid, type 2 pneumocytes will be there, because amniotic fluid goes into the fetal lungs. It comes out of the fetal lungs. When it is coming out, even some type 2 pneumocytes, the type 2 pneumocytes will also come. Okay, so in this type 2 pneumocytes, what you can see is this lamellar bodies. Okay, in the lamellar bodies, what you will see? Surfactant. So if you can see these lamellar bodies, if you find good number of lamellar bodies in the amniotic fluid, if you see good amount of lamellar bodies, it means fetal lungs are matured. Okay, so that is called as the lamellar body count. Okay, lamellar body count. Yes, it is used in the assessment of fetal lung maturity. But the best test for fetal lung maturity is, out of all the best tests, is if you find this one substance that is called as a phosphatidylglycerol. We have discussed, it is also one of the major lipids. See, phosphatidylglycerol here. Phosphatidylglycerol, one of the major surfactant lipid. If you see this thing in the amniotic fluid, it is only there in the amniotic fluid. If you find it, yes, fetal lungs are 100% mature. So these are all the different types of tests to assess the fetal lung maturity. Now you can ask me, sir, why you have explained these things one by one, little detail? Because questions has been asked. All of the following are the tests for fetal lung maturity except. Okay, so listen, sphingomyelin ratio, shake test or bubble test, lamellar body count, and the presence of phosphatidylglycerol in the amniotic fluid is the best test. It's the best test. So done. Clear? Next, what else you should know regarding the surfactant? See, who stimulates the surfactant production? Who stimulates? It's the steroids. So surfactant production in the fetus is stimulated by steroids, mainly glucocorticoids. It's a steroid, glucocorticoid. That's a cortisol, it's a steroid. So steroids, let me write here. Steroids will stimulate the production of, steroids from the mother will go into the baby. Steroids from the mother will go into the baby and stimulate the production of surfactant. True. Thyroid hormones will increase the production of surfactants. True. At least for your exam, no, you know these two things. Enough. So steroids and thyroid hormone. Enough. These two things, enough. And who inhibits the surfactant production? Who inhibits the surfactant production? Insulin. Insulin inhibits the surfactant production. Okay. So, for example, say, let me tell you a scenario. So imagine, for example, this female. Okay, this female, she's a pregnant. Okay, she's pregnant. There is a baby here. Now, unfortunately, she developed gestational diabetes mellitus. Okay, gestational diabetes mellitus. So what happens to her insulin levels in the body? Gestational diabetes insulin, like mellitus, insulin levels are going to be more. Okay, insulin resistance is seen. Insulin levels are going to be more. Now, she is having more insulin in her body. What this insulin will do? Insulin inhibits the surfactant production. So this baby is not going to have surfactant. Means baby's lungs are not matured. Baby lungs not matured. Okay, baby's lungs are not matured. So once this baby is delivered, the baby is having problem with what? the baby में surfactant नहीं है, so the baby's lungs are collapsed. So that will cause neonatal respiratory distress syndrome, NRDS. Now the baby's lungs are collapsed, so there will be breathing difficulty. The baby is having difficulty for the breathing because the lungs are collapsed, because there is no surfactant. Surfactant nahi hai, so surface tension will be more. The lungs are collapsed, so the baby is going to have RDS, neonatal respiratory distress syndrome, also called as hyaline membrane disease. Okay, hyaline membrane disease or neonatal respiratory distress syndrome is due to deficiency of what? Deficiency of surfactant. Why surfactant is less? In this condition, the mother is having diabetes mellitus, gestational diabetes mellitus, and she is having insulin resistance. Her insulin levels are more. Insulin inhibits the surfactant production. So that's it. Okay, that's it. Okay, so that's why here I have clearly given. See, here I have clearly given hyaline membrane disease, also called as respiratory distress syndrome. What is the major cause? Why it is there? Due to deficiency of surfactant. In which people the surfactant deficiency will be seen? Which baby surfactant deficiency will be seen? It is seen in gestational diabetes mellitus. If the mother is having gestational diabetes mellitus, the baby is going to suffer with respiratory distress syndrome. And same, this respiratory distress syndrome is also seen in premature infants. Prematurity, the baby is delivered by 31 weeks. So surfactant production is not enough. So same thing. Okay. So these are the points which I want you to know. So hyaline membrane called as neonatal respiratory distress syndrome seen in premature infants and gestational diabetes mellitus, because there is surfactant deficiency. Surfactant deficiency. Okay. So far is that clear? So lamellar bodies, we are looking for the lamellar bodies in the amniotic fluid. We are looking for the lamellar bodies in the amniotic fluid. Okay, in the amniotic fluid, lamellar bodies can be seen. Okay, they can also be seen in the type 2 pneumocytes. So any doubt, sir? So far, if you, do you have any doubt? So in which babies are going to suffer with the respiratory distress syndrome? The babies who were delivered prematurely. Premature infants don't have surfactant, and if the mother is having gestational diabetes mellitus, then also those babies will have respiratory distress syndrome. Yes, of course, Rekha, you are true. CS delivered. If a baby is delivered by cesarean section, some babies who were delivered by cesarean section can also have respiratory distress syndrome. Okay, cesarean section people also. Jyoti Sharma, you are asking why cesarean section, why cesarean section can lead to respiratory distress syndrome is, let me tell you. If you're asking, if you want, you know it. You just tell me one thing. Okay, you just tell me one thing. See, there is a baby. Okay, when you are delivering the baby have to go through the birth canal. The baby have to go through the birth canal. Means, a baby have to go through such a narrow birth canal, through the bony canal. See, delivery will take a lot of time. Okay, delivery is not a small 1 hour thing. Delivery will take 8 hours, 9 hours thing. Delivery is a long process. Okay. First stage of labor, second stage of labor, third stage of labor. For all these things, it will take a lot of time. So baby is under a lot of stress. Okay, baby is under a lot of stress. Now, when the baby is under a lot of stress, what is produced in the baby? Steroids. Steroids are produced in the baby. Cortisol, stress hormone. Cortisol is produced in the baby. The steroids, what I said you, just now I have explained you. Steroids stimulate the surfactant. So, normal delivery is good. In normal delivered babies, normal vaginal delivered babies, there is more surfactant because babies are under stress. Surfactant is more. But cesarean section, it's like simple. Cesarean section babies are like red carpet babies. They don't want to do anything. They are simply sleeping. The doctor is going to be under stress. Not the baby. Doctor is under stress and mother is under stress. Okay, now you understood. If a baby is delivered by normal vaginal delivery, baby is under stress because the baby have to pass through that birth canal. The baby have to do lot of twists and bends.
The baby is getting hypoxic. So stress is there. So steroids will produce more surfactant in the lungs. Now you understood? Vamsi, Jyoti, you understood why now? Yeah, that's the reason. Okay. So if you want to remember this, that's a NEET PG question. So this hyaline membrane disease or respiratory distress syndrome, it is seen in premature infants through gestational diabetes mellitus mothers and those babies who are delivered by C-section. Okay. And now this preterm labor, this thing is not needed. Just leave it. Next, we are going to start with the mechanics of breathing. Okay. Second conceptual topic after surfactant. Now we have started with the mechanics of breathing. Now in this mechanics of breathing, I want you to know how air enters into the lungs and how air exits out of the lung. Why the air is going in and why the air is going out. How the air is going in and how the air is going out. Please be attentive. Please be attentive. So breathing, how many phases are there? There is inspiration, there is expiration. Inspiration is active process, expiration is passive process. Okay, sir. Inspiration active, expiration passive. Simple, okay. Inspiration, look, inspiration. For inspiration, which nerve is required? For inspiration, see, first let me tell you like this. For inspiration, you need to have contraction of diaphragm. The diaphragm need to be contracted. So that's why active process. ATP is getting utilized, muscle contraction. So which nerve is helping in the contraction of diaphragm? Phrenic nerve. So diaphragm is contracting with the help of phrenic nerve. What is the root value of phrenic nerve? The root value of phrenic nerve is C3 to C5. Some students will have a confusion. Okay, let me tell you. Guys, look. This is your cervical part of the spinal cord, not the cervix. This is the cervical part of the spinal cord. This is just wait. These are the spinal nerves. This is C3, C4 spinal nerve. This is C5 spinal nerve. These spinal nerves are coming, right? This C3, C4, C5. These three nerves, they will fuse and form which nerve? Phrenic nerve. They will fuse and form phrenic nerve. Where this phrenic nerve will go? The phrenic nerve will directly go and innervate diaphragm. So now the diaphragm will be contracted. Okay, diaphragm is contracted with the help of phrenic nerve. What is the root value of phrenic nerve? C3, C4, C5. Okay, done. Okay, done. Okay. Now, apart from diaphragm, what other muscles can help in inspiration? What other muscles can help in inspiration? External intercostals, scalene muscles, and sternocleidomastoid. External intercostal, scalene muscles, and sternocleidomastoid. These are all muscles helping in inspiration. Don't confuse. Student will confuse. External intercostal, external for expiration. No, external intercostals for inspiration. External intercostals muscles, external intercostal muscles in between your ribs. External intercostal muscles, scalene muscles, and the sternocleidomastoid muscles, they are all helping in the inspiration. Okay, sir, done. Expiration is passive process. No need of any muscles. No need of any muscles. Okay, no need of any muscles. That's it. Here I have to keep a full stop. It's missing. But what is the exception? For forceful expiration, you require muscles. Which muscles? These two. Transverse abdominis, rectus abdominis. This is the question. If you want to do forceful expiration, what do you need to do? Transverse abdominis muscle is required and rectus abdominis muscle is required. This rectus abdominis, the six-pack muscle. Okay, six-pack muscle. Okay, that is required. This is a question which was asked. Which muscle is helping in the forceful expiration? Rectus abdominis. Done. Okay, sir. So I have said you some basic thing, basic ABCD. Basic ABCD. Now, after this, what you should know? What else you should know is the placement of the lungs. Okay, the placement of the lungs. Let me show you. Just give me a minute. There is respiratory. Okay, look at these two slides. I want you to copy. Let me paste it here. Yeah. So you please look at here. How the lungs are situated. How the lungs are situated. Carefully look. What is this muscle that I am showing here? This is your diaphragm. This is your diaphragm. Okay. So your lungs are sitting on the diaphragm. Okay, this is the one thing. On the downside, your lungs are sitting on what? Diaphragm. On the sides and anteriorly, see, anteriorly and even in the sides, your lungs are surrounded by what? Your lungs are surrounded by ribs. Okay, these are the ribs, right? This is the cross section of the ribs. Okay, so your lungs anteriorly, posteriorly, and even sides, they are completely surrounded by the rib cage. Okay, they are completely surrounded by what? Rib cage. Oh my God, what happened? That image is gone. Just let me take that image again. Copy. Paste. Okay, so the same thing, let me show it in a different view. Let me show the same thing in a different view. Sir, on the bottom, what I'm showing you, this is the diaphragm. Okay, on the bottom, I'm showing you the diaphragm. Okay, so these are your lungs. These are your lungs, both the lungs. Okay, now your lungs, carefully look at your lungs. So your lungs are surrounded by the pleura. Okay, so this pleura, which I'm showing you, which I'm highlighting right now, for example, see this pleura. So there is, the lungs are surrounded by pleura, yes or not? Yes, this is the pleura which I'm drawing, highlighting right now here. So this pleura is called as which pleura? Sir, this is called as visceral pleura. Okay, the pleura which is just attaching to the lungs, which is attaching very near to the lungs. This pleura is called as which pleura? Visceral pleura. Okay, sir. Visceral pleura is attached to the lungs. Visceral pleura. Now, the other pleura which I am showing you here, the outside, there is one more pleura. See this pleura which I am highlighting right now. See this pleura which I am highlighting. I hope you should see this. This is called as which pleura? Parietal pleura. Outside. Parietal means outside. This is called as parietal pleura. Okay. So now look here carefully. Parietal pleura is attached with what? Down. Parietal pleura is attached with the diaphragm. True. And the same parietal pleura is also attached with the rib cage. Parietal pleura is attached with the rib cage. True. Okay. So is this important? Absolutely important. For understanding the concept, this is important. Now, what is the space between these parietal pleura and visceral pleura? What is the space? There is a space, right? There is a space between visceral pleura and parietal pleura. What is the space? This is called as a pleural space, intrapleural space. And in the intrapleural space, who is there? Fluid is there, intrapleural fluid is there, and there is a pressure, sir. Okay, see here in the intrapleural space, there is a fluid and there is pressure, that is called as intrapleural pressure. How much is that intrapleural pressure? Minus 2.5 mm Hg, minus 2.5 mm Hg. One by one, I will teach you. Okay, just first understand the orientation, how the lungs are there. Two lungs are there. They are sitting on the diaphragm. Okay, they are sitting on the diaphragm. Parietal pleura is attaching with the diaphragm. Parietal pleura is attaching with the diaphragm. And parietal pleura anteriorly, posteriorly, and even sides. Parietal pleura is attached with the rib cage. It is attached with the rib cage. What is the space between parietal pleura and visceral pleura? The space between the visceral pleura and parietal pleura is called as intrapleural space. And what is the pressure in the intrapleural space? Minus 2.5 mm Hg. Minus pressure means, what is what minus pressure? Minus pressure means vacuum. Negative pressure means vacuum. There is vacuum around the lungs. True, there is vacuum around the lungs. Okay, there is vacuum around the lungs. Okay, sir. Okay, now what else you should know? Same whatever I have taught you so far. Let me show you the same thing here. Here I am representing the lung, entire lung in the form of an alveoli. Imagine this is your lung. Entire lung, I am showing you one alveoli. Okay. Your lungs are surrounded by what? Pleura. This is the pleura. Okay. Now, what is the pressure in the pleura? What is the pressure in the intrapleural space? The intrapleural pressure is minus 2.5 mm Hg. Minus 2.5 mm Hg. Okay. Now, what is the pressure in the atmosphere? You tell me. And pressure in the atmosphere is considered as 0. That is 760 mm Hg. Normal atmospheric pressure is 760 mm Hg. Let's consider it as 0. Okay. You are having nostrils, right? You are having nose and nostrils. They are open. So the same pressure is communicating. Same pressure is communicating even into your alveolus.
So intra-alveolar pressure, see PALV, alveolar pressure is also 0. So outside 0, here also 0.
Now tell me, will air moves into the lungs or not? Outside 0, inside your alveolus also pressure is 0. Intrapleural pressure is minus 2.5. Now will air enters into your alveolus or not? You just think and tell me. Outside 0, inside 0. So will air enters into your alveoli? Do you think air will enter into your alveoli? No. Air is not going to enter. Air is not going to enter. No, because there is no pressure difference. Outside 0, inside 0. So air cannot enter because there is no pressure difference. There is no gradient. Okay, there is no pressure gradient. So air is not going to enter. Okay, so keep that point in mind. Okay, air is not entering. So let's see one by one. At rest. When you are at rest means you are not inspiring, you are not expiring. You are not doing inspiration, you are not doing expiration. Okay. What is atmospheric pressure? 0. What is the intraalveolar pressure? 0. Both are 0. Okay. And what is the intrapleural pressure? Intrapleural pressure is always negative. Okay. It's always negative. Always negative. Okay. It's always negative, minus 2.5. Now there is one more pressure which is called as a transpulmonary pressure. What is this transpulmonary pressure, sir? Transpulmonary pressure is the difference between these two. Intraalveolar pressure and intrapleural pressure. The difference between intraalveolar and intrapleural pressure is called as transpulmonary pressure. Look, what is the TPP, transpulmonary pressure? Alveolar pressure minus intrapleural pressure. Alveolar pressure is how much? 0. 0 minus, what is the intrapleural pressure? Minus 2.5. 0 minus of minus 2.5. 0 minus of minus will become plus. Okay. The transpulmonary pressure value is plus 2.5. Plus 2.5. That's it. Know the value. That's enough. Know the value. Our transpulmonary pressure value is plus 2.5. Intrapleural pressure is minus 2.5. Intraalveolar pressure is 0. Environment pressure is 0. Done. Done. Okay, done. Now, write the most important formula. It's called as the Boyle's law. Boyle's law. What is Boyle's law? Boyle's law states as pressure is inversely proportional to volume. Okay, pressure is inversely proportional to volume. I should say, let me put it in a little way. Volume is inversely proportional to pressure. Okay, you can also say something like this. Both are true, but this will be better. Volume and pressure, these two parameters, volume and pressure, are inversely proportional. Which means when volume increases, pressure decreases. When volume increases, when the volume increases, pressure will go down. This is Boyle's law. Why this is important, I will tell you. Within a minute, everything is done. Now it's just all your imagination. Now you have to imagine everything. Imagine. Okay. Now, how air enters into the lung? Inspiration. Okay. How air enters into the lung? Now, guys, look at me once. Sir, now my phrenic nerve is firing. My diaphragm is contracting. Look, my diaphragm is contracting. And my chest wall is expanding during inspiration. Chest wall expands, diaphragm contracts. Now you tell me, sir, diaphragm is attached with which pleura? Parietal pleura. Normally, see, here is the visceral pleura. Here is the parietal pleura. Or let's put it this way. Here is the visceral pleura. Here is the parietal pleura. Now, when the diaphragm is contracting, the parietal pleura will move away from visceral pleura. The parietal pleura is moving away from visceral pleura. Am I right or not? Even here also, when the chest is expanding, parietal pleura will move away from visceral pleura. Am I right or not? Parietal pleura anedi జరిగిపోతుంది. The parietal pleura is moving away from the visceral pleura. Now tell me, guys, look here. What is the first event? Chest wall expands. Okay. Diaphragm contracts. Okay. So what happens? Sir, the intrapleural space is increasing because the parietal pleura is moving away. As the parietal pleura is moving away from the visceral pleura, what happened to the intrapleural volume? The volume is increasing because the gap is forming. You know the Boyle's law, when volume increases, what happened to the pressure?
The pressure is decreasing. The pressure is decreasing. Initially, it is minus 2.5. Initially, how much you have? Minus 2.5. Okay, initially, how much you have? Minus 2.5. As the volume increase, okay, the pressure is decreasing from minus 2.5. The pressure is even decreasing. It becomes minus 6 mmHg. Means intrapleural pressure becomes more negative. From minus 2.5, it have moved to minus 6. Means what you have generated? More vacuum. More vacuum. You have generated more vacuum around the lungs. You have generated what? More vacuum around the lungs. Have you ever done this experiment? I'm asking you, just wait. Have you ever done this experiment? When I was a small kid, my mom used to give me milk. Okay, I used to drink all the milk, and after drinking that milk or water, I used to take that glass tumbler. I used to take that glass tumbler to my mouth, something like this. I used to suck out all the air. I used to suck the air out of the glass. So I'm generating the vacuum in that glass. Do you know what that vacuum will do? That vacuum will suck your lips. That vacuum, it will suck your lips into the glass. Have you ever done that? Okay, the glass is going to stay over there, and that vacuum is going to suck your lips. Yes, right? Yes, right? Now, what you have done, vacuum. See, vacuum is going to suck the things. It's going to expand the things. Now, what you have done, sir, here you have generated more vacuum. Because of that vacuum, what the vacuum is doing? Vacuum is going to pull the alveolus or expand the alveolus. So because of that vacuum, the alveolus is expanding. Okay, now, what happened to the alveolar size? Alveolus is increasing. See, now the alveolus is expanding. When the alveolus is expanding, you know the stuff. See, when alveolar volume increases, what happened to the pressure? Intraalveolar pressure decreases. When volume increases, pressure decreases. Previously, here the pressure is 0. Previously. But now what happens? The pressure is decreasing. As the volume increases, pressure becomes -1. Outside it is 0. Now you have decreased the pressure over here. Now there is a gradient. Outside is more. Inside is less. So automatically air is coming into the lungs. Air comes into the lungs. So this is how air enters into the lungs. Okay. So I have explained you how inspiration occurs. The only question that will come in your exam, only question that will come in your exam is, during inspiration, okay, what happened to intrapleural pressure? During inspiration, the intrapleural pressure becomes -6, more negative. During inspiration, the intrapleural pressure becomes -6. During inspiration, what happened to intraalveolar pressure? Intraalveolar pressure is -1. So air automatically from outside, air automatically enters into the lung. Air enters into the lung. Now, first tell me, is that clear? Now you understood how air enters into the lung? Why the air from outside is coming into the lung? Okay. Now, let me see how many of you can really answer this. Okay. Question is, at the end of what first time? What's that device? First time? Okay, you have used the boil stuff for the first time. First time, understand. Okay. Now, look. Write this question. Question is, at the end of inspiration, what happens to? Okay, at the end of inspiration, what happens to intraalveolar pressure? At the end of inspiration, end. The word is end. End is important. Listen carefully and answer this. Means inspiration completed. Inspiration ho gaya. At the end of inspiration, what happened to the intraalveolar pressure? What do you think? Inspiration completed means now air have from outside, air have entered into the lungs. So outside and inside again it should be equal. So how much it will become? It will again become 0. It will again become 0 because now new air is entering. No, new air is entering. As the new air have entered from outside, again from -1 it will become 0. Excellent. Okay.
So that's the answer which was tested in the exams. So at the end of inspiration, not during inspiration it is -1, during inspiration it is -1, but at the end of inspiration it becomes 0 again because a new air came. So outside and inside again it is equilibrated, it becomes equal, so it is 0 again. Okay, it's 0 again. So inspiration ho gaya. If you understand inspiration, expiration is very easy. 1 minute topic expiration. So during expiration everything reverses, everything is reversing. Chest wall is collapsing, diaphragm is relaxing, going back to its original position, going back to their original position. So parietal pleura is coming back to its original position. So what happens, sir, when the parietal pleura, look at me, once look at me, sir, once look at me. Now the parietal pleura is again coming back to its original position. Parietal pleura, this is a parietal pleura, it is coming back to its original position. So what happened to the intrapleural volume or intrapleural space? Decreasing, right? See, it is decreasing. Okay, from -6 again it is becoming, from -6 again it is becoming -2.5 again. Simple. So that's why look here, from -6 it is becoming again normal, -2.5, -2.5. So intrapleural space or intrapleural volume decreases. When volume is decreasing, pressure, see, pressure is increasing, -2.5. So from -6 it is becoming -2.5. This is more, right? Okay, so from -6 it is becoming -2.5. -2.5 is more. Okay, less negative means that's a more value, higher value. Okay, so now there is less vacuum around the lungs. Now here vacuum decreased, now there is less vacuum decreased. When the vacuum is decreased, that suction force decreased, so alveoli is collapsing. Okay, alveoli is collapsing. When the alveoli is collapsing means alveoli is becoming smaller. Okay, alveoli chota ho gaya, now alveoli are becoming smaller. See, now alveoli collapse, which means alveolar volume decreases. When volume decreases, pressure increases. So from 0 it is increasing to 1. 0 it is increasing to 1. Outside is 0. Here you are creating 1. So your high pressure, your low pressure. So automatically air will go out. Automatically air is going out. So air exits out of the alveoli. The question which will come in your exam is, what happens to intrapleural pressure during expiration? During expiration, intrapleural pressure again becomes -2.5. Okay, during expiration it comes to -2.5. What about the intraalveolar pressure? It becomes +1. It becomes +1. Now, can anyone tell me at the end of expiration, what happens to intraalveolar pressure? During expiration it is +1, but air is going out. As that extra air have gone out, what happened to the intraalveolar pressure at the end of expiration? What happened to the intraalveolar pressure? It again becomes 0. Equilibration. Outside 0, inside also it will become 0. So ends are always 0. Starting and end are always 0. Always 0. That's it. So inspiration ho gaya, expiration ho gaya. The main topic which I want to teach is done, sir. Now only MCQs are left. The main topic, the core concept which I want to teach you is done. So let me ask you some questions. Buddies. Okay, I know it's little difficult, little tricky, little confusing, but try to answer. Okay, first, at rest. What is the intrapleural pressure at rest? What is the intrapleural pressure? Means I'm not inspiring, I'm not expiring. What is the intrapleural pressure? -2.5. What is the transpulmonary pressure at rest? Transpulmonary pressure. A transpulmonary pressure is the difference between intraalveolar pressure and intrapleural pressure. Transpulmonary pressure is +2.5. The difference. Transpulmonary pressure. How many marks from respiratory physiology? 2. I will tell you what questions were asked in the recent exam. I will tell you 2. Okay, if your time bad, only 1 will come. Okay, but respiratory physiology is highly integrated with medicine. If you see in that way, it will get you at least 4 or 5 marks if you are integrating with the medicine. Okay, but pure physiology is 2. Next question, sir. During inspiration, inspiration, what happened to intra-alveolar pressure? Intra-alveolar pressure, once think, outside is 0. During inspiration means intra-alveolar pressure. Intra-alveolar pressure, it becomes -1. Intra-alveolar pressure becomes -1. During expiration, +1. During expiration, +1. Simple. Simple. Okay. So now let me add things here. You just check whether they are true or not. You just check whether they are true or not. Okay. See, atmospheric pressure during expiration. These are all about expiration. Atmospheric pressure is 0. Okay, true. Intra-alveolar pressure becomes +1. You know it. And intrapleural pressure come back to -2.5. It come back to -2.5. You already know it. You already know it. I have said you. I'm talking about the intra-alveolar pressure. See, during rest it is 0. End, always at the ends it is 0. During inspiration it is -1. During expiration it is +1. These things have tested. Okay, end is always 0. End is always 0. Okay. Now, students, whenever they look such diagrams, they'll be terrified. Okay, they'll be terrified. Now, simple. Draw a line between these two. Okay, in your book also, draw a dotted line here. I'm dividing the breathing into 2 parts. Inspiration, expiration. See, here I am talking about the inspiration. Here I am talking about the expiration. Inspiration and expiration. Okay. Now, in the beginning of the inspiration, look, in the beginning of the inspiration, what is the intra-alveolar pressure? On this axis, I am talking about the intra-alveolar pressure. See, in the beginning, it is 0. Okay. And during inspiration, intra-alveolar pressure is becoming, okay, -1. See, it is becoming -1. And at the end of inspiration, see, at the end of inspiration, again, it's becoming 0. Again, it's becoming 0. And during expiration, from 0, it is going to +1. See, here it is +1. And it is coming back to 0 again. At the end, it is coming back to 0 again. That's it. Same. Simple. Simple. Okay. Here, this is a small mistake. It should be -1 here. It's -1. Okay. Done. Okay. So, this is what they are showing. From 0, it will go to -1. It will come to 0 again. From there, it will go to +1 and again 0 again. Okay. Done. And intrapleural pressures. You know about the intra-alveolar pressures? See, intrapleural pressures there is no 0. Intrapleural pressures, they do not have something like 0. It is only fluctuating between 2 values. At the beginning of normal inspiration, it is -2.5. And at the end of inspiration, it is again 6. Okay, it is fluctuating between -2.5. It will go to 6. And again, it will come back to again -2.5. There is no value of 0. 0 anedi ledu. There is no such thing as 0. Okay, so intra-alveolar pressure during inspiration -2.5. Sorry, during rest it is -2.5. At the end of inspiration it becomes 6, and during expiration it becomes again -2.5. Okay, so done, sir. Done. That's it. Enough. These tables are not needed. These are like, for first year students. Just leave it. Okay. So one big topic completed, sir. One major topic. Okay, like a little mind-boggling topic completed. Now let's take a 1-minute break. After that, I will explain you about the concepts of compliance and elastance. Okay. Very interesting topic. I love this topic. Okay. In the entire physiology, I love this topic. When I was a student, I was fond of this topic. I like this topic very much. So just take a 2-minute break. Okay. 1-2-minute break. Like, I will complete this topic, like compliance and elastance. I will complete this one topic and I will leave you. Okay. I will complete this topic. Yeah, mistake in the book, sir. Yes, mistake in the book. Oh, excellent. You guys are excellent. Okay, there is a mistake in the book. I have corrected. No, I have corrected. No, Vishnu Yadav, yeah, I have corrected. So take a break of just 1 minute, 1-2 minutes. During expiration means it's coming back to -2.5 again. During expiration, it is again coming back to -2.5. From -6, it's coming back to -2.5. Okay. There is no such thing as 0. 2.5, 6, again 2.5. Take a break of 1 minute. Chalo, break completed. Now, the concepts of compliance and elastance. Now, for you to understand this, let me take a rubber band. Let me take a rubber band. Just give me 1 second. Let me bring a rubber band so that it will be better for you to understand. Okay, guys, look at me. So, are you able to see this rubber band? This rubber band. Okay, are you able to look at this rubber band? Let me open the chat box. So, this is the rubber band, right? You are able to look at this rubber band, right? Now, you tell me, sir, I'm trying to stretch this rubber band, right? What is this property called as? Compliance or elastance? I'm trying to stretch it. Okay, I'm trying to see it stretching. What is this property called as? Is it called as compliance or elastance? What is this property? Come on, you know it. Tell me. People are saying elastance, and compliance. What is this property? Is it called as compliance or elastance? It's a compliance, no doubt. Those who are saying elastance, that is a blunder. It's not elastance. It is not elastance. It is called a compliance. Compliance means stretchability. Compliance ante itla sagadam. Okay, now compliance means stretchability. Now, when I leave it, it is coming back to its original position. See, when I leave it, it is coming back to its original position. So this is called as elastance. Elastance means coming back to its original position. Elastic recoil. So compliance means stretchability. Elastance means coming back to its original position or maintaining the original shape. Resisting deformation. Yes, compliance is the ability to stretch. For example, look. See, there is this thing. For example, here there is this thing. Now I'm trying to stretch it. I'm trying to stretch it. Is it stretching? No. So it is less compliant. This is less compliant. Okay, this is less compliant. I'm trying to stretch it. It is not stretching. Maybe if I use a machine, a big machine, powerful machine, maybe it will stretch. But its compliance is, we have to say, its compliance is less. It is less compliant, but highly elastic. This is highly elastic. This substance is highly elastic. Okay, because it is resisting the shape change. It is maintaining the position. It is maintaining the shape. So according to the physiology, this is highly elastic. This is less compliant. Our rubber bands, okay, these are highly compliant, and also coming back to its original position. This is also elastic. It is compliant as well as elastic. Okay. Now that's the first thing which I want you to know. Look, so compliance means it's the stretchability or distension capacity. Compliance means how easily you can stretch a substance. Okay, rubber band, you can very easily stretch it. Or if we are talking about some like bottle, it is very hard to stretch. So compliance means how easily you can stretch it. What is the formula of compliance? The formula of compliance is delta V by delta P. Some students will scratch their head. Hey, sir, what is this delta V by delta P? I can't understand. Delta V by delta P. And delta V means how much volume is changed. Change in the volume for change in the pressure. How much volume change for the change in the pressure. That will tell you the compliance of the substance. Okay, look at me, guys. Now, for example, this substance, I want to know the compliance of this particular substance. So, for a given pressure, I'm giving little pressure, more volume change. Okay. For a given pressure, more volume is changing. So I will say this is highly compliant. The compliance of this particular rubber band is more. For a given pressure, more change in volume. Okay, I'm changing little pressure. More volume is changing. So this is highly compliant. Now, about this, I'm giving so much pressure. But there is less volume change. So this is less compliant. So that's the formula of compliance. Okay. Manam enta pressure icham, that is how much pressure we have given, and enta volume change ayindi, how much volume have changed. So that is called as the compliance. Okay. And remember, compliance means stretchability. Elastance means maintaining the shape, going back to its original position. So both are inversely proportional, both are opposite. Okay. Compliance and elastance are opposite to each other. Okay. Remember that. And what is the normal? Our lungs are also compliant. Okay, our lungs, they are also stretching. So what is the normal compliance of the lung? If you give this much pressure, 1 centimeter of water pressure, 1 centimeter of water pressure, how much volume will be changing in the lungs? How much lungs will expand? 200 ml. If you give this much 1 centimeter of water pressure, my lungs will expand by 200 ml. 200 ml volume change will occur. That is the normal compliance of the lung. Simple. 1 centimeter of water pressure if you give, same 200 ml is also called as 0.2 liters. 0.2 liters. So same thing. Again, for understanding purpose, again same. Compliance means its stretchability or expansibility or distensibility, how easily you can stretch a substance. Now, the next important point is compliance is opposite to what? Surface tension. Because surface tension is what? Collapsing force. One is collapsing force. Surface tension is the collapsing force. But compliance is about stretching. Okay, stretchability. So both are opposite. So you can write compliance is opposite to elastance. So true, compliance is also inversely proportional to surface tension. This is the super high yielding thing in the entire topic. This is the super high yielding thing. So whenever, means how the questions are going to come, whenever surface tension increases, if surface tension increases, what happens to compliance? Compliance decreases. Whenever any condition where surface tension increases, what happens to the compliance? Compliance decreases because they're opposite to each other. One is a collapsing force, other is the expanding force. Okay, expanding force. Okay, so compliance is opposite to elasticity. You already know it. Okay, now look at let me give you one question, sir. Let me give you one question. Your lungs always want to collapse. Lungs, right? No need to write. At least listen. Lungs always want to collapse. Always want to collapse. Why? Because of two forces. In your lungs, there are two forces which always wants the lung to collapse. Okay, which always wants the lungs to collapse. There are two forces. What are those two forces? In your lungs, there is surface tension. I have told you. Surface tension wants the lung to collapse. Surface tension wants the lung to collapse. This is the force number one. And your lungs are made up of elastin. That elastin fibers and collagen fibers, they will undergo elastic recoil. They want the lung to collapse. So there is also elastic recoil. Okay, that elastic recoil because of what? Elastin and collagen. Okay, so these are the two collapsing forces. Look at here. In your lungs, what is responsible for their collapse? Collapse or recoil? Why? Why always your lungs want to collapse? Why always your lungs want to recoil? Why? Because of surface tension. Okay, the number one is because of the surface tension. Okay, you know, surface tension is because of air, water interference, air fluid interference. Second thing is because of elasticity. In your lungs, there is elasticity. That elasticity is because of what? Elastin and collagen. I have explained you. Okay, I have explained you. So your lungs always want to collapse. Okay, because of two forces. There is surface tension in your lung and there is elasticity because of elastin and collagen. Okay, let me write here. It's because of elasticity. Better word is elasticity. Okay, elasticity is because of elastin fibers as well as collagen fibers. So your lungs always want to collapse. Okay, now you understand, your lungs always want to collapse. But are they collapsing? No, they are not collapsing. But they're always wanting to collapse. They're always willing to collapse. Okay, now my question to you. Imagine there is a dead person. Okay, there is a dead person. A person is dead. Now you have taken out his lungs. You have taken out his lungs. Okay, you have totally filled his lungs with saline. You have totally filled his lungs with what? You have totally filled the lungs with saline. That's a saline filled lungs, right? These are the saline filled lungs. Saline filled lungs. Now, in a saline filled lungs, what happened to the compliance? Will compliance increases or decreases? That's the question. If you fill the lungs with saline, what happened to the compliance? What do you think? If you totally fill the lungs with saline, what happened to the compliance? Will the compliance increases or will the compliance decreases? What do you think? Someone are saying increase, decrease. Saline filled lungs. Lungs ni saline to fill cheste. If you fill the lungs with saline, that lungs will become more stretchable or less stretchable? That lungs will become more easily stretchable or less stretchable? Compliance increases. The compliance increases, sir. Look, what happens to compliance of the saline filled lungs? Compliance, PLINS. Okay. What happened to the compliance of the saline filled lungs? Alright, guys, look here. Now you have totally filled the lungs with what? Water. There is total saline. Now tell me, is there any air-water interference? Now I'm asking you here in the lung, is there any air-water interference? No. No air-water interference. अरे air water interference नहीं है तो, if air and water interference, air fluid interference नहीं है तो, there is no surface tension. Okay, surface tension decreases. Surface tension nahi hai. The surface tension is not there. Okay, surface tension is a collapsing force. Surface tension is a recoil force. Now recoil force is not there. Collapsing is not there. Now it is easy for you to stretch the lung. Very easily you can stretch the lung. Now the lungs will stretch more. For the given pressure, lungs will stretch more. So compliance increases. Okay, go one by one. See, look here. If you fill the lungs with saline, you have removed air-water interference. Now it is just water everywhere. Now it's water. Therefore, there is no surface tension. So less recoil, less elasticity. So compliance increases. Okay. Now I have told you, surface tension is inversely proportional to compliance. If you decrease the surface tension, compliance increases. Okay. Now you understand? If you understand this, I will give you one more problem. If you say, yes, sir, we understand, I will give you one more problem. Otherwise, I will stop. I will stop means I will try to explain. Is that okay? Clear? Next, I'm asking you. Okay, at least try to answer this. Sir, during inspiration, what I'm doing, see? During inspiration. Now what I'm doing? During expiration. During inspiration and expiration, am I having the same lungs or different lungs? First tell me that thing. First get a clarity. During inspiration, during expiration, am I having same lungs or some new lungs are coming into my body? Harish, you are saying different. New lungs are coming or what into my body? It's the same lungs. It's the same lungs during inspiration and expiration. Okay. First thing is, yeah, we are having same lungs. Now, question number 2. When do you think lungs will be more compliant? During inspiration, there are lungs, and during expiration, same lungs are there. When do you think my lungs will be more compliant, more easily stretchable? During inspiration, lungs are more compliant, or during expiration, lungs are more compliant? What do you think? First question. When do you think lungs are more compliant? When do you think lungs are more compliant? Inspiration or expiration? People are saying inspiration, expiration. OYC is saying during expiration. The answer is expiration. During expiration, lungs are more compliant. Okay, during expiration, lungs are more compliant. Okay, it's a little tricky, but look here. So now, first let's see during inspiration. Alright, guys, look. Inspiration. Okay. Usually student, what they will think, sir, during inspiration lungs are expanding. No, lungs are expanding. No, so they are more compliant. No. You are not supposed to think like that. Compliance means how easily we can stretch, not just stretching. How easily we can stretch.
Okay, so during inspiration K time, what happens? Look, so this is the alveolus, right? In the alveolus, what is this protector molecule? Our guardian angel, our protector is there. Who is this? This is surfactant is there. Okay, surfactant is protecting us. Now during inspiration, what happens? Lungs are expanding. Okay, lungs are expanding. When the lungs are expanding, now tell me what happened to the surfactant molecules. So the surfactant molecules are moving away from each other. Okay, the surfactant molecules, look here, देखो, the surfactant molecules are moving away from each other. So what happened to concentration? The surfactant concentration decreases. Surfactant is going down because the surfactant molecules are moving away from each other. Okay, so surfactant is going down. And when surfactant decreases, what happened to surface tension? What happened to surface tension? The surface tension increases. Okay, surface tension is a collapsing force. So during inspiration, yes, true, surface tension actually increase. So when surface tension increases, now tell me what happened to compliance? Array, collapsing force is more, recoiling force is more. What happened to compliance? Compliance decrease. So compliance decreases. Compliance decreases. This is true. Actually, during inspiration ke time mein, compliance is less. Your lung compliance is less, which means you have to use more energy. That's why inspiration is an active process. Means you have to use more energy to stretch the lung. Of course, lungs are stretching, but you have to use more energy. It is difficult for you to stretch the lung because the compliance is less, because surface tension is more surface tension, because less surfactant. And expiration के time में exactly opposite thing. Expiration के time में look, so this is your alveolus. During expiration, alveolus is collapsing, alveolus is becoming smaller. So what happened to the surfactant? Sir, for the given volume, look, for the given volume, surfactant concentration is increasing. The surfactant molecules are coming close to each other. So here, surfactant is more. Surfactant zyada available here. Okay, more. Surfactant is more. When surfactant is more, what happened to surface tension? Surface tension is less. Surface tension will go down because they're opposite to each other. When surfactant is more, the collapsing force decreases. Surfactant decreases the surface tension. When surface tension is less collapsing force. So what about the compliance? Compliance increases. That's it. So during expiration, compliance increases. Okay. So what I want you to know is, array guys, you are having the same lungs. Don't confuse. You are having the same lungs. God gave you the same lungs, but the lung nature differs. During inspiration, the compliance is different. During expiration, the compliance is different. You understand? During inspiration and expiration, the compliance of the lung changes. During inspiration, compliance is less. During expiration, compliance is more. During expiration, you can stretch them easily. If you want to stretch them, you can stretch them more. Okay, so there is this difference. So the same thing here, I have shown it in the form of a graph. Okay, I have explained here. During inspiration, so look, during inspiration, compliance decreases. During expiration, compliance increases. Explanation I have given. You go through it once. During inspiration, expiration, I have just now explained you why compliance decreases, why increases and decreases. Now, the same thing, I have shown it here in the form of a graph. Okay, so on x-axis, first always look at the x-axis. What I'm discussing, pressure changes, -4, -5, -6. What are these? These are the intrapleural pressure changes in centimeters of water. Okay, you know, for example, for easy understanding, okay, let me keep here -2.5, -2.5. Pressure is going from -2.5 to 6. You can understand it, right? And on y-axis, I'm talking about volume change. How much volume is entering into the lungs? How much volume? Look, during inspiration, wait, just wait. Now you should tell me on x-axis, I'm talking about pressure. Pressures are changing from -2.5 to -6, which means this is the delta P pressure change. On y-axis, I'm talking about the volumes, which means this is the delta V. So tell me, delta V by delta P. This graph is about the delta V by delta P, which is going to give you about what? Compliance of the lungs. This graph is telling, this is the compliance graph. This is the compliance curves. These are the compliance curves. See, now two curves are coming. See, during inspiration, this is the compliance, less compliance. But during expiration, see, more compliance. The graph is on the top. Okay, the graph is on the top. So this is the compliance of the lung during expiration. This is the compliance of the lung during inspiration. They are not same. They are different. Compliance during inspiration and compliance during expiration, they are different. So there is a difference between these two curves. Okay, when it is more during expiration because it's on the top. Okay, done. Okay, so this difference is called as the FMG exam. This is the question. What is this difference called as? This difference is called as hysteresis. The difference between these two curves are called as hysteresis. The difference in the compliance is called as hysteresis. My dear students, you are going to tell me hysteresis is due to why there is this difference? Can anyone tell me? Why this difference is happening? Can you tell me? So what is changing during inspiration and expiration? Sir, during inspiration and expiration, in your lungs, what is changing? Sir, surfactant is changing. Surfactant concentration is changing. So surface tension is also changing. So that's the answer. This hysteresis is due to surfactant. Okay, surfactant, it changes during inspiration and expiration. This is one answer. Or you can also say surface tension. Okay, so these are changing. Surfactant concentration changes. So automatically surface tension also changes. Whenever the surface tension is changing, automatically compliance also changes. You know it. Okay, so these are the points which I want you to know. Okay, this graph is all about the compliance. Okay, this graph is all about the compliance. The difference is called as hysteresis. Okay, difference is called as hysteresis. Now I have explained you the concept completed. Now image based questions I will show you. Very simple. If you are really good, if you are a really good student, then you can answer it. Okay, but before going to show you the image based questions, first look at this. Look at this. No, not here. Look at this. Concepts of compliance and elastance. Here there is a disease, sir. Emphysema. Look, emphysema. Okay, let me take a slide and write. Emphysema. You know, smokers will get emphysema. Alpha-1 or the children with the alpha-1 antitrypsin deficiency will cause emphysema. True. Smokers and alpha-1 antitrypsin deficiency people will have emphysema. Emphysema, do you know what happens? In emphysema, what happens is the elastin fibers in the lung, elastin fibers are damaged. If you understand this, medicine is going to be easy. Emphysema condition low. In this emphysema condition, elastin fibers are damaged. Elastin fibers are damaged. Okay. When elastin fibers are damaged, you tell me what happens? Elastic recoil. Elastic recoil. What happened to elastic recoil? Decreases. Aha, okay. Elasticity is decreasing. The elastic recoil, the collapsing is decreasing. When elastic recoil decreases, what happened to the compliance? Compliance of the lungs increases. Okay. Emphysema patients' lungs are more compliant. True. So that's the same thing which I have given here. Emphysema patient lungs. See, emphysema patient lungs are more compliant. Compliant increases. Compliant increases. Okay. Next, pulmonary fibrosis. Second example is pulmonary fibrosis. Pulmonary fibrosis. Okay. In pulmonary fibrosis, what happens? In pulmonary fibrosis, look, in pulmonary fibrosis, alveoli are getting scarred. Fibrosis, the alveolus, lots and lots of collagen is getting deposited. Okay, lots and lots of collagen is getting deposited. See, lots and lots of collagen, elastin fibers are getting deposited. So lungs, now it's hard for you to stretch the lungs because lungs are scarred, lungs are fibrotic. So it is hard for the alveolus to stretch. It is hard for you to stretch the alveolus. So what happened to compliance? Compliance decreases. Pulmonary fibrosis, fibrosis, lungs are getting fibrotic. So compliance decreases. It's hard for you to stretch. So compliance decreases. In emphysema, compliance increases. Okay. Now, let me show you some graphs.
You just try to answer them. First, before showing the graphs, is it clear? Is the concept clear? Tell me. Is the concept clear? I'm trying my best to explain the concepts of compliance and elastance. Okay, is it clear? Emphysema may more compliance. Pulmonary fibrosis may less compliance. Okay, now look at this image. Okay, just wait. Even before the image, say, if I show you a graph something like this, here there is a curve A, curve B, curve C. See, the curve which is on the top will have higher compliance. Simple, remember. The curve which is on the bottom have lower compliance. Okay. Even in our curve also, here also, see, expiratory curve is on the top. So it is higher compliance. During expiration, more compliance. And during inspiration, less compliance. Okay, keep that point in mind. Now look at this. This is a normal person. For example, this blue color line, this dotted line is a normal compliance, average compliance of a normal person. Now, my patient compliance is something like this. During inspiration, his compliance is like this. Okay, during inspiration, his compliance curve is going like this. And during expiration, his compliance is coming down like this. Okay, now tell me, when compared to the normal person, he is having more compliance or less compliance? When compared to the normal person, now my patient is having more compliance or less compliance? That's the question. This curve is having more compliance or less compliance? More compliance. Okay. Can you tell me which condition? Who is this patient? Now, can you tell me who is this patient? Who is this patient, sir? That's the emphysema patient. Excellent, Rekha, excellent, Jyoti. Salva, yes, you are all true. Vishnu, Maria, yeah, Najib, you are all true. It's emphysema. The patient is having emphysema. So look, example is emphysema. The patient is having what? Increased compliance. Okay, increased compliance. Next. Okay, next. See, when compared to the normal compliance, this is the normal compliance. The dotted line is the normal compliance. When compared to the normal compliance, my patient is having compliance like this. Okay, so this is the compliance during inspiration and this is the compliance during expiration. Who is this patient? Who is this patient? First of all, compliance is decreased. So this is decreased compliant. Who is this patient? The patient is having pulmonary fibrosis. Okay, the patient is having what? Pulmonary fibrosis, right? Pulmonary fibrosis. Or even the patient, even the patients of acute respiratory distress syndrome. The lungs are collapsing, you know. Acute respiratory distress syndrome. Surfactant is not there. So lungs are collapsing. So compliance decreases. So patients of pulmonary fibrosis, respiratory distress syndrome, their compliance curves are going to be like this. Okay, they will have curves something like this. Okay, they will have curves something like this. Okay, so the answer is pulmonary fibrosis, or acute respiratory distress syndrome. At least remember these two. Okay, sir. Okay, sir. Now let me show you one more graph. Okay, let me show you one more graph. So this is the normal compliance. You know, this orange color thing is the normal compliance. Normal compliance during inspiration, during expiration. This is the normal compliance. This is the normal person, normal. When compared to the normal person, our patient, this blue color thing is the patient's compliance. Okay. So who is this patient? What is this patient suffering with? First of all, tell me, compliance increases or decreases? More compliance. The patient is having more compliance, no doubt. More compliance. Because see, the graph is going up. More compliance, no doubt. So what is this patient suffering with? Can anyone tell me? What is this patient? Who is this patient? Who is this patient, sir? Anyone? Who is that patient? The compliance is increasing. Who is that patient? The patient is having emphysema. Who is that patient? Which I am showing you here. When compared to the normal person, the patient compliance is increasing. Okay, is this emphysema patient? No, this is not emphysema patient. What you need to appreciate, Maria, you are true. What you need to appreciate here is, array, the hysteresis is gone. There is no hysteresis. Here,
That difference is not there. Hysteresis is not there. Who is this patient? Just right here. Hysteresis is not there. Hysteresis not there. The hysteresis is due to what? Tell me. Hysteresis is due to surface tension. So in this lungs, in my patient lungs, surface tension is not there. Surface tension is not there. In which lung surface tension is not there? In saline filled lungs. Okay, I have explained you already. In saline filled lungs, there is total water everywhere. There is total water. If there is total water, there is no surface tension. If there is no surface tension, there is no hysteresis. So there is very less hysteresis, or there is no hysteresis. So this is saline filled lungs. So hysteresis is not there because it's total water everywhere. Surface tension is not there. Here, look, in normal person, more surface tension during inspiration, less surface tension during expiration. We know it. But in saline filled lungs, there is no surface tension. There is no surface tension, so there is no difference. So the answer is saline filled lungs. Okay. And last question for today. You have 3 subjects. Okay, we are having 3 patients and 3 equivalent ABC compliant curves. Okay, this is a compliance curve A, B, C. 3 patients. One of the subject is normal. One subject is normal. One is normal. Second one is having emphysema, and the third one is having, or third one is using these drugs, amiodarone and bleomycin. Who is the normal? Who is having emphysema? Who is using drugs like amiodarone or bleomycin? Can you tell me? Who is normal? Who is normal? A, B, or C? Who is normal? Who is having emphysema? And who is using drugs like amiodarone, bleomycin? Can you tell me? Can you tell me? Yes, exactly. Exactly, students. A is emphysema. A is emphysema. B is normal. Okay, excellent. So, you know, A is on the top, which means highly compliant. This is emphysema. This patient is emphysema patient. B is a normal patient. And third patient is using drugs like amiodarone and bleomycin. What amiodarone and bleomycin will do? A, B, C. Amiodarone, right? Amiodarone. B for bleomycin. C for cyclophosphamide. Carmustin. And ABC, M. M for methotrexate. Methotrexate, used for rheumatoid arthritis and ectopic pregnancy. Methotrexate. So these are the drugs. ABCM, amiodarone, bleomycin. Okay, just wait. So amiodarone, bleomycin, cyclophosphamide, methotrexate. What is the side effect? Can anyone tell me what is the side effect of these drugs? ABCM drugs. Can anyone tell me what is the problem with these drugs? If you use these drugs, what happens? Pulmonary fibrosis. Pulmonary fibrosis. So that's why the patient compliance is less. Okay, that's why the patient's lung compliance is going down. So amiodarone, bleomycin, cyclophosphamide, and methotrexate, these drugs will decrease the pulmonary fibrosis. Sorry, these drugs will decrease the lung compliance because they will cause their side effect. Their side effect is pulmonary fibrosis. Okay. And with this, the concepts of compliance and elastance is done. Compliance and elastance is done, sir. Okay. Okay. So I have tried to explain as much as possible. Just read these things today itself. Read these things. Okay, today itself, now itself, you sit and try to revise. Wherever you are having doubt, watch the video again and again. So let's meet tomorrow morning exactly the 9 o'clock. Exactly at 9 o'clock. Same timings. Exactly at 9 o'clock. Okay. So if you have any suggestions, personally message me. Now let me share the respiratory also. Okay, respiratory also I will share. Okay. Yeah, I will try to upload it early, not at midnight. It's not in my hand actually. It's in the management. Like, you know, the management people,
like they might say, sir, we have to convert it, we have to do some things, we have to edit it. They will say some things, but from my side, I will like ask them to do it as soon as possible. Okay, I will try to do it as soon as possible. See you tomorrow. Bye bye, guys. Bye bye.